Good morning, everyone. Apologies for the delay of 10 minutes, and we'll immediately start off with Cow Anthem. I request the console team to start. And patient safety. We have a goal, a noble drive, hand in hand, step by step, to march together. Shine the future, faith in quality healthcare. We are CAHO, joining hands for building a vision, shaping a culture for patient safety, setting up standards with best foot forward, won't ever leave no stone unturned. We wear our pride on our sleeves, work with passion like a breeze, train their skills, spreading the message of quality healthcare for safer patient care, a better nation. We have a goal, a noble drive, hand in hand, step by step, we will fly to march ahead together. Safety and quality healthcare. We are CAHO, your healthcare companion, standing right by your side. Good morning, everyone. Very good morning to all the eminent guests, faculty, delegates, and the organizing team to the 8th edition of the Cahotech 2023. We have come a long way from the first one that was held in Hyderabad in 2016. Also, a very good morning to my co-host, Ms. Devashree Chatterjee. Let me introduce her. She's the managing partner of Om Synergist Healthcare and Hospitality Consultants located in Mumbai.
Thank you, Dr. Suvin, and a very, very good morning to you as well. My co-host, my fellow co-host for today, who happens to be, apart from a well-known figure, also the laboratory director at LH Nandani Hospital, Mumbai. And this brings us to the opening of Cahotech 2023 sessions, which has the tagline, or it is themed as technology to make healthcare accessible, efficient, and affordable. So welcome once again, all of you, to Cahotech 2023.
Again, my apologies. As I apologized in the beginning, we are delayed by a few minutes, and we'll directly go on to our sessions. Moving ahead with the inaugural session, we would like to introduce and welcome onto the stage Dr. Harsh Mahajan, sir. I'll be introducing, you can please take a seat. Dr. Harsh Mahajan, sir, is the organizing chairman of Cahotech 2023. Please give a warm welcome to him. He is an eminent radiologist who is the founder and managing director of Margin Imaging, New Delhi. He set up India's first MRI center in 1991, which would qualify as a startup in today's parlance. Dr. Mahajan sir received the Padma Shri in 2002. He was the National President of Indian Radiology and Imaging Association in 2012. He is the consultant to the International Atomic Energy Agency at Vienna, advisor to UPSC, and is also on the government committee for Make in India for MRI.
Next, it is my privilege and I'm happy to welcome on stage President, Consortium of Accredited Healthcare Organizations, CAHO, Dr. Vijay Agarwal, sir. A big round of applause to him. And as we know, he's a very qualified pediatrician, strategist, and administrator who has played a very key role in introducing the National Pulse Polio Program and centralized waste management scheme in Delhi. He has held various positions such as the co-chair of NABH Accreditation Committee, as Director Operations and Administration Max Healthcare, as Executive Director of Pushpanjali Crossley Hospital. Apart from such others, he is also the recipient of the Distinguished Alumnus Award of Maulana Azad Medical College, Lifetime Achievement Award from IMA, and the Quimpro Platinum Standard Award in 2019.
Next, welcoming and requesting the presence on the stage of the President of Association of Healthcare Providers in India, AHPI, the ever-charming Dr. Alexander Thomas. Welcome, sir. He is the founder, member, and president of Association of National Board Accredited Institutions, ANBI, that is called, and also the founder, president, 2012 to 2017, as well as the patron of COW. He led the expert group on medical education for the National Education Policy, headed by Dr. Kasturi Rangan. Dr. Thomas was awarded the Emeritus Teacher Award by NBE for his distinguished achievements and contributions to the field of medical education. Welcome, sir.
Next, welcoming on stage the ever-charming, smiling, vivacious, vibrant, and the heartbeat of CAHO, Dr. Lalu Joseph, our Secretary General. And she's going by qualification, she's the quality manager at CMC Vellore. A mechanical engineer by profession, she's gone on to complete her doctorate in business administration and a diploma in CQI from the Canadian Healthcare Administration. And also, the best outgoing student of VIT Business School in 2000. She was the recipient of the Young Quality Achiever Award of 2016 of CAHO and Dr. M.S. Ashraf Award, IMA of TN State in 2018. Welcome you, Dr. Lalu.
We request the eminent dignitaries to give their opening remarks on the event. We can start with the lady first. No, we'll call.
Thank you very much. Good morning and welcome to this full day, I think, of vibrancy, passion, which is going to come through as you will see. This is part of Cahotech, which has been actually held in three parts. We had the Hospital Innovation Summit, which was held online on the 30th of September. Yesterday we had the Startup Pitch Fest, which kept us, riveted to our seats morning till the evening, and 23 startups presented and showed the quality of what the work that is being done by these youngsters. And today we are going to have all of you participate in how technology is actually changing the healthcare scenario in this country. So I won't stand between you and the others. We are already running late. Welcome again, and hope to have a great day of learning. Thank you.
Good morning to all of you. It's always a pleasure to be here at CAHO. And whenever I come here, I always think of the early days. The early days in Hyderabad, in Bangalore, where we had to go after people and get them to join Cahotech. So amazing and so great to see people now flocking towards Cahotech, and it's a landmark event. All I want to say is that, as was said yesterday, technology has come to stay. We need to leverage it to make healthcare affordable, accessible, and improve the quality. And I think CAHO is only one of the very few organizations in the country which is getting these people together. So, and while doing that, I think we should not also forget the human touch. So once again, congratulations to all of you for organizing this, and all the best, and God bless.
So, good morning, ladies and gentlemen, and I think it's a proud privilege for both Lalu and me, we are our partners in crime, to declare this conference open. So let's proceed with the proceedings. So thank you very much.
We will request all the dignitaries to remain seated. Yeah. Because we have a very eminent personality will be joining you on stage for the keynote address.
And joining us would be Mr. Karan Singh. I would request the presence of Mr. Karan Singh on the stage, please. Big round of applause to him. Mr. Karan Singh is the chairman of Bain & Company's India's offices, and he leads the APAC Sustainability and the Responsibility practice. He is an MBA from Wharton School of Business at the University of Pennsylvania, and has advised and been knowledge partner to Nat Health, Healthcare Federation of India, and Kailash Satyarthi's Children's Foundation, and also been a member of committees of leading business chambers such as FICCI and CII. Also, Mr. Karan is on the board of advisors for ALVL Foundation and Bridgespan. Welcome you, Mr. Karan.
It's a proud privilege, sir, to have you on board for the keynote address. I'll request you to deliver your keynote address on navigating the digital frontier, sir. Thank you, sir.
I don't know if you want to sit here or you sit back there, whatever works for you. But Dr. Mahajan, thank you for inviting me. It's an absolute pleasure to be here, especially bright and early on a Saturday morning. So looking forward to, I'm sure, a very vibrant session. What I'll talk a little bit about is a couple of key messages that I'll spend the next 15, 20 minutes going through. First is, I think the outlook is extremely bright for health tech, and we will see accelerating growth and explosive growth going forward. So now I'll explain a little bit about some of the enablers of why I say that. The second, I think in terms of priorities, I think there are three major priorities. The first priority is real scalability of tech, which is being used, but we need to take it to a completely different level to be institutionalized. So scalability is a significant challenge as we see companies that are truly innovating, but how do you take it to the next level to be a way of life? The second priority really is, when you think about, is the need for experimentation. And I'll talk a little bit about all the different technologies and the use cases, but that has to be thought through in conjunction with how do you create an attractive and a compelling business model, and then how do you think about creating that platform as well. So I think experimentation to me is a very important one, but thinking about it quite holistically is pretty critical. And the third, but not and most important also, is the enablers, and I think policy, the platforms of the digital stack that we are seeing in India, but also how the government plays a really key enabling role, when it comes to ecosystem creation. I think is going to become even more important going forward. But this has to lead to a more sustainable and a better health system in this country. I think we have the opportunity to lead and leapfrog. So everything that we are talking about in health tech has to be with that end in mind, saying how do we create a system that really delivers affordable quality and accessible care for the entire population. We've seen enough health systems that are struggling, and I think we are at the chapter 1 or chapter 2. So how do we use this to really create a much more sustainable health system? Let me first start at the more macro level. This is a report we published earlier this year in conjunction with Google, and we looked at what is the outlook for the entire digital economy in India. And currently we are saying this is about 150 odd billion, and we think this has the potential to get to about $1 trillion of the digital economy in India. That is about a 6-fold increase from where we are today. We would estimate we are about 4 to 5% penetration of digital economy in this country. That can get to 12 to 13% in the next 7 to 8 years. And Som, as you look at it, the share and the importance of when it comes to IT. IT is such a critical backbone of this country, but digital economy probably is going to be an even larger portion, and where the IT sector will continue to grow in this market. So this is extremely significant, extremely disruptive in terms of some of the potential in this market. It is quite fascinating to see when one compares how we are consuming digital in this country. And some of the data is quite mind-boggling. If you look at the time we are spending on the internet, if you look at the social media consumption, and if you look at the online video hours, just a sense of this young population is adopting and using digital quite disruptively. And we are not lagging, whether it comes to developed markets or when it comes to even China, which is clearly at the forefront of a lot of the innovation. So we have the ingredients to really consume and to adopt digital. How do we then use this to think about transformation of the health system? If I go a little bit deeper in terms of what's driving this $1 trillion of digital economy in the next 5-7 years, we've broken this in, and I apologize, it's a little bit of an eye chart, but we've broken this into the different segments or the different opportunities. The top part of the chart is the consumption-based sectors, and what stands out here is the health tech opportunity. And the health tech opportunity, we think, will grow from about 1 to 2 billion to about 20 to 25 billion. That's a 12 to 15x. And that is probably the highest growth that we'll see amongst all the other sectors. The other one really will be, what we're already seeing is a lot of focus on B2B e-commerce, which we think will also grow at about the same 13 to 15x going forward. So a lot of the action so far has been on the consumption side and the B2C side, but just more broadly thinking about the different sectors, health tech absolutely does stand out. We also have looked at some of the changes in terms of not only the overall population, but how needs and the awareness levels for health is changing in this country. This audience is pretty aware, but I think COVID's given us a massive fillip in terms of the awareness of health amongst the entire population. But when we go and survey the population, there is a huge set of unmet needs, and there are changing needs here. That is the opportunity of what health tech can do to try and change the paradigm. In terms of behaviors, people are more informed, people are more engaged, and people are looking for and are engaging much more on the digital side to look at different treatment options and different ways to consume healthcare. From a treatment perspective, it's not only the hospitals. People are looking for alternative sites of care beyond the hospital. So we will start to see an ecosystem develop beyond the hospital that again will go a little bit to the affordability point. Convenience in addition to quality is paramount, and people interestingly are willing to spend for better outcomes. I think one of the big things in this country and for the health system is to really focus on improvement of the outcomes. So I think if you think about what health tech can do to improve health quality outcomes is a significant opportunity going forward. From a coordination of care perspective, I think we are extremely siloed in terms of what is happening across the treatment corridor from primary, secondary, tertiary care. And the consumers are all looking for multiple ways to simplify and create single touch points. And so I think there is an opportunity here for new models of integration of care that I will talk about, which I think can, again, get to the same objectives that we're talking about. But the consumer needs are changing. This is the opportunity for us to think about innovation to try and address some of these pain points. This is a chart. It's probably outdated by now, as Doc was mentioning. Given the vibrancy of the entrepreneurial ecosystem in this country, the health tech insurgents, we've seen already a significant rise across the treatment corridor, from the preventive side to the curative side, to a lot of what is happening on the health insurance, medtech, data aggregation, IT side. This is going to explode. We are already hoping that this will actually change some of the gaps that we have not seen in the market. And areas like preventive, early treatment, et cetera, is going to play a critical role as it comes to making healthcare a lot more affordable in this country. We are also going to start to see chapter 2, a very different chapter when it comes to platforms in healthcare. We've got 6 very well endowed players that are participating in the health platforms in India. Chapter 2 will be a very different chapter than a chapter 1. We are now talking about a focus on sustainability and creating much better use cases and much better unit economics for any of these platforms. We are working with several of them. Their plans are still quite dramatic, but they will be a lot more responsible in terms of burn rates, et cetera, going forward. I think the other big challenge with the platforms has to be a focus beyond just price-based. So how do we differentiate? How do we stand out for improvement of some of the needs that I talked about, and improvement of quality is going to be quite critical here. The other challenge I think we will start to see in these health platforms is how do we truly make sure that there is the right cross-sell? These platforms were created with a huge promise of convenience and one-stop shop, but that is absolutely not happening. And so I think as we think about chapter 2, we will start to think about, with the consumer, how do we provide the right cross-sells in areas that are lacking, but it has to be with an eye towards improvement of health outcomes. This is an interesting chart. If you step back a little bit beyond India, there is a significant amount of capital. If you look at the right-hand side, there's about $35 billion that has come into health tech globally. If you look at the bars in this chart, the US, as we would have expected, is probably the most significant funding source, and next followed by China, but India is not far behind. So we're talking about health tech is about 3 to 4 billion that has already come into this market, which is pretty significant. The other interesting point as you look at this chart is the focus of health tech. In the US, there's a lot of black on that, on the bar. The black represents virtual care or telehealth, which has been among the significant focus in the US, along with a lot of parts of the yellow part, which is focused more on health and wellness aggregators. That's really been a focus on in the US. If you look at China and India, there's a lot of blue. The blue part is really looking at e-pharmacies, looking at disease management, looking at marketplaces. And then there is a little bit more on when we look at some of the other rest of the world. Surprisingly, we're not seeing Europe as being at the forefront on health tech. So those are some of the investment themes that we will start to see, and we will start to see that are being relevant, that are quite relevant across the world. If you step back a little bit and think about the unicorns, we are probably well aware of the unicorns in India, but globally, roughly about 100 unicorns in health. Of that, India's share is small. But I don't think this is going to be the picture a few years from now, given we think that India's share will be significantly larger, definitely more than 4 or 5. We will talk about double-digit unicorns that hopefully we can lead and leapfrog when it comes to the overall health tech landscape. And one of the reasons I say that is not only because we have an extremely vibrant entrepreneurial ecosystem, but there is tremendous amount of funding that is available for the right opportunities. This chart shows a little bit on the financial investors that are focusing on health in this market. The 22 data, by the way, is beyond 4 billion. So this has not come down in spite of the funding winter that we're talking about when it comes to health. So there is plenty of capital. And I think when we look at the overall financial investing landscape, health and IT is the other one that remains extremely top of mind when it comes to big investors. So there is an abundance of capital, and when we look at what is the capital that is sitting out on the sidelines, what we call the dry powder is extremely significant. It is mind-boggling. Globally, we are sitting on about 4 trillion that has been raised, that is waiting to be deployed. We are raising this year about another $900 billion, and that has come down by another $100 or $200 billion. So there is plenty of capital. If you look at APAC, Asia itself is about 675 billion that has already been raised, waiting to be deployed. And what is very significant is there is a move away from China. So when we look at and we work with the leading financial investors, there is a clear pullback, and it is now China for China, not China for the rest of the world. So what the financial investors are doing is they're rebasing their portfolios towards markets like India. So the number that I showed you earlier, about 4 billion, will be surpassed if we have the right opportunities. So capital is not the constraint in this market. Healthcare also is extremely resilient. I thought I'll just show you the IRRs and the deal returns when it comes to healthcare versus other sectors globally. And these are median returns, and some of the bars show you what's the performance in the top quartile and the bottom quartile, which shows you a massive spread. But healthcare returns have been significantly higher, 4 or 5 points higher than other sectors. So not only because there are a lot of opportunities, but healthcare has performed well. On the right-hand side is an interesting one also. We are getting into a more inflationary environment around the world. The era of cheap capital, cheap interest rates is probably over. So I thought I'll show, what happens to healthcare spending in inflationary times. This is going back to the 70s. The same thing, by the way, is true when it comes to times of turbulence as well. So healthcare is continuing to be resilient. And so we will continue to see capital flowing into this market. I tried to create a chart a little bit looking at what are the opportunities for health tech when it comes to improving access, affordability, and quality of healthcare. And I have absolutely not done justice here. There is so many more opportunities that can be truly game-changing when it comes to improving access, crashing and making a lot more affordable care, and then really creating a paradigm change when it comes to quality. And I applaud Caho for what you guys are doing here. But just these are amazing opportunities. I'll just give a few just to try and bring it to life. We know what the challenges of healthcare beyond the top 20, top 30 cities, which gets all the investments, all the press. But the biggest challenge, I think, what we're seeing is it's not about lower affordable care. It's about lack of manpower, lack of skilled manpower. So how do we think about using technology to try and provide skilled manpower and skilling? And there is some really good health tech solutions, and I've been blown away by some of the remote care, EICU solutions that I've seen people use in the metros and try and solve those problems. There's another issue around, unfortunately, mental health and amongst others are not well treated and are not getting the right. But I think there's an opportunity again of how do we use wearables, telepsychiatry, there's chatbots, voice biomarkers to truly change how we go after certain disease states. I'm not going to go into this in a lot of detail, but I thought I'll bring a few to life, showing what can some of the health tech opportunities do to really be game-changing for this market. We are extremely bullish on healthcare SaaS. The SaaS market, which is the software as a service, is about 12 to 13 billion today. India is superbly well suited to be the SaaS capital of the world. We think this market can get to about 35 to 40 billion in the next 5 years. We have the software capabilities, we have the entrepreneurship here, and when we look at SaaS, people talk about vertical SaaS, which is which verticals could you apply it, and also think about horizontal SaaS applications. There are so many of the unicorns that we are seeing extremely successful when it comes to Postman, Zoho. There's a whole host of them that we are working with and we're consulting to. But I think the opportunity lies in really using and really the creation of healthcare SaaS. The companies like an Indegene, companies like an Innovaccer, I think are going to change the paradigm of how health is consumed globally. If you look on the right-hand side, you see how healthcare SaaS companies are a lot more stable in terms of how they scale. This is a model that we think has tremendous potential in healthcare SaaS, and India being on the forefront of leading in that area, I think can be extremely significant. I'll be remiss to not talk about OpenAI or Gen AI. What we are seeing in the last few months is quite astounding. This is the data published by JAMA, Journal of American Medical Association, and you will see in the last 2 or 3 months what the uptick is in terms of the outcomes, comparing physician advice compared to the computer advice coming from OpenAI. It is mind-boggling, but I think the most interesting insight was not that there is useful technology in terms of prediction or in terms of deciding treatment outcomes or treatment solutions. Surprisingly, the empathetic quotient was even higher than what we are seeing with docs, which was very, very interesting. But we are seeing players globally around the world across segments focus on AI as a disruptive area to focus on. This is a CEO topic. This is no longer a IT topic. This is a CEO topic. This is in medtech. This is in providers. This is in payers. And this is very much in pharma as well. Just showing you a page in terms of what are the use cases we are seeing in OpenAI. Foundational models have the opportunity to completely change how we discover drugs. So we are seeing a lot of experimentation. This is a stage of experimentation because we are in very early stages. The opportunity to think about what are the right molecular structures, to think about how do we think about running clinical trials, the endpoints of clinical trials, how do we think about on the front end of making sales, much more personalized sales, digital marketing, and the promise of personalized and customized care is very significant. So the big point I'd love to make is, can India be the third capital when it comes to OpenAI and foundational AI beyond Silicon Valley and China, which is where a lot of the innovation in OpenAI is taking place? There is no reason we should not be experimenting and be at the forefront when it comes to such a disruptive technology. And then I would like to also talk about some of the new platforms. There is a whole host of new platforms that we should be also looking at quite seriously. It is interesting when I look at pharma as an example, about 50% of the pipeline today is coming from new modalities which 5 years ago did not exist. We're talking about peptides, vaccines, cell gene therapy, which is very significant. So 50% of the pipeline is focused on a lot new ways of delivering and discovering medicines. This is really going to be the rise of precision medicine from a pharma perspective. This market is about 4 to 5x growth in the next few years, very significant. And I think we're seeing what can this do when it comes to the delta compared to the traditional medicines. This is just an example of mRNA. We're all aware of Moderna, BioNTech, but we've also seen Indian players like Genova and Gemcovac come in with products that are quite disruptive. And I think it's not about here and now, but I think the big promise is what can it do when it comes to infectious diseases like, what is being tried today on dengue, on Nipah, on Zika, and then the trials that are taking place in terms of new areas which could be quite disruptive when it comes to cardiovascular diseases, oncos, CNS. Again, I think these are the kinds of platforms that I think the government has picked up on, and we are seeing tremendous, and I think it'll be great to have the minister talk about this, but some of the PRIPS policy changes in terms of what the government is doing is also quite substantial and could enable new tech platforms where India could again lead. Just the last 2 pages I'll talk a little bit about. I'll be remiss to not talk about how do we change the paradigm and what is required and the role of health tech. And we have to be thinking about moving from a sickness focus to a wellness focus. The data of early intervention is quite dramatic in terms of what it does for reduced cost and improved outcomes. So what is the way for us to think about consuming early, but also I think the big challenge with our Indian population is we don't know how sick we are. So the role of diagnostics and affordable diagnostics has to be at the forefront. So how do we think about health tech to kind of crash that cost so that we are aware of what the issues we are all facing and we can actually start to get the right appropriate care. And the last page, and I'll stop here, is we need to be also thinking about business models that are a lot more integrated than the way we are thinking today. If you think globally, we are seeing integration of care, which could be the provider-led, which could be payer-led, which could be pharma-led. What is interesting is the last bar is all driven by IT, tech, and data. So as we think about new models that are really truly going across the treatment corridor, tech, IT, and health tech will play a critical role in that enabling. So with that, I know there's a full program, so let me stop there. But thank you very much for the opportunity, and I hope you have a wonderful conference.
Thank you very much, Karan. I think that was fascinating, telling us where we are today, where we are headed, where we could go if we actually seize the opportunities that exist and the talent that is there in the country. Also, the shortcomings, especially trained manpower, which we all know, but it seems very little is getting done. Quality, safety, two buzzwords which Caho is very, very keen on. Again, can technology play a role in leveraging that? Since you're here and it's very tough to get Karan to come, maybe 2 questions if anyone has. I think
I've definitely confused everybody.
Seem to be overawed by the numbers, Yes, please.
I can hear you. I can hear you very much.
No, it'll come in the records.
My name is Rajeshwari from Chennai. Just want to know, can you throw some light on how higher education in India can support or engage with healthcare more productively, meaningfully? What are the gaps?
What are the gaps with the role higher education can play? I'm sure there are other folks here who are more knowledgeable, but I think just how do we, the biggest gap really is how do we create skilling, but how do we use tech? To me, the most obvious one is can we improve CME, and can we use technology to improve how we do medical education on a continuous basis. And thinking about the opportunity of asynchronous education is a low-hanging fruit, and I think we can move quite substantially. When we talk about quality, that could be one of the low-hanging fruits to try and focus on. But I think there is a much bigger opportunity here, which is can we think about how do we close the skilling gap? The skilling gap is dramatic. Doc will know best in terms of what the numbers are of the 1 million, 2 million. The docs, the nurses, the specialists that we are missing in this country. So is there a way to disruptively, think about creation of more or retraining of allied healthcare to address this gap? But I don't know, Doc, you probably have a better
I
view.
think the numbers, in fact, Dr. Gyani showed the numbers. AHPI has done a lot of work. We didn't even know how many hospitals there are in this country, how many more than 100 beds, how many doctors, what is the doctor-nurse ratio. But I think we have latest, pretty authentic numbers which AHPI has put together, and possibly we'll share those with you. But the fact remains that maybe we need nurse practitioners, maybe we need physician assistants, and that's where I think the medical fraternity will have to come to an agreement that, just MBBS doctors cannot, in the short term at least, provide the ability to reach universal health care.
I think Mukul had a question, if I heard you.
Yeah, hello Karan, wonderful talk as always. Just a comment and maybe your thoughts on this. I think you will agree that the government or the public health system will play a very significant role in if we have to achieve some of these ambitious projections. And as you'll agree that the affordability and access really rests at that 70% unserved population of our country. What we have observed in the last few years, although many PPP models have come up, that's one area which has not really taken off to the extent to which it could. And somehow we have not been able to come together with a good solution, towards integrating and making these innovations accessible to the government. So that is one thought which I wanted maybe you could comment. And another aspect is that, when health tech is racing ahead, especially on these new innovative models like SaaS, the regulatory pathway also has to keep, pace. As you're aware, in the US, the, SaaS and the US FDA now approves digital therapeutics, etc., as part of a separate pathway. But in India, that pathway has not yet been set up. So if India has to be the SaaS capital of the world, I think those are also areas where the government has to really step up.
The unfortunate part with the SaaS is that the focus is all actually in the developed markets, because the players are looking at the profit pool, belonging to the, especially in the US. And so it's a real shame if SaaS is not going to be used for Indian healthcare. So the way we are seeing SaaS players develop is I'll develop in India on the cheap, but I'll commercialize all in the US. And so we have to change that paradigm where it is good business and good economics and good impact of having SaaS impact the larger healthcare. Some of the solutions of SaaS, in terms of predictive care, in terms of even what Doc is doing and what Vidur is doing, just even on the radiology side, is game changing, but it's the penetration here is extremely low. It's really about, can I test it and do a minimal testing, and then can I focus on global markets and really change the paradigm there. So I think the government is probably going to be a willing listener. The government, I find overall, is just very open, but it's a much more complicated topic that I leave to people in the front row here to figure out how we navigate that. But I think the timing is right to engage, and how do we kind of leverage this in the public infrastructure has to be a key priority. Otherwise, we will just be focused on the niche part of the pyramid.
I think what Karan is hesitating to say is that there has to be viability in the system, financial viability. If that is there, then those things will happen here as well. Why would one want to go to other parts of the world? Of course, one may still go, but leave your own country and think only because of financial viability. Sam.
Thanks, Harsh. Karan, question is a bit different in terms of health has become a very nice subject to pick on and beat up, especially the provider ecosystem. What are your insights and perhaps suggestions you have for us as an industry so that we can get the regulator a little bit more on our side rather than picking on public, and therefore it's a right to everybody to get health, and therefore non-sustainable models of health, which seems to be the growing case of view for a lot of the government's actions and policies?
That's a great question, Samir. It's a big question. I'm not sure I'll do justice, but I always think there is, we've got to be thinking, we've got Indu here, so I think Indu would be the right person to probably turn this over to. So somebody can get Indu a mic.
He's on next.
He's on next. But I think there has to be an opportunity of give and a get between the public sector and the private sector. This is not an easy one. I think the private sector has a huge role to contribute, to play. So there has to be a combination of, and I think there is a lot that the private sector also needs from the government, and there are some big risks that are also impending in this environment that we need to protect against. So we need a vibrant private sector, but also the private sector has to play a role in the point you made on skilling, whether it's about quality, whether it's about, there's so much of opportunity for the private sector to contribute to the public sector. But there has to be a coming of the minds saying, how do we coexist and fuel each other? Bindu, Indu, I'll turn it over to you. I'm sure you have all the solutions to share with us.
Final quick question, and then we close it.
I'm Dr. Nagendra. My question is the extension of what Sam asked. It's about, there are more than 25,000 hospitals in India, which is a neighborhood hospital. And you touched upon a very important early prevention and early intervention into the thing. We unfortunately are having less than 40% occupancy in most of those hospitals, where we are continuously talking about developing infrastructure while the existing infrastructure is being very underutilized. Looking at the early intervention, prevention, and the rehabilitation into the consideration, and 70% of the illness is secondary care thing, how do you think that we can enhance the neighborhood hospitals to support the government and the tertiary care? Any thoughts on that?
I think this goes back a little bit to the how do we create the PPPs and how do we create good enough incentives for us to provide quality care. The unfortunate part is Ayushman Bharat is just not feasible for the private sector. So it's a great step, great move forward. But with the pricing of Ayushman Bharat, it just doesn't become attractive. I don't know, you tell me otherwise. So I think we need to set a minimum viable pricing that allows us to deliver quote unquote standardized care or minimum quality care. I think if we are providing that and we're not going to make economics, if it's not a business case, how does it help? So I think this is a big topic that I think Doc and others will have a view of. But if it's not good economics, but it's a real shame if we're sitting on infrastructure which is underutilized. We keep talking about we've got to build another 1 million beds, but if we can't use the current infrastructure optimally, I think that's criminal. So it has to be good business and good economics that allow, and basic standardized care that has to be the need of the hour.
I think with that, we'll have to call it. I'm sorry for the gentleman at the back who wanted to ask a question. Thank you very much, Karan, for your insights. And it's a pleasure having you here.
Thank you, sir. Thank you for providing the context and the premise for the entire day. I'm sure we'll have solutions through in the course of the day by various faculties who will be speaking on the dais. Over to you, Devashri.
Well, after the thoughts are already rolling in process, as said by Mr. Karan Singh, we move forward to the first session of our Cahotech 2023. The theme being healthcare's digital transformation, bridging policy, technology, and practice. For this, we would like to request the presence of our moderator, Mr. Som Mittal, on stage, please. Mr. Somithil, he is the former president of NASCOM. He's on the board of Apollo Hospitals, EXL Services USA, Sheila Foams, Tata CIA Airlines, and Vodafone India Services. He is also the former board member of Axis Bank Limited and Cyient Limited. He chairs leading NGOs like NCPEDP, the Museum of Art and Photography, MAP that is. He is on the board of GMR Varalakshmi Foundation and trustee of the Axis Bank Foundation. And he's currently chairing the Patient Safety Initiative along with us.
Welcome, sir. And we have a fantastic faculty to join you, sir, for this session with tons of experience in the domain of digital health. I'm requesting the panelists to join. Requesting Dr. Indu Bhushan, sir. Requesting Dr. Kiran Anandapillai, sir. And requesting Dr. Uma Nambiar, madam, to join us on the stage. I'll be giving a brief introduction to each of you. Dr. Indu Bhushan, sir, was the founding CEO of National Health Authority and Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, a flagship health assurance scheme of the Government of India, covering more than 500 million citizens from April 2018 to Jan 2021. He also led the implementation of another flagship scheme, the National Digital Health Mission, which was later renamed as Ayushman Bharat Digital Mission. He is an ex-IS officer, 1983 batch, Rajasthan cadre, and holds a PhD in health economics and a Master of Health Science from Johns Hopkins University, USA. He is an alumni of IIT BHU and IIT Delhi, where he completed his BTech and postgraduate diploma respectively. Welcome, sir. Dr. Kiran Anandampillai, is the advisor technology with the National Health Authority. He is a volunteer supporting the NHA to create digital public goods under India's two large digital health initiatives, the Ayushman Bharat Digital Mission as well as Ayushman Bharat PMJAY. He has volunteered with the UIDAI for the Aadhaar program and with the iSpirit Foundation on the health side. Mr. Kiran is a telecom engineer by training and was a founder member of On Mobile, where he helped build it to become a public company. He is a founder and CEO of iDrishti, which delivers high-quality eye care from a district capital to the village level. Thank you, sir. Welcome on board, sir. And finally, I'll introduce Dr. Uma Nambiar, madam. She is a trained neurosurgeon and an experienced hospital administrator. She is currently the CEO at Bakshi Partha Sarthi Hospital at the prestigious Indian Institute of Science, Bengaluru. She is the co-founder and chairperson of DHII, Digital Health India Association, director and board member of Amos Group of Hospitals in Sri Lanka, as well as the director and board of member of IIHMR, Bengaluru. Welcome, madam. I welcome all of you on board, and I'll request Som sir to begin with the session. Thank you, sir.
Thank you, and let me extend my own welcome. It's amazing to see all of you back here in person. I think it's last 4 years that we have been doing this Cahotech virtually, which was fun, but I think it's much better to have you and see all of you in person here. I think it's being live streamed. If not, I think it's all going to get recorded. So while we had much larger audiences online, I'm sure the reach will still be there, because everything that's being shared here, I think, is here to stay. Our shelf life of what we discuss is quite long. You heard Karan talk at a macro level, and I think it's very important. We will the whole day discuss micro level of what we're doing with technology. But as he said, I think for this country, a healthy nation is very important and critical. G20, and we got really all the data about how well the country is doing, how well the economy is doing, science and technology, our youngest population. But I think health for the nation is critical. Significant strides have been made in healthcare at all individual levels, and many of you are sitting here adopting. Every time we see presentations of clinical excellence, new innovations that are happening. The other day when we had hospital innovations coming up, they were amazing. So there's a lot of work that is happening at individual level, but for our national goals, ambitions, and aspirations, we have to make use of technology for the three factors that Karan spoke about, which was accessible, affordable, and effective healthcare. One of the biggest achievements that was talked about, rightly so, during the G20 was the digital platforms. What has digital infrastructure done for this country? And this is the first time it's being done in the world at that scale. And you heard about what Aadhaar did, Jan Dhan did, UPI, CoWIN, telehealth, and the list goes on, and we have people who have been very deeply engaged. I know Kiran has been involved in many of those, and of course, Dr. Indubhushan himself was part of it, which actually allows rapid deployment, and that's what has happened. Our diversity, literacy levels, etc., actually make it a little more difficult for us, right? Because to take it to masses is. So the moment we step out of hospitals and we move into a larger plane where technology is probably a biggest change agent, I would think, we would have to think very differently. Dr. Gyani, you have been at this affair and now seen at this level. So I think we have an amazing panel here. We have Dr. Indubhushan, who is been a policymaker. He's the one who started Ayushman Bharat and then saw the next phase of it beyond insurance as well, taking into a mission level, right? We have Kiran, who represents technology, and he knows what it means to scale, because this is not the only one that he's been engaged in, and he's seen it all. We have a practitioner, because it's okay to create policies and technology, but we have a practitioner, and I represent the patients, right? At the end of it, I think we do all of it for us. How are all of us getting interlinked in this area? So we have been very fortunate that the organizers have allowed our first session beyond the keynote to be focusing on national health. And I think we have done it consistently. Dr. Indubhushan has been with us before. Sir, your successor, Dr. Sharma, also was with us last 2 years talking about it, and it's good to have you back here. We will take a format. We will request each of them to speak and share their perspectives for 10 minutes. And we've already seen, I prepared some questions just in case you don't raise your hands, but I don't think this audience will need my questions because you were already active in the previous session as well. So with that, can I request Dr. Indubhushan for you to set the stage, share with us. You have done it yourself, and now you see it from outside. So give us your frank views of what's going on. Dr. Indubhushan.
So, first of all, thank you very much, Mr. Mittal, Dr. Mahajan, Dr. Agrawal, for inviting me. Thank you, Kaho, for inviting me again. The lost son who have come back to this conference after 2 or 3 years. In my short 10-minute presentation, I would like to share with you what I see from earlier inside but also outside. What are the key policy challenges? What is the key policy focus of the Government of India or government in general? And what are the problems or challenges that we face in terms of achieving those policy objectives? And finally, how, in my perspective, technology can bridge that gap and bring the practice and policy together. So just starting with the first question that if you ask anyone on the street, what is the core government policy on health? I think the answers will be varied, and because if you look at 2017 policy document, it has long list of policy objectives that we want to achieve. But if you go at the core of the policy is to provide universal health coverage, that everyone should be provided with the universal health coverage. And that is also enshrined in our Sustainable Development Goals, which is SDG 3.8, that we want to achieve SDG UHC by 2030. And how do we define it? Of course, there is a very complicated definition of UHC, which is generally accepted. And it has, if you look at this long definition, it has basically 3 core elements. One is that they should be all different kind of services available, whether they're preventive, promotive, curative, palliative, or rehabilitative. They should also be available. They should be of sufficient quality and should be effective, not any service, but they should be effective services. And finally, there's a concept of affordability, that in using those services, no one should be put to any financial hardship. So if you try to translate that in a simple language, the objective of the government is that everyone should be able to use their services according to their needs. Whatever they need, they should be available, and they should be able to pay according to their ability. So according to their need, they should be able to access services, whether what kind of services they need, and in terms of payment, they should be able to afford on them, and they should be able to pay according to their ability. It's not that the services should be free, but it should be affordable, and people should be able to pay according to their ability. So now, if you look at how we have done in terms of providing services, usually the measurement of UHC is done on two dimensions, that what is the access, what is the service delivery access, and what is the affordability. So if you look at the first part, this is a chart that I've put together, providing different countries where they are in terms of service coverage index. It's compiled by the World Bank and WHO, and this is about with respect to per capita income. So obviously, countries who are richer can provide better services, access is better, and that's why you can see that very discernible regression line which goes up, and India is somewhere in between. But one thing which stands out here is that as compared to our income, we actually have done quite well in terms of providing service coverage, because we are slightly above the regression line. All other countries of the similar income have not been as effective. But one thing, of course, you have to also take into account that averages sometimes mask huge differences that we have in the country, and this may not represent everyone in every state, every family here, and I think reality is much more nuanced. But in general, on an average, I think we have done quite okay as compared to our income. Service coverage is quite okay. But if you look at how we've done in terms of affordability, and here you would find that India is slightly quite far above the line. Here, being above is actually not good, because this represents proportion of families who are spending more than 10% of their disposable income on health out of pocket. And obviously, this is one area where India has not done well. While we have been able to provide services, we can question the quality and access to the last mile, but in terms of coverage, I think we have been fairly okay. But in terms of affordability, a long distance to go, that's a major challenge. So if we look at the major challenges that we have in achieving the policy objectives of achieving UHC, what we find is that there is inequitable access. I have a very beautiful chart which shows that we live in several countries. Many of the states have health indicators and health services which are very close to what we see in sub-Saharan Africa. And there are some states where our health indicators and our access to service is that of upper middle income countries, actually approaching high income countries. So there is a huge inequity in access to health in terms of geographical location by rich and poor, but also urban rural areas and different socio-economic characteristics. We also have a problem of uneven quality of services, both in public and private, and that needs to be, and that comes partly because of the accountability structure that we have. And we also see that the focus on lack of focus on primary health and weak continuum of care, and was what Karan was talking about, greater focus on curative side rather than welfare-oriented health system is there. And again, we also see inefficiencies in management of services, in public sector, but also private sector. In general, as a health system, if you see the kind of fragmentation we have in terms of provision of services and financing of services, probably is one of the largest in the world. So when the question is that how can technology help this in addressing these challenges? And when we were launching a national digital health mission after Prime Minister announced it on 15th of August 2019, many people asked me the question that, digital health, is India ready for that? And if we don't have services, if we have so many problems that I've mentioned here, how is tech going to help you? Because, you need to have bread before people can eat it. Technology can't create bread. So you don't have services, then how would technology help? But I tend to disagree that actually technology can help in many of these fields, and I'll leave that with you, that if we are talking about access, and of course we need services, more services, but creating services overnight is not possible. But one way that tech can help, of course, is through telemedicine and bridging this gap between underserved areas and where we have more services. Right now, if you look at the availability of health professionals, on average, I think we are okay. But when you look at the distribution, that's where the problem is. So can technology help in terms of bridging that gap? And one answer is, of course, the telemedicine. There may be other answers too. Similarly, quality of services. And of course, here, enforcing quality of services, we have tried that in Ayushman Bharat PMJ by having standard treatment protocols and using technology to help us improve quality. We can also look at the rational prescription, whether antibiotics are being provided which are not necessary, and technology can help that. Again, also in getting the data, because right now many providers are actually prescribing based on inadequate or no information, sometimes shooting the dark. And can technology help in terms of improving their diagnosis, improving their capability to provide more effective treatment? Accountability, if can technology make the transactions more transparent so that we can hold our health system more accountable for what they're doing? Scale. When I joined Ayushman Bharat in 2018, and we were told, Kiran was with us in the team, we were told that we have to launch this scheme in 6 months' time. And a scheme which was going to be reaching 500 million people, getting on board 36 states and UTs with the help of thousands of hospitals, and identifying all those people and ensuring that those people are the real beneficiaries, and having the accountability structure wouldn't have been possible without a tech backbone. And and we saw in COVID time that COVID, which provided almost 1 billion doses and provided those certificate, couldn't have been possible without technology. So upscaling in a country where we have 1.4 billion people, I think how can technology help in terms of creating models, but upscaling those models for population? And that's targeting. If government has to provide resources, subsidies, and special services to people, so ensuring that it's going to right persons, right people, we identify their eligibility, but also their identity. Can technology help in that? Similarly, reducing fraud and abuse, because if government is providing resources and services, are they being used properly? The payments are not going to any ghost entity. Can technology help in terms of reducing fraud and abuse? Now, one element of is affordability, and affordability comes from cost, and reducing cost is also one of the critical aim of policies. Can technology help in terms of making services more efficient And of course, we've seen that by better record keeping, better diagnostics, we can reduce cost. Right now, we have known and seen that a lot of unnecessary tests are done. Tests are done again and again because we don't have access to previous diagnostic results. So can technology through new system of National Digital Health Mission, or now Ayushman Bharat Digital Mission, can we ensure that all the records are there so that we don't have to do unnecessary tests and reduce cost? Monitoring, real-time monitoring of what's happening in the field and giving that real-time feedback to the government, whether the schemes and their projects and programs like Ayushman Bharat are going on track, is another area where technology can help. Grievance redressal, having a feedback loop from people, what kind of services they're seeking, is another area where I see the challenge for technology for helping us. Portability of services. Right now, since we know that large number of tertiary care facilities are available only in few places, we should be looking at portability of health records and ensuring that this is feasible. And again, technology has come to our help in terms of ensuring portability in general, but can we do it more? Public health management, now providing more nuanced data about epidemiology of disease and how they are spread in the country, and what kind of things are emerging on real-time scale, will also help in terms of managing health services much better. And again, technology has a role to play here. And finally, research. Once we have a large amount of data which is available through technology and through ABDM, that will help in terms of ensuring and pushing research, both for public health but also for medical research in a big way. And that is one role technology can play. With that, Mr. Mittal, I'll close my remarks and I'll be happy to come back during the discussion later at some time. Thank you. Thank you for your attention.
Thank you, Vinny, for laying out all that technology can do. And I'm sure as we discuss, we'll go and do a dipstick check on where we are right now. Kiran, over to you. And you know, you've been part of many platforms and so on. How is this different and compared to what you've done before?
Good morning, everybody. Thanks, Indu sir, for that interesting presentation on where all technology can help. So I think what I'm going to try to focus on a bit about is, while I think there's many things in technology, and as healthcare providers or various players, you know, we saw Karan talk about how many startups are there providing various solutions. So very clearly the future is going to be a lot of different technology solutions that's going to really come to providers, insurers and others. But what is really the role of government? Where should government keep its head or focus when it comes to technology? And that's really what I'll kind of talk about. And I'll talk about this with the construct of this new theme that's going around, where India has really become the leader. And I think you would have seen this even during G20, the whole talk about digital public infrastructure. So we'll take a quick look at India's digital public infrastructure for just a couple of minutes. There's nothing new here that none of you know. We are today probably the best identity infrastructure in the country. Now think about it as, you know, when I was working with Aadhaar, the original TOR that was given was everybody had to get a unique ID. So the government could have just stopped by giving each of you a number and saying, hey, here's your unique ID, go. But I think what made the difference was the fact that it actually converted that into a digital service. All of you now experience eKYC. eKYC, where you are able to go give your authentication or a biometric and you're able to instantly authenticate or provide your proof of identity and proof of address for a whole variety of services. And that was the transformative thing that India did as a digital public infrastructure when it came to identity. Now this identity infrastructure was actually used to drive bank accounts. So back in 2008, India had less than 18% bank account penetration. But because of eKYC and the drive that it did in terms of banking through what's called now JAM or the Gen Aadhaar and mobile, we were able to drive the number of bank accounts to 80% of the population today having a bank account. The third innovation that India did, and I think all of you in this room have used and use UPI today on a daily basis, is really the payments infrastructure. So it took this layer now of identity, bank accounts, and then created a P2P transaction layer. So think about, if you go back just 5 to 6 years ago, there were only 1 million merchants in India who would accept card payments. How many people now accept UPI payments? We are closing to 40 million merchants. So what drove this change? So two things. One is an ecosystem approach. This would not have been possible if the government tried to do everything. So the government essentially created UPI as a platform, but it allowed a lot of the players. So each one of you is using probably Paytm or PhonePe or Google Pay to actually make your payments. And if it wasn't for these ecosystem players coming in to drive, we would not have happened. The second thing it did was on policy. It took away the cost. So it made the cost of a transaction on UPI zero. And it subsidized it through a different way to support the players. And so those are the two things which has essentially resulted in India being now the world's largest in terms of real-time payments in the world today. So look at the difference between India and even China. So these things have all been possible because India has taken a lead in thinking about some of these things as digital public infrastructure. So what's the real difference between technology or driving technology in these various approaches that you might see? So one approach is, of course, to say that the government should do it all. The government builds the application, manages it, runs it, and there is a lot of challenges with this approach. What we see in the West, for example, is where certain things which should ideally be in the public domain. I'll give you a classic example. All of us use maps. Almost everybody in this room probably uses Google Maps. Google Maps should technically be a public infrastructure, but it's actually fully controlled by private entities. You can think of many other vertical areas where such public spaces have actually been captured by certain organizations with almost very limited say by the regulator or the government. So India's DPI approach is unique because we are pushing a third approach in the world. And that approach is a balance where we are able to say that the government has a role of creating a few but very limited capabilities in terms of very clear digital public infrastructure and then allowing the private ecosystem to come and play on the top of that. So this is the thinking. Now the question really becomes, can we take this thinking, can we apply it in healthcare? Can it actually have the same transformative effects that we are seeing in the financial sector happen for us in healthcare? And that's really what we'll talk about today. Now, all of you have heard about Ayushman Bharat Digital Mission. Indu sir was there when the mission started. And really the challenge, one of the core challenges, we talked about continuum of care being a big challenge. It's actually because we have a huge amount of data. While there is, of course, a large part of India that is still not using digital. I mean, I'm sure that a whole bunch of doctors still do only everything on pen and paper, but please do look at the fact that there is also a lot of data that's already digital. None of you here have seen a diagnostic report that did not come out of a printed computer. Most of you are seeing discharge summaries, which are also all digital. There is a huge amount of digital data already there. The question is, it's still siloed, and it's still not useful in the continuum of care. So the key thing that ABDM is saying is that ABDM will help bring this data, which is siloed today, into the hands of patients through this control and put the control in their hands through what we are calling as personal health record apps, right? And then we are saying they will be able to share it forward with the healthcare provider community so that they can actually access that and get access to full history and including full imaging or other history that can happen. So this is actually technically possible today. Now, how is this actually going to happen? Because of a digital infrastructure that the government is creating, which is called ABDM, right? So in the middle, you see the digital public infrastructure that the National Health Authority has actually happened. Most of you in the last 2.5 years would have heard about ABHA. In fact, there are over 40 crore people who have already got their ABHAs today. And ABHA essentially stands for an Ayushman Bharat Health Account, and it's a way by which it's a digital identity by which you can actually start to integrate or capture your health records. How do you get an ABHA? you can actually get it again from an ecosystem approach, from a whole bunch of apps, similar to how you have the Paytm equivalent apps. We have a whole bunch of players that are now coming forward to create a bunch of applications in healthcare. We have Briefcase, we have Arogya Setu, we have Eka Care, and even Paytm and so on, which have actually created personal health record apps, and I know that there are several more that are working on it in the pipeline. So the idea here is that when you go to a healthcare provider, you have to share your ABHA. There are some very easy ways to share it. If any of you have been to AIIMS or any of the public hospitals here in Delhi or in most states, you will now see that you can just go scan a little QR code that's placed at the registration desk and skip the queue. So the long queues that were there are being cut, and we are seeing between 30 to 40% of the patients now starting to adopt this because they see value in it. Now, when that happens, what really happens is that the software system that is being used in the healthcare provider gets access to that ABHA. And essentially, if that software system has become ABDM enabled, it will be able to link the health record with the ABHA. The moment it links it with the ABHA, you can actually see it on your phone, you will be able to get a copy of it, you will be able to share it, but more importantly, this also helps the healthcare provider, if they're using an ABDM compliant software, to start become compliant with the DPDP Act, which has recently been passed. So this is one thing that's happening. The second area, so this is one set of digital public goods that's working. The other area that I think we should be looking at as we want to, if we really want to achieve UHC, is how we do health claims in this country. This is a big area that's really broken. If any of you are running a large provider, that you will know that for every insurer and TPA, you use a different portal, you're uploading and sending documents. It's very, very hard to track and reconcile. And even if you think about who's doing the digitization, a lot of the digitization efforts is actually being done by the insurer, where they're trying to look at the uploaded documents and figure out what and make sense of the data as part of the claim processing. And bulk of the adjudication that's done in India is actually done manually today. Now, think about the cost of doing this is over 500 rupees. And let's say if tomorrow we really went to UHC, where we said we want to make an OPD claim happen in this country, we really cannot use this process for driving OPD claims. So the other big digital public good that ABDM is working on is what's called the National Health Claims Exchange. And the idea here is to come up with a simple digital standard. So what NHA has done is it's come up with an e-claim standard. It's an e-way of creating an insurance claim, and then you can actually create it in whatever software you're using at your hospital, and you can submit it to the National Health Claims Exchange, which just acts like a big router. It can't really see the data that's inside it, and sends it to the appropriate insurance and TPA. And the core advantage is that you get a tracking ID that can track you all the way from pre-auth to payment, and you can do it now in whatever software the hospital is using. And because the process is digital, it will also help insurers move towards auto adjudication, which will reduce costs. So this is an area where the National Health Authority and IRDAI are actually working together to get this out in the market. It's already live with a few payers, insurers, and a few providers participating right now. So we talked about the health claims, health information exchange and consent manager, which is doing the personal health record. It not only helps do personal health records, but it also will, in the long term, help bring data for disease surveillance and public management, as well as anonymized data sets that are very, very important for AI and large training. We talked a bit about the second digital public infrastructure that is working on the health insurance part, and there is a third one that's working on digital health services. So today, if you think of teleconsultations or telemedicine or even booking an appointment, the way you would book an appointment is you were to have to find the hospital, go to the hospital, say website, and maybe book it. Or if you're thinking of doing a teleconsultation, today both the doctor and the patient will need to use the same platform, say a Practo on both ends for it to work. Most doctors are uncomfortable saying, hey, I don't want to recommend my patients to a certain platform. And the idea that we have here, very similar to ONDC, it's called UHI. The idea is that the doctor can choose any compliant application. They can set when they're available, what time they're available for teleconsultations. They can actually decide what's the amount, and the patient can use any compatible app. They'll be able to find the doctor, book an appointment, make a payment, exchange health records, and do interoperable teleconsultations. And we think this is again going to change Another parameter that we were talking about is how do we bring more equitable access or access to parts with teleconsultations. And so this is all being done using new digital public infrastructure. Now, Som asked this question, what's the difference between this DPI initiative and the other DPI initiatives that India has? Humongous differences. If you think of UPI, can we imagine UPI if banks said that they would not participate? You know, it's very easy for us to say we're enjoying UPI, but the reality is that we had to get every key bank to first set up infrastructure and participate. Now, an equivalent problem in this would be our healthcare providers. ABDM is not going anywhere unless we can get our healthcare provider ecosystem to participate. And India's healthcare provider system is humongous on a scale compared to the few banks, which will be less than 100 that we have to worry about. We have more than 200,000 healthcare providers across a variety of things that we have to worry about. Now, what really do these guys have to do? What we care about is what software are they using, and has this software been changed or modified to become ABDM compliant? So when we started looking at what software do providers do, we found more than 2,000 players. So again, huge fragmentation. If I were to go to the US, I would find 3 players who would have 70% market share. I can't find one player in India with 1% market share. So significant fragmentation here. So it's a long journey. Everybody's, again, I would say suboptimal. In my mind, one of the big problems is Indian healthcare, and especially the smaller healthcare providers, just do not have enough budgets for IT spends. So the reason why I think in the morning Karan was talking about that we are building SaaS platforms for the West is absolutely true, simply because there isn't just enough spending and economics for health tech sometimes in the Indian market. So the second area is the software vendors. Now we have to convince these vendors to come and integrate with these digital public goods and make their applications ready and then go to the market. So far we have got over 100 plus of these convinced, and there are several more in the integration. So what's really going to drive adoption? You know, how do we really get this ecosystem going? Right now there are 2 things that are, I think, tailwinds for adoption. One is the DPDP Act. So healthcare is definitely, you know, anybody who's holding health records digitally in their hospitals or clinics is going to come under the DPDP Act, and the easiest way for healthcare providers to actually comply with the DPDP Act, not get slapped with the 250 crore odd fines that are being talked about, is to actually use an ABDM compliant software, because that's one of the things that's going to make sure that your providers and services are compliant. The second thing is right now to encourage adoption and also to cross-fund or to fund some of these infrastructures. The National Health Authority has a financial incentive scheme. You can actually get ₹20 for every health record linked. It's not just you who get it as a healthcare provider, but even the guy who made the software for you gets about ₹5. And so this is a big incentive scheme with several crores of rupees, over 50 crores in just this financial year that's been put in, and likely that there'll be more as we go along, that's driving this adoption. So to end the talk, I think India is taking a very interesting approach in terms of what the government is trying to do in terms of pushing digital health technology and adoption across the country with the ABDM initiative. You can see some of the numbers on the right in terms of where we are already reaching, but there is still a long way to go, and success really depends on getting the provider ecosystem on board. Thank you.
Thank you, Kiran. That was really wonderful. I think you demystified in a lot of ways and made it simpler for us to understand. So we heard the whole initiative from the government and how it's getting translated. Umaji, we're going to hear from you now what you sense and what should the healthcare organization be doing. As you go there, I think this is the time that they should partner with Caho, right, to take it down to the healthcare providers. I think that collaboration is required, and I do hope, I know that both of you are now adjacent to the mainstream, but I do hope that organizations like Caho take this up to take your mission further. Umani.
Thank you very much. And segueing from where my co-panelists have just taken you to, definitely we understand as healthcare providers that we have a big role to play in achieving what you have laid out for the country. And if healthcare in this country has to move to the next orbit, which is what we all aspire for, but we need to understand where we as healthcare providers, where are we at this moment, and what is our understanding of the whole system and how we would like to be more inclusive in this entire system. So, our ask for all, healthcare providers and seekers, have always been to improve quality at lower cost, make it more accessible. While we thought that we were trying to fix it, came COVID. And suddenly we realized that all the edifices that we had built to think that we were solving our problems came crashing down. We realized how vulnerable we were, how wrong we were, and we were playing these games in silos, how we thought that we as individuals can succeed better. We were shying away from sharing information, and we were far from documenting what we were seeing. So we didn't have the game right, and fortunately, at that time is where people on the dais were working on ABDM before that. And we realized that just as COVID made us realize, we also had our government putting in places the pieces to solve this puzzle. So we had some tools to realize that, okay, this may be the right way to go. All of us understood, the population understood, they were not shy of using digital technologies. The healthcare community realized that we need to fix the system, and the tools that are provided by digital technology could just be the right tools in our hand. It also, majorly focused on empowering the citizen, which is actually a very, very bold move by the government. I mean, I have to congratulate my co-panelists for having been part of this revolutionary movement in the world, because I don't think across the world any government, and especially with a population of 1/6 of the world, could have had the courage to even embark on this if they were not confident that our country was ready for it. And when I say that we were ready for it, it also displays the confidence in the healthcare providing community and the intelligence of the average citizen to seek it in a more rational manner. But it's easier said than done. Look at the fragmented system in which we live. How are you going to collate all this data together from this disparate system that we live in? Obviously, we needed to build a building block. So digital tools actually provide the backbone to converge all this data, to collect it and converge it, to actually realize the dream, to move the healthcare to the next orbit. So, very simple slide. What is healthcare? Healthcare delivery is nothing but data management. What does a typical physician do? Collect data from the patient in forms of history, examination, diagnostic reports, analyze it in his mind based on the information of the knowledge that he has from books, journals, friends, old patients, and with the availability of that information, analyze, diagnose, and prescribe. If we use digital tools, how does the game change? The computing power of the analysis of the doctor's mind multiplies. It now has the collective multiplication, of the entire data sets that we have for diseases and the management. And therefore, every doctor is now more empowered because the tools that are available for decision making are now that much more. Also, it saves their time. You don't have to cram up books. You don't have to remember unnecessary details. It's all available to you, provided to you by a system which is rationally and scientifically analyze that information. And that's truly changing that business model that's available to us. So simply put, healthcare delivery is managing data, and which the government has realized and is trying to, but the problem is, have we all, in terms of healthcare provider, understood this new paradigm? Are we ready for this? What are we waiting for? we also now have an empowered citizen who will have a personal health record in his hand, who will be demanding a well-managed his or her data by us. So while we are ready, we need to understand that what is required from us is better documentation, more collaboration, and coexistence. So the tools of data collection are part of the new healthcare ecosystem, because we are no longer just writing on paper and pen. So all the technology providers sitting here and providing healthcare technology to us, they are now not vendors, but partners in healthcare delivery. Understand that we are equally responsible to provide healthcare delivery. So everybody who creates technology is part of this new ecosystem. It is important for them to understand that the quality of data that the healthcare provider needs to collect can only be improved by them. That quality is what is going to determine the kind of healthcare that is going to be delivered to the patient. So this is a new profile of the healthcare ecosystem players. But what is the challenge here? Now in all this, now we have three players who are important, in fact four in fact. Healthcare provider, and I would include the technology developers now in the healthcare provider part. So that's one stakeholder group. The patients, who need to understand what is the importance of the data that is given to them in PHR and how they can access it, how they can use it. And government that needs to facilitate it. The challenge that we have today is the digital illiteracy of the first two group of stakeholders, the healthcare providers and the patients. It is easy to say that I'll provide data on the patient portal to the patient's phone. What is he going to do with it? Who's going to tell them how to access it? Who's going to tell them how not to access it? Who's going to tell them whom to access it with and to prevent use and misuse and abuse of that data? It is the healthcare provider community that has this knowledge as to what the patient should do and not do with that data. But are we empowered to teach them, train them? Have we actually created that capacity in our country? Not yet. So while it is okay to say that this is the moment where we can think that healthcare has arrived, but unfortunately that is not the truth. While on the one hand we are trying to develop implement digital tools, technologies, and improve the documentation and collaborative efforts, and to provide better care, standard care, we have not yet. In fact, what is happening is the other nuts and bolts system of the healthcare, which is a safe working place, which is trust for healthcare providers in the community, making healthcare as an aspirational career, that is taking a beating. So if we don't have users, who is going to use the technology? So we need to create users. We need to again make healthcare a respectable profession. We need to again create manpower that thinks that, and the students who aspire to become healthcare providers. You know, if you see the number of seats that go vacant in super specialties after NEET, that's an indication that we will, in a few years to come, not have enough healthcare providers to use the technology that we are trying to deploy. So we need to change that by creating an environment of trust in the community. We need to make sure that, there are financial requirements to create all this. It's okay for the big hospitals, but what about those 30-bed, 50-bed, 100-bed nursing homes in Tier 3 towns? First, they don't know what is the ask of ABDM. They are told to do something, they deploy. They don't have the financial muscle to do the change. They don't have the knowledge to do this change. So how are we, like Mr. Karan Singh in the morning told about billions of dollars that are available. Even if the powder that he mentioned was available, not the one in the vault, but just the powder lying around, is available, some of those finances could be deployed to help these 30-bed hospitals to survive, because otherwise they are going to die. The number of beds that are available in the country is going to reduce further. We need to create and we need to think about more flexible and agile manpower deployment system so that the available resources, instead of in tight compartments, could be more flexibly deployed to create a delivery system where there is enough manpower. We need to make sure that there is a good business model, and by that I mean create a conducive marketplace for the private healthcare system to survive and thrive, to ensure that healthcare is not a populistic tool, but a value add for building healthy human capital for the country. Thank you.
Thank you so much. We are kind of running out of time. I think the minister is already here, but I think there would be some questions that we should anyway raise. So I think the one that you raised here, to all of you here, you know, when you brought in Aadhaar, you got in UPI, it didn't nothing existed, right? And it was new that you could impose. Here, hospitals exist. If I'm putting and digitizing myself, I want to be a unique experience for my patients, so it's my competitive edge. Now you're trying to democratize it. What's the incentive for me to share my data?
You know, that's a very pertinent question because, you know, the comparison is not with the Aadhaar, but with the UPI. What ABDM is doing is exactly like UPI. He showed, Kiran showed that highway that is being created. And if ABDM is successful, it will do the same thing that UPI has done for finance sector. It will do the same thing for health sector. Now, of course, when UPI was put in place, banks existed. All the commerce was taking place. The exchange of money is taking place. And banks at that time were also reluctant to share the data, share the accounts information because they didn't let people to go. They don't want to part with their money as well, right? So, but they came on board. Here, health sector, health people also have to come on board. But the biggest problem that we see is one, that at that time there were 200 banks, and banks are very heavily regulated, and we can identify and deal with the banks in a much more effective manner as compared to health sector, where we have different kind of providers, not only corporate hospitals, we have small hospitals, we have clinics, we have labs, we have other like people, jhola chap doctors. So just getting all of them on board is a big problem. The second is that in UPI and finance, I think everyone's interest was almost convergent because bank wanted a smooth system where they can make the payment based on EKYC and others. E-commerce players wanted a system where money could flow. Here the consumers wanted a system which is more efficient. But in health, it may be that all these interests are not convergent. Maybe like what you mentioned, that hospitals don't want to share data because they don't want to lose the patient. Doctors don't want to share the data that they have for patient because they become more accountable. So I think the convergence has to come from the, if we look at it from the patient's perspective, that if the sharing of the data and information will help providers and hospitals to provide more effective care, because once they have access to all the previous data, they can provide more effective care. And that's where probably the motivation has to come from.
I don't know that. Yeah. It's okay. So just want to add another viewpoint, right? So I think ABDM is not asking providers to share any data that they're actually not already sharing. You know, think about what gets shared. You know, the ABDM says share your diagnostic reports. Now, every hospital is sharing diagnostic reports with the patients. Most of them are sharing it digitally. You know, you get an SMS, you go to some portal, you get your report and you think, but you are not adding it to their long-term record. So ABDM is just giving a way by which these reports become part of your longitudinal record, right? ABDM is not asking that you should share, say, indoor patient files which are currently not being shared by most hospitals unless there is a request. Now, switch to the DPDP Act. The DPDP Act actually says that if you are holding any personal health data or any personal data, that you have a right, the patient has a right for you to get access to that data. And so, with the DPDP Act, you have no choice but to make sure that, you also share that data, but you are also safe that it cannot be misused by other parties without the consent of the patient. See, one of the core problems that sometimes happens is, if I share my data digitally, can the PHR apps or others misuse it in some ways? Can they cross-promote to my patients and others? And so, with the Act now being in place, there's a lot more control in terms of what purpose it's being available for and what controls are there. So I think, we should take that into play as we kind of go forward in adoption.
So, as far as the sharing of this data is concerned, I don't think clinicians have any issue in sharing data. And in fact, sharing more than what you just mentioned is also useful for the research and clinical purposes and analytics and further advancement of medicine. So therefore, making sure that de-identification of data is effectively done and that it is in a secure environment. Now, data security is one of the biggest concerns in terms of when we talk about data sharing. And this is a knowledge which, as a clinician, if you ask me that, or as a hospital in charge, that I am responsible for security of the data that I'm storing on behalf of the patient, that's a tall order for us. So this is a new environment. I could save paper in a vault, but I can't save this data in an environment for which I expect that the government will facilitate and make sure that we are also not held vicariously responsible for the data breach that happens. So that is something that...
No, in fact, that's one of the key things, because we understand that doctors are not expected to be experts in IT security, right? So it's like saying, I think the best example I have is this, right? We don't want you to understand what it takes to make a Bharat Stage 4 car, but we want you to understand that buying a Bharat Stage 4 car is good for the environment, so please buy it. So the equivalent here is ABDM compliance. So what we are asking you is to make sure that if you're using a software in your hospital, make sure it's an ABDM compliant software. And if you look at the compliance process of ABDM, much like an ABH or others, one of the key things in it is data security. And so we don't let anybody take that stamp of ABDM compliance unless it actually meets the data security and other standards. And that's the safeguards that you're going to have.
So I just wanted to shift the discussion, and we'll take your questions. Are ready? Yeah, okay. I'm a patient, right? UPI, people made it simple. FASTag, people made it simple. This sounds very complex to me, right? You're asking me to put records and I must share it. I must go and scan. I have an Aadhaar number, and I do go to the hospital. Is there any way that you can simplify it? So if you do simplify it, so there should be a surge bottoms up from patients saying, all of you, please follow NDHM. I want my data and records to be transferable. What's the effort going on there? You have ignored us.
That creativity actually has to come from the private sector, and they will need to find solutions and applications which are user-friendly and all those, and that's where the challenge is, that whoever comes up with the very user-friendly and nice applications which makes things easier for you, they'll have a bigger market share. Same thing also goes for the doctors, Doctors say that they don't have time. They can't input all those record their patient notes. They are more used to writing. If we can have technology which they can dictate and it goes there, and optical recognition software that can do the trick for them. So I think there's a huge amount of work that is there, and that gives a lot of potential for innovation, and private sector probably will fill in that gap. I have no doubt, given our talent and the creativity that we have in the country.
I think this, you spoke about smaller hospitals, and I think Caho actually took that on itself, right, to take the accreditation to smaller hospitals, talk about quality in smaller hospitals. So I'm not sure Lalu, Sam, you are here, and of course the founders are here. Will organizations like Caho take on this mission of getting the healthcare providers now time, given the whole advantage? Because I think there is a large job to be done, and this might be the right forum for us to start engaging. So you did it with banks because they were easier. I think for the healthcare providers, you probably will have to lean on organizations. Yes, sir, who had a hand up? Yeah, you have a mic there with you? There's a mic to be given later, that side.
Hello? Yeah.
Yeah.
Sir, I am from Preferred Limited. We are a company based in UK looking after the data privacy in the US healthcare. So my question to you is, since the DP Act is there in India, but we see no progress with the hospitals or with the healthcare people here in India. I want to have your comments for that.
Well, I mean, we'll have to give it time, right? DP Act is now a couple of months old. In fact, we are all waiting for the creation of the board, the rules to kind of come out, and there's going to be at least a year and a half of implementation timeline. But my own expectation is that, once the timelines are announced, you're going to see much more rapid adoption and better understanding as people try to comply to the act.
Yeah, and if you go back to 2008-9 when Aadhaar came in, there was no Data Privacy Act, and there were lots of concerns that people had that everything is getting tied up. And I think we have now experience of all these years of work that while we have Aadhaar really linked up to so many things, I don't think we have seen any data breaches of that kind, right? So I think the systems are robust enough, and the Act really provides a big cover. As it is, privacy wasn't a big thing for us in India because we share data very freely. But I think that's getting right.
Hello, sir. Hi.
Yeah, the gentleman at the back.
My question is that we've seen quite a few huge transformations in this country. We've seen Aadhaar happen, we've seen UPI happen, but we all know that for it to really become all-pervasive, like it is required in case of Aadhaar, it has to have a very strong push initially. So is the government planning any such thing like the Aadhaar? If you remember those camps that were held to register everybody on Aadhaar, and UPI, etc., of course, took a different momentum. But is there any such plan from the government to have such a push? Because it's a fantastic concept.
Yeah, see, creation of Aadhaar is, I think, the first step, and we have done quite well in terms of creation of Aadhaar. 45 crore Aadhaar is not a small number. And if you look at it, even before before Abha, we had Ayushman Bharat, and in Ayushman Bharat itself, we had given more than 10 crore IDs in just 2 years' time, and they were linked to all the records that they were using for PMJ. So I think we have done that process already. I think it's a question of just taking another step. So you also have to be cognizant of the fact that UPI took about 8-9 years before it came to this stage. It takes time. It takes time for people to understand. It takes time for the ecosystem to also get galvanized. Here, also, UPI was helped by also demonetization, where there's a push for like a cashless transactions. So here, I have no doubt that maybe in 3-4 years' time when we meet, you will see greater adoption, and I think it will have organically will happen, but government is of course pushing it, like what Kiran mentioned, by giving incentive for linking of records and starting with all the government schemes where probably record can be linked very easily. And if say 50 or 60% of the population is already in Ayushman Bharat and other government schemes, that can be linked very easily right away, right? So if 50-60% people are already have health records with linked to their ID or their Aadhaar, I think once there's a critical mass, and so all the hospitals probably will take it on themselves to ensure that all the records are linked to Aadhaar ID, because it's in their interest ultimately, right?
Hello, sir.
Respond?
Yeah, thank you. My comment and question is a little different. I think this is an absolutely fantastic scheme, and thank you, Bhushan sir and Kiran, for working on it. It's going to be transformative. But I think there's one basic block which we're all forgetting or not addressing. You said that the smaller hospitals cannot afford the software. See, I think the basic thing is we've been talking to the government. The reimbursement rates that you provide for the procedures, and now 50% of the payments is through the Ayushman. So your thoughts on how we can convince the government to increase that very, very important block of giving adequate rates for the procedures to make the hospitals viable, who then will also be more involved and wholeheartedly take part in the efforts of universal health care and also as subsequently for technology.
I think you have two questions. One is related to small hospitals not able to afford software. Second is on rates that we provide in Ayushman Bharat, right? So, see, the rates of Ayushman Bharat probably is not the focus of this conference, and we can have a chat on that separately, because, and you know, in every place, every conference I've gone to, I think that issue has come up about the rates. But you know, rates is such a sensitive issue that we finding a sweet spot always has been a challenge, because if the rates are too low, and obviously private sector doesn't have any incentive or motivation to participate, but if they're too high, then there's a lot of leakage from the scheme. And we've seen that, and I can give you an example that for total knee replacement in one state, the rates were about 50% more than what we had prescribed. And we found out that about 60% of total knee replacement in the countries were taking place in that province, that state. And they were, hospitals were coming up just for total knee replacement, and they were sending out recruits in neighboring states to get patients. So, of course, we had to reverse that. And one big problem with the rates is that we don't have data which is valid and is applicable for the whole country, because we have a big country, and here the rates and cost structure in different parts of the country are very different. So so it's a very, and I think NHA is evolving it, and they're changing rates, and in last 5 years, the rates have been changed, I think 4 or 5 times, and I think that process is still going on. On software, ABDM is going to be putting up reference applications which will be free and open source, so that everyone can use them. And of course, that happened for, say, UPI. Bheem was a government application, and then others came up. Similarly, that will happen in this also, where there will be free software available for all the hospitals who can't afford it, but of course private with better features will also be available. But Kiran, you can give some more.
Yeah, see, I think I don't really buy the fact that there's unaffordability of software even for the small sector, right? I think there is an adoption challenge. And today with the incentive scheme, I can share with you, sir, that there are many hospitals that we are seeing which are taking up to about 2 lakh rupees a month in incentives just because they're decided to participate in their linking records. And that's a lot of money from a digital perspective. And I think it is out there. So I think it's more about building the awareness and convincing your ecosystem of providers to actually come on board, because we think that the timing is right. And I think if we can create that momentum towards coming in, I think you will see the tsunami effect that we saw in UPI also happen in healthcare.
Yeah, thank you very much. You know, this has been an amazing session. I don't think it's a question of choice for us as a country. It's not a matter of choice for any one of us as healthcare providers. I think it is important for us to integrate. Every session we go to, we talk about how fragmented our industry is, and I think linking up this industry for a cause of healthcare at a national level is required. So I think we have our course charted out, I'm sure, while you're not directly starting, but thank you very much for initiating, and Karan, thank you. If you didn't know, Karan is a great example, being a telecom engineer, then he supported this, and I think he got so convinced that he is running a very successful eye care area, reaching up to block and village level, leveraging technology. So these are some good examples of how technology are coming up. I know there were some more questions, but this is the right time. The minister is here. We have had amazing conversations, and some of the questions that could not be answered on funding, etc., I think it's the right time for having our minister come up. So thank you very much, and appreciate. Thanks to the group here.
Thank you so much, the dignitaries on stage. Requesting you all to come forward and so that we can have a photo shoot. Well, with this, we conclude this first session of ours.
Ladies and gentlemen, we are about to inaugurate the conference with the auspicious lamp lighting ceremony. We would request the presence of our dignitaries onto the stage for the occasion. Requesting our chief guest, Honorable Minister of State, Dr. Jitendra Singh sir. Our guest of honor, Dr. Girdhar Gyani sir. The organizing chair, Dr. Arsh Mahajan. President KAO, Dr. Vijay Agarwal sir. Patron KAO, Dr. Alexander Thomas. And Secretary General KAO, Dr. Lalu Joseph madam. I'll request that we'll proceed. Sorry for the delay, and just getting the light for the lamp. I'll request all the dignitaries to please, for the lamp lighting, we'll have request all the presence of the dignitaries. Light brings brightness and prosperity, dispelling darkness and ignorance, and igniting of thought and enlightenment. We begin to see things clearly, opening our minds to new knowledge. I'm sure with this auspicious beginning, Cahotech 2023 would be a successful event for times to come.
With this beautiful inaugural, with the lamp lighting, we request the presence of Dr. Girdhar Gyani sir, who's our guest of honor. He's a founding member and patron, KAHO. He's currently the Director General of Association of Healthcare Providers in India, AHPI. Dr. Gyani introduced a number of measures integrating quality into the regulatory framework in the area of education, healthcare, environment, industry, and public services, which are known to have resulted in good governance practices. SME World magazine, in its cover story of June 2012 issue, described him as the quality man of India. Dr. Gyani has been instrumental in the formulation and operation of National Accreditation Board for Hospitals and Healthcare Providers, NABH.
We request our guest of honor, Dr. Girdhar Gyani, sir, to talk a few words on technology in healthcare and their challenges. Thank you, sir.
Namaskar. Honorable Dr. Jitendra Singh, my colleagues on the dais, ladies and gentlemen, it is my proud privilege to begin this inaugural session. I will like to say straightway one thing, that healthcare is now taking a central stage. In my lifetime, we have seen after independence, first 30 years, we were talking of roti, kapda, makan. Next 30 years, we were talking about bijli, sadak and pani. I think this is the time now, if you see, since last NDA government came, in 2014, it was in the manifesto that healthcare will be in the central stage. And rightly so, we saw in 2017 the new health policy. Normally, when policy comes, it takes few more years to talk about implementation. But right next year, 2018, we had the world's largest health insurance scheme, Ayushman Bharat. In fact, that same year, I was invited in Frankfurt, and they told me, speak only on this topic, how can a country like India can afford to have launched 500 million population? Anyway, so that was the curiosity, and which still remains world over. Now the issue here is that within next 2 years, we saw National Digital Health Mission, because we understand one thing, that the basic infrastructure still we have to match. We had less than 2 beds per 1,000 population, whereas the requirement minimum is 3.5 beds per 1,000 population. But sir, I would like to tell one more thing here, that number of beds is one issue. But more importantly, we in Caho and HPI have done this study, that we have seen big diversity in the number of beds per 1,000 population across India. So I only quote 2 figures. Karnataka has got 4.29 beds per 1,000 population, whereas Bihar has got only 0.3 beds per 1,000 population. And when I am talking Bihar, if I do the calculation for each district, some of the districts of Bihar will have 0.1, 0.15 beds per 1,000 population. I think this is the area we have to work. It may take some time, but that is where the technology is going to help us. And sir, I must tell you here that Caho is an organization which started in 2013 with a very small objective, that we wanted to bring accredited hospital to have networking among themselves and actually give feedback to our National Accreditation Board, NABH. But in this journey, I think we have covered miles and miles now. And now today, this is the body so vibrant, which is actually promoting quality and patient safety across the country and with the networking with the major countries over the globe. And sir, this particular event is the offshoot of Caho, what we call Cahotech, is specifically focused on use of technology. And this is the only platform, sir, where we bring all startups on one platform, and we have now the dictionary of these startups which can be utilized by the user, including the government. And we are, of course, closely working with the National Health Authority on National Digital Health Mission. So, sir, it is very proud privilege for us that you have come here, and all of us are eagerly awaiting to listen to you, sir. Thank you very much.
I will request the Cahotech Organizing Chair, Dr. Harsh Mahajan, sir, to kindly introduce our Chief Guest, Honorable Minister of State, Dr. Jitendra Singh, sir. Thanks.
Thank you. It's really a pleasure, privilege, and honor for me to have Dr. Jitendra Singh as our chief guest for Cahotech 2023, the 8th Cahotech conference. Thank you very much, sir. You very readily acceded to my request to come for this conference, and I can say that each and every one was so enthused by the fact that you would be coming here and gracing this occasion. We all know that Dr. Jitendra Singh is a doctor, an endocrinologist, a diabetologist of repute, and prior to taking up ministerial responsibilities, which are many, he was professor of diabetes and endocrinology and also the chairman for the National Scientific Committee on Diabetes and Research Society for the Study of Diabetes in India. So he has been a clinician treating patients while at the same time involved in research in the field of diabetes, and we all know India is the diabetic capital of the world. Sir is the Honorable Minister, independent charge for the Ministry of Science and Technology, where I've had occasion to interact with him on many occasions, and he again lends his experience and knowledge, and he has this ready ability to understand and then take steps for anything that is brought in front of him. He is also the Minister of State for the Prime Minister's Office, the PMO, Ministry of Personnel, Public Grievances and Pensions, and also the Department of Atomic Energy and the Department of Space. That's quite a handful of ministries, very, very important ministries, and it is because of the hard work that he puts in, his experience and his knowledge, that he is able to do justice to all of them. We all know he is from the BJP, from Jammu and Kashmir, and he has won twice the Udhampur seat in the Jammu general election in 2014 and 2019, and it is under his leadership that the dramatic changes in J&K that we've seen in the past few years are happening. Thank you very much for that, sir. The country will always be beholden to you for that. Now, he's also been a newspaper columnist, so that's something which many of us may not know. He used to write for the Kashmir Times and then switched to the daily Excelsior, which is the largest circulated newspaper of Jammu and Kashmir, and his weekly column, Tales of Travesty, used to feature in the editorial section of the newspaper until his election to the Lok Sabha in 2014. So the political gain actually was the newsreader's loss. I'll end by saying that he is a true friend of the healthcare ecosystem, of the healthcare industry, if I may say it so, and always giving a willing ear to listen to our problems and trying to find solutions. It's now an honor for me to invite Professor Dr. Jitendra Singh to come and address us and tell us about what he thinks of technology in this country and where it's going to go.
Thank you, Dr. Harsh Mahajan, for your very kind words of introduction. I'm not sure whether I deserve that, but regardless of whether I deserve or not, I think that proves that you are a very good friend. And so you spoke so well that I felt like trusting each word about myself. Dr. Gyani and all the friends seated on the dais, members of the faculty, delegates, ladies and gentlemen. In fact, it should I be who should be talking of some of the very pioneering works that have been done by Dr. Mahajan. And having been close witness to his kind of work and his work style over the years, I don't think there's any denial of the fact that he is virtually a pioneer in the specialty that he is dealing with, in the radio diagnosis and the diagnostic areas. And I think what is very appreciable is that he is continuously, constantly updating the facility that he is providing to the masses. And of course, that's quite a convenient milieu for practitioners who know that if there is some upgradation or some next level or next generation facility around, it would be quite confidently could be said that Dr. Mahajan would be able to provide it. So you don't have to hunt for it. And the rare quality about him is that in spite of being a very active and a busy practitioner, he has a very strong academic aptitude, which in a way I think is a reflection of the commitment that a medical professional can have towards the profession, because it doesn't have a compatible graph and growth once gets disconnected with the academics. And above all, his humor approach, which you saw in the manner he was so liberally praising me. And I think his influence on his friends is infectious. And one of the evidences of that is that I am standing there before you. Because right now I was to be in a flight to Bengaluru. Rather, I would have been alighting there. And there's a very important event happening. There's a convocation of the NAMS, the DNB. So I told them, I said, since I have already committed to Dr. Mahajan, so regardless of however important it could be, now you might have to do without me, or could you look for somebody, but they were kind enough. So nevertheless, they were kind enough to change over the timing to the evening hours. So having said that, I think I also need to compliment the organizers for holding an event like this, because as was being mentioned by Dr. Gyani, this is possibly one of the best times happening in India as far as the medical fraternity, the scientific fraternity as a whole is concerned. The nation mood is quite upbeat, and two of the very recent happenings, which are incidentally related to two of the departments led by me, have actually placed India as a frontline nation of the world. One of them, of course, is the Chandrayaan, which has proved to the world that which has established before the world that no longer is the time when India took leads from others. Now India is in a position to give lead to others. And the other countries are ready to be led by India. It's now up to us, how much are we ready to lead them. And as we've been taught as the students of medical science not to talk without evidence, I think the greatest evidence is that when we started our space journey, the then Soviet Union and the USA were already on the verge of landing a human being on the surface of moon, which they did actually in 1969, the first American, and we were still singing nursery rhymes. But yes, with the change in the prioritization and the change at the level of the policy planners, the quantum jump that has happened in the last few years has resulted in a position where, I was telling some of the American colleagues the other day, I said Neil Armstrong landed on the surface of the moon, had a stroll around, made that famous statement, small step for man, giant step for mankind, but he could see the presence of water around. It was our Chandrayaan which went and picked up the pictures. Which in other words means, to collaborate what Professor Gyani was saying, we had the talent, we had the acumen, we had the potential. We have seen those archive pictures, Sarabhai carrying a launcher on the carriage of bicycle, but we were devoid of resources. And we were devoid of the kind of milieu which could be compatible to the realization of our potential, the realization of our dreams. And that has happened now after Prime Minister Modi took over. And this has therefore also placed Prime Minister Modi as one of the tallest leaders of the world, particularly after the successful G20 happening, and the world recognizing that this is possibly one of the best G20 hosted by any other country. The other success story in the recent few years and few months, which is added credential to India's capability, again, as I said, the other department that I look after, the Department of Biotechnology, the vaccine story. Now, many of us, when we are talking of the manufacturing sector, the health sector, the instruments, and as is the theme today, healthcare accessibility, efficiency, and affordability, I know how many of us realize that we were never known as a nation very serious about preventive healthcare or protective healthcare. Leave aside the preventive, even the therapeutic we didn't know. If someone was sick, they waited for the turn of events, and they waited for the prognosis to lead them. So if they got well, it was mother's blessing. If they didn't get well, then it was Pishle Janam ka karam. So both ways, the prognostic outcomes were well taken, to the delight of the treating physician. So I have seen one of our professors who's no more, Professor Rivero from Lucknow, who is the cousin of Julius Rivero. He used to speak, Lucknowi Urdu and most of the time English. So a patient died, those days the patient would die with anesthesia itself. So they would distribute sweets if the patient recovered, because later on the boils apparatus and all this sophistication came. So patient died, and the attendants started running after him in the corridor. Sir, wo mar gaya, wo mar gaya. He was trying to pacify, he couldn't. Finally, the professor got worked up. He said, "Bhai, aap samajhta kyun nahi? Operation successful tha, patient mar gaya." So, kya hua? The point is that the very fact that we are discussing this subject is also a kind of a change in the thinking that has happened. There's a change in the mindset of the people. A country which was hardly known, not only at the government level, of course, the government under Prime Minister Modi has given a huge prioritization to this sector, but even at the social level, our priority was never health. And I think that also had certain, our economic constraints, our socio-economic shortcomings, because we could not afford to be, when you are talking of roti, kapda, makan, you can hardly talk of having a regular medicine. But now, having overcome that, the third generation post-independence, now is the time when the world is now accepting India as a leader in protective healthcare, in preventive healthcare, because we gave the first ever DNA vaccine to the world for vaccine. So I think that is a huge change of image that India today enjoys across the world, and that also gives Indian thought, Indian opinion, Indian view much acceptability across the sections of society, more so among the professionals. And therefore, when we talk of healthcare, as was being mentioned, I think it was the National Digital Health Mission which was being mentioned was announced by Prime Minister from the ramparts of the Red Fort during his Independence Day address. So in India, the Independence Day address of a Prime Minister is considered to be a declaration of intent, whichever the party in place. So you can understand what a huge prioritization was given soon after he came in. And that then, I think, reflected in the subsequent sequence of events. The government has walked the talk. You gave Ayushman Bharat, I think, one of the most fascinating insurance companies, because nowhere else you would be able to get insured for a pre-existing disease, which happens over here. Then for vaccine, we could succeed with the vaccine because a dedicated mission was started called Mission Suraksha. So as I said, the professionals were there, but that patronage was lacking. The cost effectiveness, and as was being mentioned, now the government itself is also on the same page as far as making healthcare affordable, accessible, and also self-reliant is concerned. We have rolled out a policy called Policy for Research and Innovation in Pharma, the new medical devices policy. We are among the 5 top manufacturers of healthcare instruments and devices. But our cost is much lesser. And again, I'm glad to say that I am associated with most of those institutes. For example, we have in Trivandrum the Chitra Institute, which is producing instruments which are going to the rest of the world, which is being lapped up because cost is just a fraction of the cost produced by the other 4 countries which are in that elite league of 5 top countries. And similarly, now as far as Dr. Harsh Mahajan's specialty is concerned, only on the 1st of August this year, we launched the first ever indigenous MRI scanner, and I think the Department of Science and Technology had funded it. But we realized that the demand will go on increasing because the same, when we were in the process of that, we realized that the future projection is that the demand for the MRI scanners will go double by 2030. And maybe we would also be in a position to export. So we have to increase the scale, but we are into it. At least we have initiated ourselves. Similarly, the another organ which is again part of my ministry, the Technology Development Board, collaborated with Panacea in producing the first ever linear accelerator called, which is given an Indian name, Siddharth 2. Very recently, in the last session of the Parliament itself, the Cosmetic Bill 2023, Drugs and Bill has been brought in order to reduce the regulations and also to allow online purchase and sale. I don't know whether you realize this government is the one which has done away with at least 1,600 to 2,000 rules which had become obsolete with the passage of time. Most of the governments take credit in having brought in this rule. Or most of the officials after superintending say, "Hamare time mein ye hua." Now this will be government will say, "Hamare time mein ye khatam hua," which included getting your certificates attested by a gazetted officer and so forth. So many, because they were, some of them were remnants of the colonial rule, some of them had some relevance in the last century, no longer relevant today. And therefore, we are into, yes, and our Pilani Institute, which is under CSIR, that's again something that I deal with, has also come out with very recently a technology for the oncologists, precisely hitting just 2 millimeters of the area or the tumor. So we are already into it in a big way. And now, of course, in the times to come, the artificial intelligence, etc., the projection is $50 billion by $50 billion economy in the area of medicine by 2030. But when I say we need to increase the scale, I think that is the real challenge. Dr. Gyani was very gyanful when he said that there is a lot of variation in the patient-to-bed ratio. And rightly so, because this is a heterogeneous country. So in a heterogeneous country, as heterogeneous as India, there are both advantages and disadvantages. Before you get disheartened by the disadvantages, which have been spelled out very rightly by him, I think the advantage is that you have a huge, huge resource pool. The other day, I had a group of medical researchers from, I think, Germany. They wanted to take up a project over here. They asked me what would I suggest them, which area. I said, don't ask me. You ask me what disease and I'll give you the disease. We have everything over here. So it's such a huge resource pool. And incidentally, I, like many of you, belong to the generation which has seen this transition happening. Soon after independence, more of the communicable disease, tuberculosis, etc., and many of us had our residentship postings in sanatoria. If you talk to the medico today about what is sanatorium, he'll be amazed about what age you are talking about, some ancient age. Then gradually we saw evolution happening somewhere in 1980s, going over to the metabolic disorders, the type 2 diabetes mellitus, the coronary, etc., etc. And somebody said, now this is the time when we are adopting the disease of the civilized, because earlier we were living in poor hygiene. So when we were more civilized, we became more, and then gradually the HIV hit us, and then COVID, so now we got back the same. So we are now democratized as far as, and even the spectrum of disease. Earlier on, type 2 diabetes mellitus was known to be a disease of more of the South India, more so of Tamil Nadu, as far as the Vellore is concerned. That's the reason the bypass surgery, when it happened in Vellore, was much celebrated. I remember Mrs. Gandhi had gone there. So I'm an Asian man, recall all those things. And the first ever department of diabetology in India was set up in Madras Medical College, somewhere in 1980, with Dr. Seshi as the head, because you didn't have much of it in North. Now it says, I did a paper in JAPI, which is titled Breakdown in Rural-Urban Divide. So there's a divide now, and that's where the lifestyles have become democratic. And you can't choose cultures in piecemeal. So you have to choose the same food which is being consumed everywhere. So you have to also, in the bargain, adopt the same diseases and same goods and bads about it. So now that is the challenge. How do you meet this? And this disadvantage, I think, can be overcome, and this is my considered view, only by an extended collaboration between the private and the public sector. The era of silos is over. If we have to move beyond where we are today, we have to have an extended collaboration. You can't leave everything to the government. Now, if you say Bihar has 0.5 per 1,000, Bihar till yesterday was known as a Bimaru Rajya. So it will continue to have that. Rajasthan may be better off. So unless we try to fill up these gaps by pooling of resources, and for that, I was telling yesterday also, we have to have more of trust. That skepticism which prevailed between the private and the public sector for many years. I was telling some of the corporate owners of the hospital yesterday, I said, for corporate, it was always thought that you go in and you come back with a stunt. So the urban patient overtreated, the rural patient undertreated. Now that is the answer to what you were saying, wide disparity of beds. If you have a small itch here, you walk into an urban good hospital, come back with 2 or 3 stunts. But if same thing happens in a village area, you might lose that golden hour and succumb to the cardiac episode or whatever. So if we are able to collaborate, have an extended collaboration, we'll be able to also uniformly, just as the disease spectrum has become uniform, we'll be able to. And therefore, and that has to be happening both at the level of our professional healthcare providing outlets, at the same time at the level of research and innovation. And I think what is heartening is that today when I say we are among the 5 top manufacturers, we are also the most cost effective. That gives us an advantage also, that we are not compromising on the quality or at the level of the generation. Now we are in the same generation. For example, soon we will be providing you quantum, which will be handy for Dr. Mahajan and many others in his area particularly. And also it has a huge lot of, even in curative treatments like malignancies, etc. So quantum technology is going to revolutionize. But why I am saying, giving the example of quantum is, that very recently India came out with Mission Quantum, India Mission Quantum. And we are now among the 7 countries of the world which are into that league. And we are at the same level, R&D level. We are yet to, make it fully applicable, even though in certain places, like for example, the latest Tata Satellite Hospital, which was opened in Mohali last year, we are virtually almost quantum, not because it's not quantum, but virtually almost. The radiation beam moves along with the lung, along with the gallbladder to hit the exact point. But when it comes to quantum, it's going to be a game changer altogether, both for the patient as well as the doctor who is treating. But when I say we are among the 7, now we have been given to comparative trials, cohort trials. I think the best evidence would be that earlier on, a technology would be adopted by us at least a decade later or half a decade later. It's no longer so. The most common example, the layman example, is that of television. Television was popular, very commonly prevalent in USA even in 1950s. I know how many of us are aware. In fact, the famous 1960 election of USA was determined by a television debate when Richard Nixon lost to Kennedy and the turns tabled. Over here, we didn't know what is TV and how does the debate happen on TV. It came here somewhere in 1970, a weekly Chitrahar in Delhi and other places still not. South, we had this first test match, I think somewhere in 1975 or so in Chepak, Madras. They created a special slot. So we were almost a decade and a half behind. Same way computers. But here, if they are into quantum, we are into quantum. We are among the 7 countries, the others are still yet to take it. So we are at par even in our armamentorium, and that gives us an advantage, which means that knowledge-wise, technologically, we are at par. At the same time, we have also mastered and shown the world the skill of being cost-effective, because that's in our genes. The Chandrayaan cost us 600 crore, and the simultaneous lunar mission which failed was 12,000 crore. Why? Because we were strategizing. We have learned the strategies of being cost-effective. We were taking use of the gravitational forces. So we went round. Earth gradually came out. Then we went around the moon, took 20 circles closely, came in. It was just like putting your vehicle on the neutral and saving on the fuel. So we cost only 600, where the other one went like a bullet train. So same way, even in manufacturing sector we have, and now we are also going to have a biomanufacturing policy, which is again going to be also partly related to my department. And therefore I think as we move on, the question now would be the vision for the next 20, 30 years. It's very difficult to visualize. I mean, things are not only moving continuously, moving at a faster rate. What you think would happen next morning before you go to bed would have already happened in the midnight. It actually did happen once when the Chandrayaan was about to move out of the Earth's orbit. It didn't move out till about 12 o'clock in the night. I thought now it will happen only by early morning. I went to sleep, it happened just after the midnight. But same way, the pace has increased. So it's become very difficult actually to visualize. And as a common human mind, we tend to visualize 25 years from now, as Prime Minister keeps saying 2047. But we tend to visualize 2047 through the prism of 2023. Because we don't know what things would be like that. So we are looking at it from today's context, sitting in this room. I don't know whether we will be at all sitting. We will be required to sit at all. Now, if again, as a scientific brain, if you want to analyze what it is, go back 25 years. From 2023, go back to 1998. So what was new in 1998? For example, one was that video cassette, VCR, a favorite item for a dowry. The dowry would be incomplete without that. Where is that VCR now? You give somebody in dowry, he'll throw it back on your face. And what was new in 1998? Because we, as scientists, we have learned to, understand things through these procedures. The other common example was that of an STD booth. And in front of the houses of the politicians, you find queues of people coming in, sab, एक STD booth दिलवा दीजिए, बेटे की जिंदगी बन जाएगी. और जब तक बेटा बड़ा हुआ, STD booth बंद. So, that is why I have set up a team to work out the indices for 2047. Because we are still doing merely talking by imagination, by fascination, but we don't have any solid. So if we have solid indices for 2047, because a huge lot of things going to, because so much of, and the artificial intelligence taking over in such a big way, that we'll have to find out means of having human interface rather than artificial. Because I am, quite progressive in all these futuristic technologies, which are the first in government to have used face recognition technology for old pensioners. Just look into your camera in the mobile, within 60 seconds, the certificate with the verification of Aadhaar reaches the bank. So similarly, I was the first to put the grievance totally online. As a result, 98% disposal. But then I told the officers, I said, disposal is 98%, but the complainant is not happy. And in West these days, you talk of something like happiness index. So why I'm saying is, about 7-8 months back, I set up a human desk, got a place in Noida. After every complaint is disposed of, a human being calls up the complainant to counsel or to talk or to tell him about the options, because the complainant feels that once his complaint is lodged, suppose I want a promotion, if I lodge a complaint, I'll get promoted. It doesn't happen that way. My responsibility is to dispose it off in 5 days time, and in 5 days time I get the department's answer which says no, he was not eligible, he's yet to qualify. But that doesn't make him happy. So I think we'll also have to then find means of drawing an optimum balance, whether we would require it at all. The telemedicine has shown it. I'm doing this experiment, one of the first among the members of parliament. I have a doctor on wheels, telemedicine, which runs in the remote test areas. We just have 3 youngsters handling it. A boy from Bengaluru, a boy from Gujarat, and a girl from Hyderabad. All in their early 30s, non-medicos. In 40 minutes, they get you the best of the treatment, put your profile on the thing. They have connected with 3 hospitals, one in Ahmedabad, one in Bengaluru. They get connected to the neurology, cardiology, endocrinology, whatever. Within 40-50 minutes, they give you the thing. And it's a huge health startup area. Of course, we are doing it out of philanthropy. So this is going to be the challenges which we can't see. But one challenge which would remain persistent is that our lifespan is going to be biphasic. So we are, on the one hand, more than 70% below the age of 40. On the other hand, the elders are also still continuing to live. So plus 60 as a whole is also on the increase. And when we talk of India being a country of the young, obviously we are going to be the biggest resource pool, youth resource pool. So we can't afford to squander our youth energy, which is meant to be utilized in nation building and the century India of 2047. So then it will be preserving the health, because now I think the challenge is the occurrence of the diseases of the middle age in the young. Type 2 diabetes mellitus is no longer a disease of the middle age. It's now happening in the early 30s also, even late 20s. So many patients we have. Earlier on, if you saw a patient in his 20s, you simply put him on insulin, assuming that it was a juvenile or type, but it's no longer so. So is the case with the young heart attacks. And therefore, the prevention, so that if you want to preserve their energies for the task of nation building, it's no longer only going to be the responsibility of the health professionals, but also a national responsibility. So ladies and gentlemen, I think the matter of pride for all of us is that when we discuss and plan the strategies as health providers, which is health providers who are efficient, who are accessible, who are affordable, we are no longer only serving the cause of medicine or the profession of health, we are actually discharging a national responsibility for the years to come. Thank you.
Thank you, sir, for the gems of wisdoms that you have provided. I'll request President Kao to present a memento to Honorable Minister of State, Dr. Jitendra Singh. It's a token of appreciation for your presence, sir, on behalf of the team from Caho. One more. Yeah.
Would like to request Dr. Alexander Thomas, sir, to present the plaque and the memento to Dr. Girdhar Gyani, sir.
Dr. Girdhar Gyani, sir, is our patron as well as
The
guest of honor for the occasion. Thank you, sir. I'll request all the dignitaries on dais for one last photo op before we conclude the session. One last photo op.
All dignitaries can come to the front.
We'll conclude this session and we'll move on to the next session on artificial intelligence. For that, we'll request the presence of our other pair of co-hosts who will be taking the program further. Dr. Rima Bari and Dr. Dhruv Chakravarti. Over to you.
Round of applause to them for starting off. Thank you. Take over.
Thank you. Very good afternoon, everyone. After the wonderful, exciting, enlightening sessions, we are here for the next session, Artificial Intelligence, a Game Changer or Hype. And I'd like to introduce my co-host, Dr. Dhruv Chakravarti from Andhra Pradesh. He represents Caho as State Chairman of Andhra Pradesh.
Thank you, Dr. Rima. My co-host, Dr. Rima, represents the Diagnostic Division of Cahotech North Zone, and she's also Director, Laboratory and Hospital Quality at RK Healthcare, Gurgaon. Right. Now, continuing to our second session, I request Dr. Vidur Mahajan, Chief Executive Officer of CarPL.ai, to come onto the stage, please. Yeah, Dr. Vidur Mahajan is the CEO of CarPL.ai with more than 60 partners. CarPL.ai is one of the world's first end-to-end platform for testing and deployment of medical imaging in artificial intelligence solutions. Dr. Vidur Mahajan also led Mahajan Imaging, India's leading radiology chain earlier. He is an MBA with dual majors in finance and healthcare management from the Wharton School of Business and studied medicine from Sion Hospital in Mumbai. I request Dr. Vidur Mahajan to take the role of the moderator of this session.
Thank you. Our panelists, I would request to come on the stage as I give their names. Dr. Arun Kumar Govindarajan, please come on the stage. Yeah. Clap, please. Yeah. He's Executive Director, Radiologist, Aarti Scans and Labs, Chennai. He also takes care of IT and marketing aspects of his family business. Our next panelist is Mr. Arnab Pal. Kindly come on the stage, please. Yeah. Welcome. He is Associate Director, William J. Clinton Foundation, leading the infectious disease portfolio in India. He has experience in supporting public health programs and introduced innovative products and solutions. He led market strategy for a pharmaceutical company and worked as a management consultant also prior to this. Our next panelist is Dr. Kritika Rangarajan. Kindly come on the stage. Thank you. She's Associate Professor Oncoradiology, IRCH AIIMS Delhi. As a radiologist and researcher in data science, her vision is to leverage the power of data science to make the practice of medicine more humane. Her research has been focused on one of the hand to exploring how AI can help bring healthcare to underserved areas, and on the other hand to facilitate doctor-patient interaction to restore the human touch to healing. That's really nice. She's fellow in Medical Applied Research and Practice by French Embassy in India, successfully run several grants in aid towards development of fully open source AI networks for public health problems. She's also editorial review fellowship from European Radiology and one of the top 10 candidates selected worldwide.
Thank you all for being on the stage. I request Dr. Vidur Mahajan to take over the session.
Thank you so much, and thank you to the panelists, thank you to the organizers for giving me this opportunity. There is additional pressure on me today because there's a bunch of people from my team who are here, and I have oversold myself to them. So, whenever I raise my hand, tum tali baja dena yaar, so that it seems like there's something so nice. So, we'll try to make this session a little lively and active, and, it's possibly one of the more controversial sessions today. I thought, before, and we have about, I think, 50 minutes, and probably I am stopping everyone from lunch, so that's even more pressure. What we'll do is we'll do a discussion for about 30 minutes or so. If anybody has any pressing questions during the discussion, please again feel free to raise your hands. Taali nahi baji yaar, kya ho gaya? So yeah, so feel free to raise your hands and interrupt and just ask. Again, the idea is to make it as interactive and as useful for everyone as possible. We'll do about half an hour of discussion and follow it up with about 20 minutes of questions from the audience. I think before jumping in, I'll maybe set some perspective for what it is that we're going to be talking about today. So the first is obviously AI is now. So who here has used AI? Bus. Who here has used Google Maps? Who here has used Google Search? So everybody has used AI, right? So essentially, when we think about what is AI, there is this thing called the Tesler's theorem, which basically says that AI is whatever machines can't do yet. Right? It's a very insightful thing. It's basically, AI is a moving target, right? If you go back to the year 1954, when the term AI was coined, right, and you show up with a calculator, apna normal, that accounting wala calculator, and you say ki, I can do the cube root of 725 till 7 decimal places in half a second. That would be the epitome of intelligence. That would be like, AI to another degree. Today, we consider that just math, right? We don't even think of it as being a component of intelligence, right? Similarly, how Google Maps, Google Search, we don't even think of them as, AI. Like many people in this room did not consider those technologies to be AI. So I find it very interesting that 10 years from today, there will be another panel discussion happening, and we'll still be talking about the challenges of adopting AI and, so many things, but we would have, been hopefully made some strides in the subject. So I also wanted to touch a little on what is so cool about AI today, right? If it's such a moving target, why is it becoming so interesting today? There's two reasons, right? One is just, these cell phones have, till 5 years ago, I used to say 1 million times more. Now they have 10 million times more compute than the computers that sent Apollo 11 to the moon, right? The mission Sir was also talking about. So one is just democratization of compute power. The second is democratization of AI itself. Like deep learning, anybody can today do, right? Deep learning is the process where you throw a lot of data at a computer and the computer itself figures out patterns in that data. You don't need to explicitly program the computer to figure out those patterns. If you're making a computer learn how to recognize digits, 0, 1, 2, 3, 4, 5, in the earlier days, you would have to explain to the computer what 0 looks like, right? You would literally have to say that, it's a circle, but then it can be oval, then it can be thoda mota, then it can be thoda patla, and, that's how you recognize 0. Today, you just throw 10,000 examples of how you write 0, and the system itself figures out what 0 is. So that's the power of AI today. As long as you have the data, as long as you have the compute, you can start building AI, and that is why we're seeing so much of it all around our world. Going a little bit deeper into what we'll be talking about today, I have this framework where I think of AI in two realms. There is administrative AI and there is clinical AI. Right. Administrative AI is applications of AI which support in our world, right, of healthcare, in patient scheduling. Dear sir, as we are short of time, request you to conclude in 30 minutes. Chalo, perfect. So yes, so we have till around 1 p.m. So the idea is that administrative AI is the application of AI in administrative tasks, in non-clinical tasks, billing, scheduling, discharge, OPD appointment setting, even transcription, ambient AI, where you're, taking the conversation between the doctor and the patient, putting it into a prescription. All of those things, in my opinion, fall into this domain of administrative AI. We also think of it as relatively low implication AI. The converse side is clinical AI, where you've got AI making decisions, or AI assisting in making decisions to the extent that it can change the decision of the doctor, the clinical decision, right? Which are things like diagnostics, where we see most AI today. We'll talk a lot about it. AI is helping you figure out whether somebody has cancer or not. Huge implications, right, of the AI going wrong. In therapeutics, what drug to give, what drug will have what outcome. Also things like, I see more of my teammates walking, putting in more pressure on me. So, but essentially, clinical AI is AI where if the AI goes wrong, there are clinical implications, right? And today we will focus much of our discussion on clinical AI as we go through the next 25 odd minutes. So with that laid out, I'll start by asking Kritika. So I've known Kritika since I was a kid. Had the privilege of working with her briefly. She's one of probably the smartest person I know. She has a PhD in AI also, by the way, apart from being a radiologist at AIMS. And so she's dedicated her life to AI. Why, Kritika?
Yeah, okay. So to begin with, thank you, Vidur. I think that's some very kind words. But to answer your question, I think I think perhaps all of us see potential. When you spoke about, do you use Google Maps? That's everybody, that's all of us using AI every single day in our life. And we've all experienced how it's changed our lives. We don't look for photographs, we don't file them anymore. We just write the name of the person and it finds it, right? So we have this opportunity, we're at this point where we can imagine, we can reimagine the way medicine is practiced. We can imagine what all we can do that we could not previously do. So I think that provides a really huge opportunity, and it's for people like us, all of us sitting here, to use that opportunity to do something worthwhile, and I think we can really make a difference to everybody's lives by doing that.
So do you recommend that like every radiologist should start doing AI?
So doing AI, should you start building AI? Maybe not. But should you start using AI? I think absolutely. I don't think there's a way without using AI in today's day. At some point, you're probably already using it. Your machine at the back end is probably already using it to reconstruct your images, and you probably don't know about it. But it's important to know about it, just the way we know about MR artifacts. If you don't know where AI can go wrong, you'll probably make a wrong clinical decision, or you'll probably be outsmarted by somebody else who does use AI. So absolutely, I think everybody does need to start using AI and understanding AI at the very minimum.
So it gives a lot of confidence, right? When you see like some of the, if I may say it again, and it's a fact, not opinion, the smartest people in the world, focusing their entire lives on building something, it has impact. And we've got Arun with us. Arun runs RT scans. RT scans, I think, in terms of at least install base, is probably the biggest imaging provider in India. Arun, what AI have you been using? What's your experience? Why do you use it? Yeah, some cool stories would be nice.
Thank you, Vidur. As Kritika said, we use AI because we want to be at the forefront of technology, and we don't want to miss findings, and we find value in AI. So that's all the reasons I would cite. At present, we use close to, we validate plus use close to 7 AI tools in our radiology and pathology practice. Do you want me to tell? Yeah, sure. Okay. So we use, for chest X-ray, we use Cure's AI tool as a pre-read before the radiologist goes through the image. So it sort of works as a co-pilot for the radiologists. Less findings, less missed findings by the radiologist, quick to report normal findings, normal X-rays, that's the use case. And for chest CT, we use Siemens Healthineers AI, which gives findings like calcium scoring, aortic aneurysm screening, and emphysema scoring, which are probably not quantifications which would radiologists would not want to do. And for MRI brain, we use NeuroShield as well as Siemens AI for quantification of close to 50, 60 parameters or volumes in brain parenchyma. For CT brain, mainly for triaging of fractures and stroke, hemorrhage, we use once again Q's AI. It helps us in triaging as well as informing the reports quickly to the clinician. So before the patient comes out of the gantry, we get the report and pass it on as a preliminary report to the clinician.
So Arun, how do you, like you're using, as you said, 7 different AI systems. How do you ensure things like safety and efficacy? Are there mechanisms in place to ensure that, if the AI makes a mistake, does the AI make a mistake ever? And if it does, then how do you deal with it? Like, how do you think about that whole side of things?
Does the AI make a mistake? It's not a question of ever. It's on a daily basis, it makes mistakes. That's why we let the radiologist take the final call. When there is a disparity between the AI reports and radiologist finding, we take the radiologist make the final call. That's how we try to avoid mistakes. As far as security is concerned, our PACS provider helped us a lot. So what we do is we built a layer on top of our PACS where we anonymize the images and send it to the AI provider's cloud. And when we get back the images, we de-anonymize them, and send it back to the clinician or the radiologist.
And clinician adoption is, how do clinicians think? Because, apart from radiologists, radiology affects the entire clinical ecosystems. How do clinicians think about AI?
So our radiologists, at least the
I mean like the referring clinicians, like non-radiologist doctors.
We sort of designed a system to make AI stay in the background. It's not visible to the clinician, but we send reports to them. We send preliminary reports to them. They may not know it is processed through AI. AI sits in the background, but as frictionless as possible.
Oh, very cool, yeah. So invisible AI, essentially. No, it's truly truly amazing. I'm a big fan of the work you guys do. Arnab, I'm sure many people may be wondering, what Chai is up to in AI. Could you share with us like some of your experiences where you're using AI and what you've seen?
Sure. Thanks, Vidur. So, Chai as an organization is a not-profit. So, we are trying to use AI from a public health perspective, and how can we actually leverage these technologies to help frontline workers, improve screening of diseases, better triaging of different diseases. So specifically, we've been working a lot on tuberculosis and how can you, using X-ray with an AI solution to increase screening for TB at a community level. As many of you would know, access to X-rays at the community level is fairly low. I mean, in cities, it's obviously everywhere, but if you go to remote areas, you don't get access to X-rays very easily. And obviously, there's a significant shortage of radiologists as well, not just in the public health system, but generally overall as well. So I think that's where we are looking at how do you deploy these solutions at the community level, so that imagine the situation, a handheld X-ray machine goes to a village in somewhere in Tamil Nadu, screens anyone who's at high risk of TB. The AI solutions right there, which immediately gives a score or a risk profile for that patient. And then the community health worker can immediately make a decision of triaging that patient to, let's say, for confirmatory test, or referring the patient to a medical officer for further treatment or diagnosis. So that's how we've been using it. So till date, we've deployed over 10 such machines, both as mobile diagnostic units, as well as handheld machines in Tamil Nadu and Delhi. We have close to another 200 odd machines which are in the process of being deployment over the next year or so. We've seen actually fairly good results. I mean, we've also done some validation of these, of the AI solutions, compared them with radiologists. So we are seeing that the performance of a lot of these AI solutions is actually better than a radiologist. So you're missing out on less number of cases. You're obviously ensuring early diagnosis, and then obviously that's helping us in reducing some of the TB, the burden of diseases in these settings.
That's fantastic. And so you mentioned Delhi also. Can you share where in Delhi it's?
Yeah, so we've deployed 3 machines in the urban slums. So one in Jahangirpuri, one in Sangam Vihar, and one in Badurpur. These are obviously, large urban slums have huge burden of not just TB but other chest infections diseases as well. So these AI solutions not just identify TB abnormalities but also any chest abnormalities. So I think we've been able to kind of identify close to 500 odd patients over the last 18 months in Delhi itself in these 3 sites.
That's amazing. So essentially, if anybody here is interested, they can probably go to, so it would be in the community health center?
In the primary health center, yes.
The PHC in these areas and see the thing in action. Right? Because there's a lot of, doubt around whether AI is even being used and, where it's being used. So one of my intents was to bring out real world, users. I have a question for you, Kritika, and we briefly touched on this in our conversation. So you did your PhD from IIT Delhi. You worked there for a while, with some of the smartest engineers in the country. And I'm sure there's a lot of engineers here, a lot of tech people here who are interested in AI. As a clinician who is now doing AI and has worked with engineers, what would be your, 2 cents of advice to these people?
Yeah, I think that's a great question, because very often I see engineers tend to focus on the perceived need, which may not really be the real need in healthcare. So healthcare is sufficiently complex, and I don't think you can judge a problem too well with a Google search. I mean, is it really a problem on ground? Even PubMed, majority of the articles, you can talk to majority of...
ChatGPT would have the answer.
I mean, that's an interesting sort of take. We could explore that, but on a serious note, I think it's very important to sit with clinicians and understand whether what you perceive as a problem is really a problem in the clinical spectrum. It's all too often that we see products which are already developed, ready to be commercialized, but don't really add too much value clinically. So what would you do? So it's 101 of biodesign, right? Go from problem to solution and not the other way. Don't try to design a solution and try to find a problem that it might solve. And also that how an engineer thinks about a problem is very fundamentally different from how a doctor thinks about the problem. And that I've seen every day. Even after you identify the problem, once you get inside the problem, don't think of it as, let me begin this project, I'll speak to a bunch of doctors, see if it makes sense, and then start developing it myself. I think it needs constant collaboration all through the process, because often you kind of tend to get lost. I've seen people who are developing liver segmentation problems without, segmenting the right and left lobe, which is probably the first thing you would do. So it was a good problem that was identified to begin with, which is you want to segment the liver, you want to do a volumetry. But then if you sort of start doing this on your own, you won't know, how to stitch it in a way that it can be used clinically. And then further for deployment, so unless you know the workflow, you won't know how to deploy it in a way that it actually adds value to the clinical practice. So it has to be a team, and there has to be somebody who uses it involved at every stage in the development rather than just at the beginning or just at the end.
That's amazing. So we have at least one clinician here that is probably open to collaborating with folks building this stuff. I'll take a pause now for questions from the audience. We have about 10 minutes left. Any question? Because I can keep asking these guys all day long. Any questions? No questions. Perfect. So Arun, what does the buying process look like? Like, how do you decide what AI to buy, what to implement? Do you validate them first? Do you validate on the fly? Like, how do you think about that?
So, as far as radiology AI is considered, there are a lot of AI products out there. So, we get a lot of incoming inquiries, incoming brochures to see. So what we do is, initially before even validating the product, we try to see how we can put it into clinical use, whether it would be beneficial, whether it's adding value. It can be clinical value, marketing value, or throughput value. It could be anything.
Could you give an example of marketing value?
Okay, so we use AI for CTKUB, which is kidney and urinary bladders. So it gives a nice, in plain studies, it gives a nice 3D view of the kidneys. Basically, it gives a CT urogram from a plain study. So since none of our competitors have it, it would make a good, compelling marketing activity, yeah.
Very good, very good. Sorry, continue, yes.
So we try to see the value in it and then try to validate it through a few demo cases whereby they deploy the solution in our premises and we send the images and I validate it personally, then the commercial bit of it, and then we deploy it in our platform.
So it's basically like buying any software, which is that you have to maybe validate it clinically. Is it like interviewing a doctor? Like, do you think of it like that?
Personally, don't interview many doctors.
Okay. Great. So essentially, you have got to this point by looking at various AI solutions, testing them out, and then finally deploying them. But the value piece is important, right?
Integration, I would say, is also very important nowadays because every AI company follows different standards. Although the DICOM standards have been there for a long time and standardized, many AI companies still want the radiologist to go to their portals and check their reports, which will never happen in this lifetime. So they need to send the output in a structured DICOM SR or DICOM PDF files to us so that, once again, the AI becomes frictionless and invisible to the radiologist as well.
No, great. So, I don't want to make this just a radiology AI discussion. So, Arnab, we talked about other AI applications that Chai is looking at, and in general also, I'm sure you come across a lot of these. Could you share some of those and the impact they're making?
Sure, I think there's a lot of work which is happening in AI. So, there are the LLMs, large language models, which are available. ChatGPT obviously is the most well-known one, which has multiple applications. But if I talk about just from a clinical perspective, again, I think some of the areas where we are interested in and we are focusing on is one is on cervical cancer screening. Again, I think usually cervical cancer screening can be done at a community level, but a real challenge is how do you interpret the result, whether the nodes are cancerous and whether any treatment can be done. So I think there can be, we are working on some solutions which can do image processing and use AI to actually help the community worker, the staff nurse actually identify precancerous lesions and then obviously initiate appropriate treatment. A very basic problem at the community level is also interpreting rapid diagnostic tests like a malaria test or a pregnancy test, right? I mean, sometimes those lines are not visible. Is it a positive? Is it a negative? Is not very clear. And many of you all might have actually, how many of you have done a COVID antigen test, a self-test, home test? So all of you might have uploaded the result on the app which was provided. So that was also an AI-based solution. So similar solutions can be used for other RDT tests, other point-of-care diagnostic tests as well. So we're trying to kind of work with solution providers to kind of test and deploy them at scale as well. So again, I think our focus is a lot more at the community level. Obviously, at a higher facility, tertiary care facilities, I think there are more advanced solutions, which I think Kritika and Arun are better placed to talk about. But I think these are things which we are fairly interested in at this point of time.
Very interesting. So you feel that like 5 years from today, most screening would be AI based?
That's a good question. So I think our experience is that adoption at the ground level is not that easy. I mean, we might be very excited about these things and feel these work, but I think it also is about how do you build confidence of the community workers, the medical officers, the communities that this actually works. For example, the work which I mentioned in TB in Delhi, the medical officers were still, they all want a hard copy of the report of the X-ray. We said, we'll send a soft copy, we have the interpretation, we have everything done, but there's still they want the hard copy. Patients also want the hard copy. So I think there is some skepticism and fear also as well, I would say, in the community around these solutions. How do they operate? How well are they? How accurate are they? So it's a process. I think as I'm sure there will be a significant scale up of these solutions, but at the same time, I think people need to get comfortable with them and start trusting them. Like Google Maps, maybe 15 years back, we might have used Google Maps for reference, but we would still maybe stop and ask someone. But at this point of time, we blindly trust whatever Google Maps says. So I think it's an evolution process which I see with AI in healthcare as well.
Very interesting. So it's not just a tech problem, it's a human problem as well. Again, I'll pause. Any questions? Yes.
Yeah. My name is Arjun, and I've actually graduated from a mathematics degree, and I'm also going to be a clinician next year because I'm just graduating medicine as well. And Kritika just said that people with technical backgrounds and clinicians usually think about problems in very different ways. What advice would you give for someone who's got both the backgrounds trying to get into the space to create a startup?
I think that's perfect. I mean, I think you're perfectly poised for that. It's not often that we come across people who've done, both in sufficient degree of depth. But since you are, I think that makes you one of the best people to sort of get into the space.
But I mean, like, how would someone like that think about the problems? Like, what kind of advantages would they have, and how should I take advantage of that position?
I think if I might just add, it's a very privileged position to be in, to start with. Of course, it comes with significant risk because, you can be stuck between two places. But the first thing to do is talk to your clinical colleagues, right? The tech exists. I think today, building of AI is kind of a solved problem, and, if you know the math behind it, you'll be better. But spend time in hospitals. I don't know, as a med student, how deep you are able to go into specific problems. But spend time in the hospitals and pick a problem that is a very large solvable problem to begin with, or pick something that is very niche but has very high impact, right? So those are the basic frameworks. Just spend time and talk to people and ask them their pain points. And then try to narrow down on a single one. I think that's, I guess hard work is the answer.
Thank you.
Thanks. Yes, yes.
Gautam, and I'm from, we are from HCL Healthcare. Just after hearing this topics that were discussed, one point comes up to my mind from the last session, where the minister, he mentioned that we are developing the first indigenous MRI, probably 18 years back when I was in the radiology lab. I was thinking, when will India make it? So we have come that far now. Now thinking about the basic thing about going in terms of studying a treatment, the prescription part, the moment the doctor is prescribing, how would the AI help in enabling the doctor to, in terms of getting the right drug being prescribed, and at the same time, that's one end of the spectrum. The other end of the spectrum, when the radiologist who is sitting in front of the machine and the technician who is using the machine, how they are getting enabled by AI, the speed of diagnosis that's getting shortened, that's one aspect, I'm sure. But what else, like, what do you see that we are going into in the future? How we can integrate these aspects to make the speed to diagnostics the fastest possible way, so the treatment can start where it matters.
Sure. So I think there's, in the interest of time, two aspects to the question. Maybe Kritika, if you could take the first one, which is, doctor prescribing a drug, how do you know it's correct? And then maybe Arun, if you could take the second on, what is happening to speed up diagnosis in radiology.
Yeah, so I'll actually go slightly tangential to that because it's kind of related. But for example, I saw, since there are a lot of administrative people here, I saw an advertisement for a hospital. This was not in India. But interestingly, it said, look, we don't have EMRs. It was an advertisement to recruit doctors. And we all know how much we hate sitting down in front of computers and actually having to type it out. So what if you can have a conversation with the patient and AI actually captures the whole thing and makes it a prescription? So I think apart from just the accuracy which we've all spoken about, there's a lot to do with smoothing out the process, making it more humane, allowing conversations with patients, which I think the sky is the limit. We all have to figure out what possible applications there can be. if that answers your question.
As far as the impact in throughput, I would say, just an example is we were reporting close to 900 to 1,200 X-rays per day, chest X-rays per day, and we had around 9 to 10 radiologists purely reporting chest X-rays. Post implementation of AI, since the reading time got less, we were able to complete the similar caseloads with just 7.5 radiologists on the same day. So there was definitely obvious use case there. And obviously the misfindings became less.
Hello.
Yes, ma'am. Yes.
I'm Dr. Namrata from AIMS, Delhi. Actually, AI is a very important topic we know, and future is AI, everyone tells. But as soon as we think about AI, and in our informal discussions, we always talk that AI will replace manpower. Our jobs will be taken. So what is your take on that? And as far as, informal discussions, dermatology and radiology is the first branch who will be taken up by AI. So what is your take on that?
Offline, yeah.
Yeah, or maybe we could just do 15 seconds from each of the panelists on will AI replace doctors?
So I think the difference between humans and AI is really our ability to improvise. And the last slide of my presentations have always been a sketch of a Ganeshji versus a real picture of a Ganeshji. And my 5-year-old daughter always, the first time she saw the sketch, she knew it was Ganeshji. Whereas for AI, you'll have to retrain it to really, learn what sketches look like before it can recognize Ganeshji. So I think it's all about how we can actually improvise, and I don't think that's happening from that perspective.
Arnab, quick 15 seconds on that.
I just feel there's such a huge shortage of healthcare workers in the country, radiologists, specialists especially. I think AI just empowers and enables us to scale up access, which currently is not available. So I don't see it's replacing, it's augmenting the capacity which is currently available in the country.
Awesome. Arun?
So AI is still at the calculator stage, whereas the human radiologist is at the supercomputer stage, I would say. So at present, there's no way AI is replacing radiologists. I'd be happy if it does, since because there is a lot of shortage of radiologists, but at present, no.
Correct. So I think that's a cool concluding point, that AI will probably make doctors 10x more effective. Sorry, we'll take questions, we can do offline, like I'm getting many
We can have
requests,
offline questions.
But yeah, so AI is not replacing but augmenting, but exponentially augmenting is my challenge to developers of AI. And on that happy note, thank you so much, everyone. Thank you.
Yeah. Thank you, Dr. Vidur, Dr. Arun Kumar, Mr. Arnab, and Dr. Kritika Rajaran for the session. Still, as a suspense, AI is a game changer or a hype. It's still a suspense for us still. Yet to go ahead in this, okay? Let's have a photograph, please.
Thank you so much. And now we move on to our next session, Technology Disrupting Healthcare Administration. And it's my proud privilege to call upon the stage, moderator for this session, Air Marshal Dr. Pawan Kapoor. My apologies, sir. So he needs no introduction, but I would like to give a brief one here. He's Patron Kaho, former Director General Military Services, Indian Air Force, Chairman Steering Committee, NABH. He has more than 40 years of experience in quality in healthcare and was one of the founding members of NABH in our country. Former Head of the Department of Hospital Administration, AFMC Pune, awarded with his Order of Royal Emblem by Sultan of Oman, Chief of Army Staff Condemnation thrice, Vishesh Seva Medal thrice, Ati Vishesh Seva Medal, also Lifetime Achievement Awardee by Kaho, and you'll be happy to know that he was former honorary surgeon to President of India. Thank you so much for being the moderator for us.
I also request the other moderator, Dr. Nagendra Swamiji, to come onto the stage. Dr. Nagendra Swami has over 30 years of experience in healthcare management with national and international organizations as a board member and a part of the top management. He was the former group medical director and chairman of the Quality Council at Manipal Health Sciences. He holds an MBBS and MD degree in hospital administration. He is associated in various senior roles with multiple medical colleges in the state. Dr. Swami is the principal coordinator of the Federation of Healthcare Associations, Karnataka. He is the present patron of the Cahotech and also founder of Medisync Health Management Services. Sir, I now request you to invite the panelists.
Good afternoon, everyone. I think it is just before lunchtime, so we'll keep the sessions short and sweet. And to do that, we have, I have with me my co-chairperson here, who you already been introduced to. We'll introduce the topic. 1 more minute, we'll take each of us to share our perspectives about the disruption of healthcare by way of technology. And after that, we'll invite our two main speakers for the day. I request them to be here, Mr. Chandrasekhar and Mr. Kaustav.
Yeah. Mr. Chandrasekhar Sibal, sir. Kaustav Priya, ma'am.
Please be here. We all know that technology has a very large impact on clinical decision making, and we have been discussing it since yesterday. This session is focused on administration. Now we all know that the role of any hospital is to provide the right care to the right patient at the right time. And to do that, everyone has to do two things. One is to identify and evaluate the patient correctly, and the second is to manage the hospital resources effectively. The first part, that is to identify and evaluate the patient correctly, the healthcare providers are trained to do that, and technology is a supplement and complement to assist them in identifying and evaluating patients correctly. Whereas most of the healthcare providers face the challenge of managing the healthcare resources efficiently and effectively. And toward this end, this session is going to address some issues related to hospital resource management, how they can be utilized through the use of technology more efficiently and effectively. So that will be the purpose of this session. With a brief period of time, we have with us only 25 minutes. I have finished my 1 minute. He will take his 1 minute, and then we'll go on to both of you to tell the audience your experiences about how the technology can be utilized for managing hospital operations and hospital resources efficiently. Thank you very much. Over to you.
Thank you, sir. Good afternoon. I think it's very important, as much as the clinical part is the other administrative part, to be equally considered when a journey of a patient in the hospital is taken. According to me, the hospital experience of a patient is based on three important aspects: clinical experience, then hospitality experience, that is, how do you take care of them, how do you treat them, how easy or convenient for them to go through your hospital journey. Third is the financial. These three dimensions will make a complete success of a hospital: clinical, hospitality, and the financial. Now, we have heard quite a bit on clinical part today. Now, this part, as Dr. Pavan explained, we will concentrate on the administrative issues where technology is playing on a hospitality, patient journey, and the also resource management into that issue. With that introduction, I think we will open the session for the speakers to. It's my privilege to introduce Chandrasekhar Sibal, Mr. Chandrasekhar Sibal. He is the Vice President of the Fiji Film India Private Limited, associated with the organization over 13 years, and he holds nearly 2.5 decades of professional experience and proficiencies in the field of what we call as marketing and sales. Why that has to come is, I think all of us know the sales or a marketing has become an integral part of how do you satisfy your patient in your healthcare environment. Probably his experience has added a lot of value into today's context of administration, how to get the thing experienced by the patient in a different way. Thank you. Vote.
Good afternoon, everyone, and thank you very much for the introduction, and thank you very much, Cahotech, for inviting me to this conference. Thanks, everyone, for taking out time on this Saturday morning. I will start my presentation. This is basically enhancing the patient care and reducing the administrative costs. Can I have the, okay. So basically, healthcare efficiency is the most important when we go to the hospital. Utilization of the time and resources, time and cost-effective care, minimalization of waiting times and administrative overheads, and quality of patient care. These are the most important points for increasing the efficiency in a healthcare model. So what are the strategies for the patient care? So what we suggest as a Fujifilm, implementation of the telemedicine and teleradiology services, to improve the access, to create and reduce the wait time for the patients. This is very important that the radiology reports, immediately as the study has been completed, it goes to the radiologist as well as the clinicians with the result. Suppose a patient is there with a stroke, he has to go for a CT or MRI, and immediately the neurosurgeon or neurologist has to take a decision. So the faster the teleradiology inside the hospital is there and the reporting is done, the faster the patient can get the services. So very, very important. Utilization of the patient feedback to improve the quality of care and identifies area of improvements. Encourage patients self-management through education and support programs. Implementation of electronic health records, risk packs, healthcare IT to reduce the paperwork and streamlining of the administrative tasks. Utilization of the data analytics to identify the areas of cost reduction and improve the efficiency in the healthcare operations, implement automated appointment scheduling and reminder systems to reduce the missed appointments and improve the patient flow. So Fujifilm contribution in enhancing the patient care and reducing the cost. So we have a portfolio of advanced imaging technologies, our risk packs, IT solutions, our teleradiology solutions, our AI and ML solutions, digitization of medical records, and training and support for the healthcare providers. So Fujifilm provides you with a lot of imaging options. We have the CTs, MR, mobile X-ray, ultrasounds, portable X-rays, IVD products, dry chemistry analyzers, and we are either number 1 or number 2 in providing these products to the hospital fraternity. And in terms of IT solutions, we have the PACS and RIS solutions. So it has a mobility solution where you can see the images on the mobile, a 3D visualization, advanced visualization tools, so the doctor can give an immediate result, and even the surgeon or anybody who's operating can see those things, pictures in his own laptop or and can perform the surgery. Radiological information systems, Synapse PACS, VNA. So these kind of systems are there, and we have a platform for AIPF, we call it. Relay platform is there. We can integrate all the AI because there are so many AI are available that it has to be integrated. Otherwise, it has a different standard as the earlier session the people were telling. So we have a AIPF tool which will combine all these things and able to give you a seamless viewing and in the packs. We can do that. So this is our modalities are there. It's going to the packs from all the modalities. Then this is AIPF platform is there, where all the AI, there are so many AI companies are there, which is on-premise or on cloud. So we can have a single platform for that, and it will give a seamless kind of a solution. And PACS viewer is there, where the doctor can sit and report. So these kind of services are there. Then we are also doing a lot of screening programs with our partners, Krishna. They are in the villages, small places. We are putting our CR systems to convert X-rays into digital, and then they are tele-reporting that. So we have done in Assam, we have done in UP, we have done in smallest of the small places. And what are the patient benefits are there? The faster diagnosis, improved patient care, efficient patient medical record, rural or remote areas are covered, and it supports the COVID appropriate behavior, though it was and a reduction in the carbon footprint and drastically. So one-stop solution for the customers so that radiologist or any clinician can report immediately and can give the solution to the patient. Apart from that, we are giving the training and support for healthcare providers for enabling tuberculosis screening in every corner of the country. We have our portable X-ray machine, which is around 3.5 kg machine with the DR detector, and a mobile console is there. We have already a program running for last 12 months where our vans are going to the smaller places. They are screening the patients and then sending them for the further investigations. And with the help of AI, we are getting the results immediately. We are also partnering with Government of India for TB Mukt Bharat, TB Harega, Desh Jeetega. So many cancer patients are there in India every year. Almost 1.15 million patients are added, and the breast cancer is the major cause of deaths in the country. Almost 1.62 lakh patients every year coming, and out of that 50% are coming at a late stage. So this is a big problem. So we are focusing on breast cancer screening campaign, and we are now going to start this campaign in 20 cities across the country, and where the ASHA health worker will be trained to see those things and go to the masses and then prepare the patient for the mammography, because in the advanced countries there is a mammography screening is done, but in India the screening is not there. So we are trying to inculcate the behavior of screening in India with the help of our program for this. So community-based screening for the breast cancer, healthcare risk assessments, and the physical examination by trained paramedicals, and counseling and transport for the mammogram, and then tracking of those referrals, and then after 30 days checkup, counseling, the palliative care, and referring them to the government hospitals for the treatment. So this is the overall screening model which we are adopting. And we are also providing a lot of training programs for the doctors. We are also launching a lot of books on fulfilled digital mammography. Our doctors, we have more than 125 installations across the country. And we have done a lot of seminars on Together Against the Breast Cancer, where our doctors are coming, teaching the more doctors for the breast imaging. Panel discussions are happening. And also we have done a lot of other things, NTB program, Yashoda Hospital, ma'am is there, so we have done with them for NTB program. And thank you very much.
Thank you, Mr. Chandrasekhar, for that very brief but complete presentation on how various technology can be used for early diagnosis, early treatment, and also how data analytics can be used for reducing costs. So thank you very much for your presentation. Now it's my privilege to invite Mr. Kaustupriya. He is the CEO and co-founder of Alden. And I got this. I don't know how many of you have got this, but what I read here was patient experience is a priority. And that is exactly what we are here for, that how can technology improve patient experience in a healthcare organization. And you are going to tell us about one of the very important, let me ask the audience, what is the most important point of care which affects the patient while he is there in the hospital? What is looking forward to when he gets admitted to the hospital and during his stay? What is one thing that he's looking forward to? He's looking forward to discharge. Okay. कि मैं कब discharge होऊंगा? When will I be discharged? How much time will it take? So he gets in first and starts thinking of a discharge immediately thereafter. Now he is going to tell us how we are going to reduce that anxiety of his and reduce his discharge time. Okay. So let me just introduce him. He is the CEO and co-founder of Alden. He is a seasoned, self-acclaimed problem solver. Okay. And he is to tell us how he is a problem solver in terms of discharge. He is passionate about user-centric solutions. And the company which he has co-founded, it aims at having a very nice, stress-free patient experience in the hospital. So over to you, Mr. Kostup, to discuss about how to have an easy and quick discharge. Thank you.
Sir, and I'll try to keep it quick also, considering that it's just before the lunch. Good afternoon, everybody. Thank you for giving us this opportunity. Thanks to the Caho team also to organizing such a wonderful event. We have been talking about care a lot, as sir was also mentioning. In last several decades, care has been paramount importance for everybody because that was most important thing, right? With a lot of medical science advancement technology and process optimization, now care has come to a point when it is very, very predictable and precise. Standardization has started happening. And we also realize that once standardization starts happening, the patient, the user starts demanding more and more efficiency and convenience. That becomes their pivotal point to make a decision. At Alden, we believe we need to change that, and we can change it. It's not just when a patient is going through an hospitalization journey, he's already very stressed and anxious. Having a straightforward convenience way out is not just a luxury today, it is becoming a necessity for us. With this as a mission we started, we went to ground, we stayed a long hours in hospitals to understand what is the largest problem, and we believe that discharge time plays very significant importance in patients' journey in the hospital. And despite of having a very good treatment, and a bad delayed discharge, that is the time when the NPS goes down significantly. People are not happy, and it ends up with a very sour taste in their mouth, even after having a very good discharge experience. From the moment the doctor says that you're fit to go in the morning, say at 10 a.m. round, the timer starts at that point of time. And I have never seen anybody come out of it before 6 or 8 hours, right? My father is comorbid. I have been into hospital very often, and every time doctor used to tell me that, okay, you can now go. It used to take me like 6 to 8 hours to come out of it. Not only that, around 20% of time the patient takes overnight stay to get out of the hospital. It is bad for the hospital also because this is the time when their beds are not getting utilized, it's underutilized, and that is an opportunity for them to earn more revenue, serve more patients around there. Also, if you see, patients are not adding any value in this process. The overall 6 to 8 hours is because of multiple process which is happening, like discharge summary getting prepared, bill getting prepared, and of course insurance approval coming in. Patient is waiting only for one thing because they don't know how much to pay. If the problem of knowing what is to be paid, that could have been collected earlier, and patient would have been let go, right? Because there's no other way, there's no other reason why they are in the hospital. Lot of hospitals have also tried out different mechanics to solve for this. What they do is they either take a PDC or take a complete advance, or if you are fortunate enough to know somebody in the hospital management, probably you will let go from the hospital, and you are offered an mechanics to come and pay later. These are all handles of trust. So if we see it deeply, the problem is there is no trust in this system. And that made us think, if we could bring this trust in this system, we could actually efficiently solve the problem. Alden acts as that trust layer. We come in between patient and hospital as an intermediary, taking care of their payment part, and in this case, out-of-pocket expenditure part. And patient leaves as soon as the doctor says that you are ready to go, takes his discharge summary and leaves. The unknown of what the bill amount would be, what the insurance approval would be, is what we take guarantee. We ensure the hospital complete payment once we receive both the bills and insurance approval, ensuring there is no working capital loss for the hospital. On the other hand, patient goes home and pays us back in few days at the convenience of their home, right? They don't even have to worry about that payment at that point of time when they're actually taking care of their family members. With this, we started, this is no more a distant dream. In last 3 months, we have done around 4,000 discharges with this process. We have saved around 10,000 hours of the hospital, which loosely translates to 1 year of bed revenue opportunity. Our patients leave earlier than a cash patient. So our discharge stat is lower than the discharge stat of a cash patient. Leave aside the insurance patient stat. We are 50% lower than insurance patient stat, 14% lower than the cash patient stat. On the side benefit, we also saw that there was enough and more optimization which has happened and in the operational efficiency of the hospitals. 27% reduction in refund request has happened, making their operational accounting system simpler. Night stays was saved by 17% of time. We have observed 17% of time the approval came next day, and patient would have to wait for that, and somebody had to lose that money, right? Either it was patient who would be paying extra, hospital who would be leaving that money, or insurance would have paid that money, right? This is a money lost. Admission operation has started getting better because of discharge operations getting better, right? Our beds are over by 1 p.m. in one of our Rajagiri hospitals. And because of this, admission starts happening faster, and hence the admission operation, which used to earlier end at 10 p.m. In the hospital, now ends at 7:30 in the hospital. So overall, lot of efficiency is what we have seen. This is one of the data which we want to show from the Rajagiri hospital, our early believer. Alden patient average stat is 2.1 hours from the time the doctor initiate discharge. Private and GIPSA patient takes usually 4.9 hours. This is an average stat. And cash patient takes 2.5 hours, as we discussed, right? Along with this, the patients are really, really happy. You can see our Google rating is still at 4.9 with 460 reviews. It really takes a lot of effort to get there. And yeah, we are very excited with this offering. We want to scale it further. And anybody who is really interested in talking about the solution or is interested on how to make it further better, we are all ears. Please drop by our stall at booth number 7. We are happy to have a chat. Thank you.
Thank you, Mr. Costo, for a very nice presentation. And I think, Dr. Gyani sir, we need not have a discharge lounge now. Because yesterday was a suggestion, and I still go by that suggestion, that there should be a discharge lounge. The moment the doctor writes discharge, the patient is transferred to the discharge lounge. Okay, the bed is vacant and your 2 hours are given to 0 hours. Because the moment doctor writes discharge, he is put in the discharge lounge. The bed is vacant, it is available for somebody else to occupy, and the patient is happily sitting and having tea, coffee, reading some books, seeing some TV, some programs.
Sir, we have tried it in Manipal.
Okay.
We do have a discharge lounge, and as soon as the patient is there, till the bill clears or this, they are kept in a comfortable location.
Does it reduce your discharge time, your costs,
At
and
least our,
patient satisfaction
at least
improves?
in one location, our inpatient load is so much that there is a waiting time for the new admission has become drastically improved with that.
Yeah, please.
Sir, very honorably, I want to beg to defer to that as an approach. I do understand that does solve the problem from the hospital perspective. Your bed do get free, but it doesn't solve user experience. A user who has just been treated was in comfort of his room, lying down on a bed. Now we are asking him to sit in a lounge, no matter how comfortable and how tasty the teas are. It is not a good experience. It is my personal view. I think it definitely solves hospital problem. It definitely does.
I agree with you. Nothing like him going back home at the earliest. They will be waiting at the 1 minute discharge. But since the process depends, your solution definitely gives a better thing. There is no dispute. We are telling in interim what has been.
Okay, now one question from the audience. One question each before we wind up. For each of the participants. Are you crystal clear what they spoke about? I think, you made a very good presentation. The audience is crystal clear, or they want to go early for lunch. Okay. So with this, I think, sir, thank you very much for being here with us. Thank you, both of you. At least, sir has to catch a flight. And both of you, I think we can interact with you here. And all of you who still have some lingering doubts, they are available. We can catch them during lunch hour, and when you go around the, not around the corner, but around the display areas, and you can meet them in the booths too. So thank you very much. All I wish to say is that for technology required to collect data correctly and in the right format, which means you must identify your pain points and identify the low-hanging fruits which will give you quick results. Once you do that, then everything else analytics will do for you. But if you do not collect the data correctly, then whatever technology you use is not going to have any impact. So the most important part of this session is please collect your data correctly and in the right format. And also please do not forget the human and the technology interaction. This is equally important. With this, thank you very much. Thank you, Cahotech. Thank you, Dr. Vijay Agarwal, sir, for giving us this opportunity.
Thank you, sir.
Thank you, audience, for your patient listening. Thanks a lot.
Thank you.
Jai Hind.
Thank you, Pawan sir. Thank you, Nagendra sir. And thank you, Mr. Chandrasekhar and Mr. Kastub. Please join for a photo.
Let's give them an applause. Thank you. Yeah. And now we head on for our last session before lunch. We will try to keep it very, very quick and interesting. So our next session is Tech Enhanced Continuing Medical Education, Empowering Medicos for Better Healthcare Outcomes. And I would like to invite Dr. Sanjeev Singh for moderating this session. Sir, please come on the stage. It's my proud privilege to introduce Dr. Sanjeev Singh, though he doesn't need an introduction. He is the Medical Director, Amrita Institute of Medical Sciences, Delhi NCR, Chief Medical Superintendent of Amrita Institute of Medical Sciences, Kochi. He is an Improvement Advisor at Institute of Healthcare Improvement, US. He is Ambassador from India to Society of Healthcare Epidemiology of America. He is an International Surveyor of ISQA, present Vice Chairman of Research Committee of NABH, Technical Committee of AHPI, and Health Sector Council of India. Welcome, Dr. Sanjeev.
Now I invite the panelist, Mr. Shankar Kaul.
Please come on the stage.
Yeah. I request Mr. Shankar Kaul to please come onto the stage. Yeah, Mr. Shankar Kaul is the Managing Director of Elsewhere Health Solutions for their India and South Asia operations. As Chief Representative of Elsewhere in India, Shankar and his team worked with an objective to enable and enhance healthcare capacity and capability that will help establish a sustainable healthcare ecosystem in India. Under his leadership, Elsewhere India successfully piloted digital upskilling of frontline health workers leveraging artificial intelligence-based solutions to screen maternal and child health conditions. Prior to joining Elsewhere, Mr. Shankar had held significant leadership positions in Asia Pacific across medical devices and specialty pharma, working for Fortune 500 companies. Mr. Shankar is graduated with Honours of Economics from University of Delhi. Thank you, Shankar sir, for being here. I request Professor Dr. Vivek Saoji sir to come on to the stage. Yeah, Professor Dr. Vivek Saoji sir, Vice Chancellor, Bharati Vidyapeeth. Dr. Vivek sir is a former Vice Chancellor of KLE Academy of Higher Education and Research, Belgaum. He is MBBS and MS Surgery from IGGMC Nagpur. Dr. Saoji sir joined Bharati Vidyapeeth in December 1990 and he served as Principal and Dean until July 2007. He is a Vice Chancellor of KLE Academy of Higher Education and Research, deemed to be University, Belgaum, Karnataka till September 22. Saoji sir has more than 34 years of teaching and clinical experience and 22 years of academic and administrative experience. He holds the prestigious Family Fellowship. He is the Governing Council member of ICMR and Association of Indian Universities, New Delhi. Now I request Dr. Meenu Singh. Not there, okay. Yeah. Yeah, I request Dr. Sanjeev sir to take on to the...
Right, thank you so much and thank you Dr. Vijay Agarwal, Lalu, Sam, for organizing such a fantastic event, and every year it gets bigger and bigger and better, and I don't know how do you do this magic, but congratulations for putting a very good program together. And I have a very enlightened guest along with me. We are here, though it looks like people are very hungry and then they chose food better than medical education, but we'll try to keep this short and see whether technology makes sense in medical education. There are 702 medical colleges. There were 347 almost a decade back. So I'm very fond of this particular government, but some of these decisions which they have taken, we'll see whether it makes sense. 702 medical colleges, 107,000 MBBS doctors coming out every year, 80,000 postgraduates coming out every year.
The employability of an engineer in India right now, a good employability is 5 per 1,000. The employability of a dental is 3 per 1,000. And with the decision which this government is taking of producing more doctors, so much so that recently you must have seen that for postgraduate admission, they have dropped the marks to negative. Even if you have got negative marks, you will still could be a postgraduate in the country. And that's the form of medical education which we are going to provide. Unfortunately, every time it is a choice of quantity rather than quality. And I'm part of medical college's rating, where we are working and under the guidance of Air Marshal Pavan Kapoor sir. How do you choose quality, and rather than assessing the room size, the faculty strength and the patient strength, can we look at, do students know what they have been taught, and do faculty know whether their plan is appropriate? So we'll see, we have two guests, and we'll have Dr. Meenu join us. She couldn't join us physically, but she possibly is going to join us online. So I'll immediately would like to ask the Vice Chancellor, for a very, very prestigious university within the country. So Dr. Savagi, how technology in the medical education has changed the healthcare professionals who are getting trained, and what do you perceive as their role?
Actually, at the outset, let me thank the organizers for giving us the opportunity here to share our views and be part of this very elite and distinguished gathering of professionals, healthcare providers, corporate head honchos, and very eminent people. Probably we are a very few people, odd men out, if I may say, because I'm from the academic field, and probably majority of the people here are from the corporate world, maybe new healthcare startups, and maybe some of the other hospital administrations and other areas. So giving an academic perspective to the discussion is very important. Number one, yes, technology is here to stay. Technology is here to make our life easier, and we need to explore, use technology, exploit technology, master technology, but technology should not be our master. It should be subservient to us. As it was said, that we really need to be, technology should augment us, it should augment our capabilities, it should empower us. Having said all this, coming from academic environment, just now Dr. Singh alluded to the point that employability. So again, do we here have that kind of a connect, that kind of a industry or a healthcare industry, if I may say, is there a connect between, because what is the need and what we are giving? And then we've been discussing that, okay, I think how technological advances are taking place. But just think about it. We are training, we are teaching tomorrow's professionals who will be in the profession for next maybe 30 to 40 years. We don't know how the next decade is going to be. And we're training the professional. We're training professional with today's teachers. Me, some of you who may be here, and with yesterday's curricula. So what can be a bigger contradiction? Because we're not adapting. In academic world, we're much slower. We've been talking about policies, we've been talking about fancy stuff, but we're not talking about learning. We're not talking about the learners. We're not talking about how we are able to empower the learners, because it is these formative years, if we are able to influence them positively, then only they will be able to use this technology, employ this technology. So I'll not take too much of time, but how do we go about it? Everyone would agree that yes, there has to be training which needs to be coupled with for learning. How do we really do this. So probably one of the things that is happening is we work in silos. We work, in medical college, we don't talk to someone in a technology institute, or in technology institute, someone doesn't talk to other hospitality industry or something like that. So probably number one is we need to develop interdisciplinary or multidisciplinary teams. Unless, of course, we in education, we in industry, we whoever at the helm of affairs, the stakeholders, we are able to develop these interdisciplinary teams, then again these isolated things or some top-down approach will be there and will be able to do, will be compelled to do something, but it will not be internalized. So I think technology in healthcare, in training, very important, cannot be ignored. If you want to ignore it, it's at your own peril, but then it is here, we need to bring it, but we also, when we're doing it, all this in the larger picture, we need to keep the learner somewhere whenever we're developing all these things. It's happening in bits and pieces, but I think if we want to have long-term impact, we need to be really working together in effective teams. So I think we'll take the discussion forward, but that's just the initial thoughts.
So those are very, very important points. While we were working on this rating of the medical colleges, we inspected few of the medical colleges in the country. And we went to one medical college, we went to a classroom, 8 to 9 lecture theater. The pathologist was taking a class. She mentioned about pneumoconiosis. She mentioned about the clinical features, the radiological features, the morphology, the pathology. 45 minutes we sat in the class, and then we asked the students, we picked 10 students randomly and asked to recall what they has been taught. One clinical feature, another radiological feature, and all 10 of them could not utter a single word. So there isn't a problem with the faculty. There possibly is not a problem with the student, but there is a problem with the method of how it's been taught, and possibly technology can fit in what is important. So I'll come to Mr. Shankar, who is the managing director, and with your experience, we saw urban, rural, local expertise being available. So how do you think local expertise could be encashed to bring in technology, and we can reach out to the community at large?
Dr. Singh, thank you very much for the opportunity. We're also very excited at the partnership between Caho and Elsevier in leveraging basically knowledge-based solutions for making positive impact on patient safety and patient outcomes. So really very excited at that prospect as well. Now, coming down to your question on local expertise, it has a huge role, right? Local expertise has a huge role in appropriate utilization of technologies for for the larger good of the community. But before I kind of directly address or expand on the relevance of local expertise, I think it's important for us to look at have an understanding of the Indian physician context and their challenges and needs. From a context standpoint, the clinicians today can no longer rely on memory. They need to know a lot. They need to know when and how to acquire this detail. I'm saying this given the way diseases are presenting itself, the way patients are turning up through multiple handoffs to the clinician, and also the explosion of medical knowledge, information, lends to constantly evolving guidelines and protocols. All of this, when you connect together, the basis of all of this to be able to address this is to have credible knowledge-based solutions available. From a challenges and needs standpoint, three big areas jump out for us. The first is that the physician force is overburdened with lesser time available. you can see that they rely on, majority of them rely on unverified resources like Google, WebMD, just to speak of a few. And then 89% of the young specialists and junior physicians whom we surveyed extensively 3 years back basically clearly expressed the need for local relevant content that is that aligns with Indian guidelines, that's per Indian guidelines and clinical practice needs. And all of this they want to be in the form of quick answers and easily available through intuitive, mobile first application platforms, etc. So when we looked at the context and when we looked at the challenges and needs, Elsevier is convinced and increasingly using local expertise to build this relevant, verified content, obviously harmonized with our global platforms and processes. Just to give you a specific example, more than 2,000 leading Indian clinical experts, we are having a collaboration with them. And these are experts who are committed to evidence-based medicine, and they are building synoptic, relevant content in across 20 specialities, which including clinical algorithms for making sure of correct differential diagnosis, etc. And all of this verified content is now available to the Indian physician community across the urban-rural divide. We are making many other platforms available so that we are able to bridge it also to make sure that this is easily accessible, it is affordable, and it is available in Indian rupees through UPI gateways, etc. So those are some of the things that I believe, from a relevance of local expertise, we will continue to have to rely increasingly on that local expertise, because if we have to make it relevant, if we have to make it verified, if we have to make it useful, and therefore to be able to drive outcomes as well as patient safety, this is going to be very, very important for us.
So, fantastic. I think that is very, very relevant. The evidence-based care, though we talk about it, I'll just share an anecdote. I was doing an assessment, and I've shared that multiple times. I was doing an assessment of a very, very, very good medical college. Went to the Department of Pediatrics, asked what was this surgery. It was a long intermedullary nailing. The first drug which was given was injection meropenem. I asked why. He said he's giving it for next 15 years, for the last 15 years. Second drug, piperacillin tazobactam, I asked why. He said that he's not sure about the infection control practices, so he gave 2. Third drug was injection tramadol. I asked him why. He says, itna bada surgery, why pain to hoga? Patient says no pain. Fourth drug was injection ondansetron. I asked why. He says, jab bhi tramadol dete hain to ondansetron dete hain. I asked the patient, do you have nausea? He said no. Fourth drug was 3 pints of normal saline. I asked why. He said, jo bhi admit hota hai, he gets an intravenous. Normal saline has been declared as an abnormal for the last 1 decade. And sixth drug was injection MVI. I asked why. He says, ki jab bhi yellow colored fluid jata hai, the patient feels very powerful. And that is where the evidence, unfortunately, is. And they are all experience-based, which they claim as an evidence. So it is going to be very, very challenging. So we have given an indication that this particular session has to be extremely short. It was almost like come to bat and bat like Shubnam Gill and walk off. The last question, do Dr. Meenu Singh still around? You want to play, and I'll ask the... Okay. So, National Medical Commission is a regulator. So, as a regulator, as a policy change to bring in technology, what are the challenges, and can, in 1 minute, you could summarize what would be your ask to them?
Thank you. Again, that's a very relevant point, because here everything what we do or we don't is regulated, and particularly medical education is regulated very rigidly, very limited flexibility. In fact, majority of the medical colleges take the disguise, ki, oh, ye NMC ne bataya hai, so we'll do only this much. Actually, NMC prescribes minimum, we can do beyond that. But a majority of us really restrict ourselves to the minimum. But nevertheless, that's besides the point. But NMC has recently launched the competency-based curriculum. Recently means just about 2 years back. And that was a paradigm shift. And now there is a focus on ability to perform and ability to do rather than ability to learn or ability to just know. And I cannot agree more with Dr. Shankar, and because they are providing the solutions and the context-based solutions. So I think the NMC has woken up to the fact that, well, yes, we need to integrate technology in curriculum. We need to use these digital solutions which are there and which will help. And as you're saying, that evidence-based medicine, you very nicely summarized, ki, okay, here say, nahi, ye, hum treatment dete hai, kyun? Nobody knows the logic, nobody knows the reason. But if we have these on-the-go solutions, ready to, algorithms, all these things, then it will be beneficial to the patient. And yes, the regulatory councils do, they are accepting these. They still have to walk a long distance, but yes, some beginning has been made. And I'm sure, I think with the advancements, they'll have no choice but to adapt to these changes which are coming up.
Thank you, sir. A very quick question to you before we get to Dr. Meenu Singh's video is, when we were undergraduate and postgraduate, if we see a patient in the ward who has a pansystolic murmur, 150 students used to stand to hear the same murmur. So how do technology be a good enabler from day zero when he joins to get to the first patient?
I think first I'll try and address this more broadly. I think Elsevier is involved in the whole continuum from day zero. When the clinician joins the undergraduate school, through his undergraduate journey, to being a generalist, to being a specialist, and then finally being able to contribute back to medical science through research. And we do this through a full suite of comprehensive platforms, from teaching and learning solutions to workflow solutions to reference solutions and together at the point of care. And we've kind of, these basically what they do from a teaching standpoint, they are able to provide from an undergraduate medical curriculum, topic-based teaching. They are able to provide skill-based teaching and training. I already talked about from a clinical expert standpoint. We have now this big collaboration with Indian clinicians on being able to provide this evidence-based synoptic content across a range of specialties, and then expansion that is taking place. In the area of clinical research, we have iconic platforms like Clinical Key Physician and Science Direct. And we are also now democratizing availability of evidence-based information in languages outside of English, in Hindi, and in other regional languages. I mean, the latest being that Lancet is being translated now into Hindi, so that we are able to democratize, science and evidence-based medical and make it more largely available. So.
Perfect. So we, I don't know whether we have Dr. Meenu. She's a medical director at All India Institute, one of the All India Institutes who have done remarkably well. If none, then I think we will close down. The mandate which was given to us is just go and just like an exam, when the exam paper is get going and start writing. But I know there would be hypoglycemic episodes and question. Is there any question from the, yes, we can take one or two before we break for lunch.
Yeah, I played the 1 minute video, sir.
Now, evidence-based medicine is also a field in which we have been working, and what is the meaning of evidence-based medicine is to use the best evidence coming from science, scientific research in the healthcare delivery. Now, the various steps which are there in practicing evidence-based medicine are that you have to formulate a relevant research question which is prioritized for the local community. Then you have to access the evidence. That means you have to search literature, and these days with the help of technology and various databases, it's become possible to access knowledge in a very easy way. Just in the palm of your hands, you have your mobile phones from which you can access. We find that using technology and evidence in a positive way in various interventions for healthcare are of great benefit. We know that we do have a lot of knowledge as to what works best in a particular healthcare setting, but we don't know how to implement it. There is a need for a lot of implementation research in the field of healthcare systems, and we need to develop capacity in this particular field so that people know how to translate the knowledge which is there into practice. And that is something which needs a lot of education, again a lot of projects like National Medical Colleges Network, which has been set up for delivery of education through electronic means. There are various learning management systems which are coming up, which we had a chance to work for eAfrica network and also for our SARC telemedicine network, in which we can disseminate knowledge and practices also can be taught through the technology. So it's very important that we also concentrate on facility development. So it is not just developing capacity of the individuals, we also need facilities in far-reaching areas where there are no physicians, there are no facilities where patients can be looked after. So I think we need to have villages where you can even make them into smart villages, where they get connected to various doctors and healthcare workers, and we can actually feel the needs, what they have. For example, sometimes they may just need some platelet transfusion for dengue fever. How to deliver that? For that, we have been making use of new technologies like drone technology, in which things can be transferred in an unmanned kind of vehicle and given to the patients in need. And this is an experiment which we have tried with the distribution of anti-TB drugs to the far-reaching areas of Uttarakhand. And the experiment has been successful, that you can deliver the drugs and you can get the samples of the patients which need to be tested. So I think these are the various examples of how technology can be used to strengthen the health services, and each one of these areas actually can be strengthened, and I think that is how we can achieve better health outcomes. Thank you.
So right with that, we'll come to the closure, because before the organizers start giving us dirty looks. So I think there is a mixed feeling with the regulator who's managing medical education. There has been a lot of corrupt practices earlier, but they have been extremely progressive. They've come up with a competency-based medical education since 2019, and that has been a vertical and horizontally integrated. So if somebody is doing lung in the anatomy, they are also doing physiology, they're also doing microbiology, being taught strep pneumo, and then they're also being taught by the pulmonary medicine people. So there's a lot of change. There is an addition of electives, addition of value-added courses, which was not there earlier. There are small group learning, which has been also added. There are learning objectives being, so a lot of pressure on the faculty, a lot of pressure on the medical students to arrange or prepare the logbook and do the competency. So there are phenomenal changes which have been brought in, and we just hope that it all comes into action, other than just preparing for the postgraduate program when you're still undergraduate, which is right now a norm. So with that, I'm going to thank, we'll do it during the lunchtime. So I'm going to thank Dr. Saugi and Dr. Shankar for their engagement, and if you have any further questions, please do trouble them during the lunchtime. So thank you so much.
Thank you so much, Dr. Sanjeev. Dr. Sanjeev Singh, Mr. Shankar Kaul, Professor Vivek Sauji, Dr. Meenu Singh, for a wonderful session. requesting for the photograph. The comment was only to entice the audience for the lunch, but it was truly, truly a very, very interesting session. Thank you so much.
Let's
and
break
let's
for a
break
quick
for
lunch.
a quick
Yeah,
lunch.
and come back within 30 minutes, please.
Thank you.
Hello, hello.
afternoon, Caho. Woohoo! Do you want me to play the national anthem again or the Caho anthem? Come on. Energy level is about as, other than Uma and Aparna who look like they're up for a serious post-lunch session, the rest of you look like you're half asleep. Dr. Chitkara looks like he's dazed with headlights. Lullaby. No lullaby is coming now. Right? We're going to have a little bit of fun. We're going to catch up some time, hopefully. So guys, this is the fun side of the session. We had some amazing startups that presented. I would like to ask my co-moderator, Dr. Ganapati, who really needs, please sir, come, who really needs no introduction, but I have to give it. He's a dear friend. He's the godfather of telemedicine in the country. He will say that I had many other godparents and telemedicine had, but this is a legend on himself. He has led part of the Apollo group for generations and has evaluated more startups than I think, actually I knew there were startups in the country, right? At least that fact is probably true for 10, 15 years ago before ET had a page 4. You know, in the rest of the world, we used to worry about page 3. By accident, if somebody opens a page 3, they would see some unnecessary pictures of things that will get you arrested in India. Whereas today, we all look at page 4 and all get excited because we think that the world is happening and we should join a startup, right? So I think we had some outstanding startups presenting to us. We had near 100 startups who had applied, and this year the quality level, I've been involved right from the start, but since the start of Pitch Fest, the quality level was much higher for the base startup. So the average was significantly higher than anything we've seen before. So please give you a round of applause. I'm also trying to buy some time for the rest of the people to eat some food and come in, and for Dr. Chitkara to also get not so dazed. Lullaby is coming, sir. Lullaby aa raha hai. So we have 4 startups that we shortlisted out of the 23 that were evaluated yesterday. What was very special about yesterday was that we had an amazing panel of judges. We had 80 judges. And when people are saying, how can you have 80 judges? This meant that we had 80 decision makers, of which 60 were from hospitals or from diagnostic centers or opthal units or dental centers, who were the decision makers on the receiving end to potentially bring the startup into that environment. So we had a remarkable, I know some of them are in the room. If we could have you stand up, Dr. Chitkara, Dr. Pichumani, come, I think some of you, Varad, please, if you could stand up and take a round of applause. Uma, Mukta, right? We had some awesome judges. It looks like the judges are all busy eating at the moment because they worked so hard yesterday. And the best piece of feedback I got for the startups that made the finalist was that we made them work hard for their food. So I think that means we actually got some outstanding judgment. So I think if the judges could join us on the front row, you could give us some Mexican waves when the startups kind of like present, it would be good. Get your energy up, some yoga. Come on. Dr. Chitkara, front row, please. Uma, don't be shy. Mukta. Exactly. So I don't know why I'm having to even repeat. Madam, what are you sitting down? BioRx was very much a part of the judging panel. Where is your other buddy? Sanjay is run away. See, all the investors are very quietly run away. They've written their checks and have gone home. No, but on a more serious note, we have 4 outstanding. We had 3 categories. So we had this category for innovation for clinical improvement. We had the innovation for non-clinical areas. And then we had something for enabling digital transformation. But because we heard such wonderful platforms, we said we'll give 4 of you a chance to present to the broader group. So why don't the 4 come to the stage? Let's start with the first one. If we can have Girish and Dr. Ramesh, why don't you come along and perhaps talk about artificial learning system, or what we have now learned as artless dristry. Please.
Thank you so much. Thank you so much. Thank you so much, and an honor and a pleasure to be on the dais here, to be presenting to this esteemed audience. We are Artilus. We are with you in preventing preventable blindness and largely focusing on the retinal blindness. The problem that we are solving is of retinal abnormalities. 90% of blindness that we see is actually avoidable. It's either preventable or curable. We are talking about 57 crore adults in the country, and we are talking about 100 crore eyes in the country. Now these eyes, there's a high possibility of a retinal abnormality, and this retinal abnormality goes unnoticed because of it being asymptomatic. And that's where we come in. Because of this huge volume that we have, that the market that you're talking about is about 26,000 crores. It's a United Nations Sustainable Development Goal, and the Indian government is also extremely committed to fight this particular incidence. So the first product that we have is a fundus camera, which honestly even a 6-year-old child can operate and give you images as good as these. But our strength actually is not just the fundus camera, but something that follows, called the Drishti report. We have an artificial intelligence report which gets generated seconds after the image is captured, which gives you 4 different things. The first is it identifies 20 different retinal abnormalities from the same fundus image. It classifies diabetic retinopathy into grade 1 to grade 4 according to the ICDR grading. It also identifies 16 abnormalities based on which it has made this particular decision of grading. And not just that, it also gives you an explainable AI. It also gives you an explainable AI which improves acceptance from the medical fraternity. But the product that I want to speak over for the next 3 minutes is our OCT that we have developed indigenously. It's the world's most economical and the most portable OCT. It's the only made in India OCT available across the world. Because I was asked for this yesterday, so I would love to show you a comparison. The images on the left-hand side, which are in the blue box, are images from a device which is 10 times costlier as compared to the OCT that we have developed. The images with the orange box are the ones that are captured from our OCT. Our OCT captures a macula, ONH, as well as the anterior imaging completely, and it also has an artificial intelligence platform which is able to identify 7 different retinal abnormalities from the same image. All our products, including our AI, are commercialized already. We are generating revenues. We are getting repeat purchases as well as referrals also. We are selling using direct sales, screening as a solution, leasing, and very recently, screening for diabetic retinopathy and glaucoma has been included as a part of AB PMJY reimbursement. We have started generating revenues from AB PMJY reimbursements also. Right now, we've generated a revenue of 2.37 crores this year, as in the first 6 months, and we have ready POs of 12.38 crores to service. Drishti AI that I spoke about, first of all, is highly sensitive and specific. It identifies multiple pathologies and also can function offline, which is another USP for our AI. Our LCHP OCT is the world's most economical, not just in terms of price, but also in terms of maintenance as well as the cost of parts. That makes the overall cost of acquisition very, very low for the device for medical fraternity. Its image quality is something that you've already seen is as good as a gold standard. It is made in India. It is the world's most portable OCT, and plus it has the backing of Drishti AI. What we're working on is Drishti AI will keep on evolving. We'll have more conditions being identified. And on the OCT front, quickly, I'd like to tell you 3 developments that we're working on. The first is called an RMAC. That is a multi-axis controller for which we won the 5G Hackathon Award, as well as we won a 50 lakh rupees grant from the DCIS to make it commercialize it. It's the world's first OCT which can be operated remotely. What are the advantages? Now imagine India has 25,000 PHCs. One OCT being shared between 5 PHCs will ensure that the per PHC cost of an OCT comes down to about 2.5 lakh rupees. Right? And that is something that we'll be able to bring in with the RMAC. It has already, the first prototype is already ready. We are working on the final prototype of the same. The second thing that we're working on is the world's most economical intraoperative OCT. Today, retinal surgeries, about 90% of retinal surgeries are conducted without an OCT in the OT. The reason is the prohibitive cost of the current option available when it comes to IOCT. We will be able to bring in an IOCT at 1/5 the cost of the current IOCT, and that is why we'll be able to have a better reach. We'll be able to serve more number of operation theaters where retinal surgeries are being conducted. We've already won the Cahotech Elevate Award for the same, grant for the same. End of October, we'll have our first trial happening, first POC happening, or the pilot happening at Sangli. We are also developing, we are in the process of development, this will still take some time, to develop something called a supine OCT. Now, supine OCT will help.
Time.
Sure,
So,
sir. Then
if you could wrap, but
two more slides.
what do you want from the group? Focus on what you want from this
Okay, sir.
group.
Sure, sure.
I think you winning other awards is great. You're
Right.
here to award for ours.
Absolutely,
What do you
sir.
want from the hospitals, from the community here?
Right. So, three things that we would seek here from the community here. One is give us an opportunity to be evaluated. I'm not asking for business, I'm asking for evaluation. We've been evaluated across more than 100 clinics across the country, and every single place, we've got a very high conversion rate. Every single place, everybody has appreciated the imaging quality and the reports that we're able to generate. So if you need an OCT, probably we are one of the best partners available here. Please give us an opportunity to be evaluated. That is one. The second thing that we're looking at is growth capital. We are at a stage where right now, honestly, we are not able to service the number of orders that we are getting. Here we need to scale up. And to scale up as a startup, we don't have those resources. We would love to help, we would love any sort of help that we'll get to scale up our resources. And from the third point of view, any network that you can help us with is something that will be highly appreciated. Will be highly appreciated. So that's my contact details. If you would like to get in touch with me, please, I request you all to get in touch with me if you can help me. Thank you.
So guys, if anybody in the audience believes they can leverage this, please just stand up or raise your hand. Come on, there's no hands? I'm sure there's some Optal centers here. There are somebody who wants to be there. We've got.
Thank you, sir.
So guys,
Thank you, sir.
look at that. I'm sure there are many more.
Yes, sir.
But I'm sure this one person will be able to access
Two of them, sir.
the network.
Right, sir.
Right? I know
Perfect.
personally, so I think go spend some time, please.
Perfect. Thank you so much for this
Thank
opportunity,
you.
sir. Thank you.
Thank you, and you are, by the way, it
Yes,
will
sir.
be announced later today,
Sure.
the thing, so I think you are in contention, so good.
Wow,
Thank you.
Thank you.
for your
Thank you
time.
so much. Thank you.
So,
Thank
the
you,
next
everyone.
one is NanoClean. We have Mr. Pratik Sharma or Tushar. Who's here? Pratik? Ah, here you are. Come. And this is, the project is called SiggyBud. This was another innovation in the non-clinical area that I think was relatively, it's very remarkable. So, please, the floor is yours. Time is of the essence. Focus on what you'd like from this audience.
Sure. Thank you so much, Sam and everyone at Coho. Sorry if I cough in between. I have been diagnosed with dengue fever yesterday only. I have been asked to see the doctors, and hence I am here. Hi, I am Pratik Sharma, founder and CEO NanoClean Global Private Limited. We are a group of IIT Delhi alumni and professors who has patented world's first biosafe filtration technology to reduce harmful effects of air pollution. And for doing this, we have received a very, very prestigious Startup National Award by Honorable President of India. And yes, we were there on the Shark Tank India platform also early this year, and this technology was widely appreciated by all the sharks. And here is the reason for all these appreciations. Our nanofilter technology developed inside the labs of IIT Delhi. This is that technique which filters out minutest of the particles which are there in the air or in the cigarette smoke. And with this remarkable tech, we have developed world's first smoking cessation filter, SiggyBud. This reduces tar as well as nicotine by up to 80% without changing its taste. The problem statement which we are solving is 63% of the smokers want to quit smoking, but in the lack of available solution, they are unable to. In terms of available solution, there is only one product in India, Nicotech, Cipla Health's product, and there are a few imported products from China and Japan, which are essentially not the filter product, but these products are there to reduce darkening of your lips when you are smoking. While with the help of SiggyBud and with the 3 variants of SiggyBud, inspired by the tricolor of the Indian flag, orange, white, and green, we are reducing your tar intake starting with 30%, then 50%, and in the last month, 80%. And by the end of 3rd month, you will be able to quit smoking. And this is the user behavior. In the first month, we adapt a user in lower amount of nicotine with the help of SiggyBud Light, which is of orange color. The next month, we make him used to the smooth effect, which it gives onto your throat. And in the last month, you becomes a SiggyBud Pro, which means that you will not be able to smoke even a damn cigarette without SiggyBud. The product was launched early this year and was widely covered by all the major media houses of our nation. And here is the best part of our product, the user feedback. We have up till now served close to 6,000 customers, and we have a remarkable reputation of more than 33%. We hold 2 granted patents for the patent around the technology, where we hold a patent which is a joint patent with IIT Delhi, and then the patent around the product itself. Our target audience is simply those who want to quit, or even those who doesn't want to quit. We can also help them in reducing their injurious effect which they get while smoking. And we are way ahead if you compare our product with the available options, like Nicotex changes the user behavior altogether. We are not doing the same, and the imported products from China and Japan are not essentially claiming anything for their efficiency. And this is completely indigenous product made in India. We are doing 2 options in terms of our...
This is less of a pitch. This is more, what would you benefit from having the people in this audience, right?
Okay, so I have a clear-cut ask over here. Thank you so much. So apart from your best wishes to continue this hockey stick growth, what we want from you is support to place our product offline on the pharmacy stores. Apart from this, if at all you want to quit, or anyone in your known want to quit smoking, then we have Sigibird available with us. You can give it a shot, and we guarantee that you will feel the difference in just 1 or 2 smokes. Thank you so much.
Fantastic. Thanks a lot, Pratik. I think to the point, we appreciate that in terms of what you do. And another very good example of being on time. So thank you.
Thank you so much.
I think we have next from Generative Innovations, Priyanka. Priyanka Singh, please, if you could make the stage a bit more colorful with your presence and share with us the wonder that comes from the House of Will Grow.
Yeah, sure. Hi everyone, I'm Priyanka, as I said. I'm from Generative Innovations. So as the name Generative is derived from the Sanskrit word mother. So the name suggests we are working in maternal and child healthcare. So we are working with a vision to see a world where no mother or baby dies during pregnancy, during delivery, or post-delivery. So before I start, I would like to ask a question. Have you heard, do you know the reason behind the death of Maya, mother of Gautam Buddha, then Mumtaz Mahal, wife of Emperor Shah Jahan, then we have Smita Patil, wife of Raj Babbar, and then T.K. Padmini, she was a famous painter. So they all suffered from maternal death. And these are only few names which I have listed, and there are a lot. So as WHO states that there are 223 deaths happening per 100,000 live births. And every 2 minutes, there is a woman who is dying because of maternal reasons, pregnancy-related complications. So we can see by the time we are ending our conference and everything, like 3-4 minutes, a lot of that would be happening. So, yeah, so with that, I would like to start that fetal heart rate and uterine contraction are one of the critical parameters to identify early complication and to prevent the maternal or neonatal death. Then partograph is a proven tool to monitor labor progress. However, paper-based partograph is complicated and it requires time. And 70% of the deliveries are happening in low-resource healthcare setting, where there is poor patient-staff ratio, and the deliveries are attended either by nurses or the midwives. So we have very less number of OBGYNs present in our India as well. So according to FOXI, we have around 45,000 to 50,000 OBGYNs only. So it becomes very difficult to analyze the reports. So with that, we have started working on AI. So this is the current technology that is being used. It's not portable, it's not wireless, it's not patient-friendly, not digital. So the person has to be present at the location to interpret the results, right? So we have came up with...
Less than 2 minutes, please.
Okay.
Get to your product.
Yeah.
Straight to the point.
Okay. So with Generative, we have this ecosystem of maternal and child healthcare products, which works for the monitoring. So we monitor fetal heart rate and uterine contractions. So this is the report that is generated by AI, and this can help the nurses to identify the early complication and get suggestion from the OBGYNs if required and take an early decision. Then we have our software, which has three interfaces, that is nurse, doctors, and dashboard. So everyone is now involved with the patient's results. So wherever we feel like the decision can be taken, it can be taken by the doctor or the administrations as well. So we have, till now, we have monitored more than 60,000 plus mothers deployed in 10 plus countries, and we have saved over 5,000 lives till now. We have already catered 4,000 plus hospital and trained over 1,200 plus healthcare providers. We are working with 7 Indian states and then one Western Africa country, Sierra Leone. So this is our team, and we are working with the medical advisory board. Yes, so these are our supporters, Wilgra especially.
No, what's the ask?
Yeah, so we are looking for collaborative partnership to work with the government and also in the private sector, and we want to scale up our product in the state and internationally.
So ideally, you're looking for any hospital that has a fetal medicine or a high maternity number that you're looking to tie up with.
Correct.
I'm sure there are a few here. I see Dr. Anuradha here, one of the rock stars. I see many others here. So I think go grab them. But thank you.
Yeah, okay.
Thank you. And guys, as the last team joins the stage, and this is one of our favorites, which is Neo Motion Assistive. So why don't you come to the stage, please, or come. This one has got a live demo. This is the product. And I think, why don't you start?
Yes, I would prefer to demonstrate. Abhishek, please show how to detach and attach the product. In few seconds, it is detached. You can go around. So now your person can go inside the office or house and do the course and come back and attach.
Why don't you reattach and go around the room while you present?
Yes.
Go ahead.
A great good afternoon to everyone present here. I am Ashish Mohan Sharma from Neo Motion. So what problem are we solving? So just think everyone, how many wheelchair users did you see when you come today morning to this event? I guess very few or maybe none. So that is the main focus that we are solving right now. Our starting focus is to develop products for people with spinal cord injury, amputees, polio, and people with other lower limb medical conditions. And that is exactly our ask also here, because we are sitting in the right where the decision makers are there, where you prescribe what product should be used by a particular person with a particular medical condition. And that is where we'll need a support from all the medical industry, hospital industry, to work with us, see how the prescription, how you work, and we collaborate and understand each other's requirement, and so that we can develop the right product for the right need. So the product for the present problem that we are solving, a small video.
में दोस्त के कंधे पर से गिरने के कारण मेरा शरीर पैरालिसिस हो गया था। इस व्हीलचेयर प्रयोग करने के बाद आसानी से हम कहीं भी जा सकते हैं, आ सकते हैं। एक गाड़ी आती है जो कि इस व्हीलचेयर में आसानी से हम सेट कर सकते हैं, और गाड़ी सेट करने के बाद हम आसानी से बाहर जा सकते हैं, कम स्पेस में जा सकते हैं और कहीं भी पार्किंग कर सकते हैं, और समय का बचत हो सकता है, क्योंकि अगर हम ओनली व्हीलचेयर यूज करते हैं तो हमारी समय ज़्यादा लग सकता है, बट वो गाड़ी जब सेट करने के बाद आसानी से हम जा सकते हैं एक स्थान से दूसरे स्थान। और
Yeah. So primarily the problem that we are solving is a mobility. So indoor mobility is one thing and outdoor mobility. So customized wheelchair is what we make. It's called NeoFly. So it is for the indoor mobility you can use in inside house and office. And outdoor mobility is a quick attachment in few seconds and you are on roll for 25 to 30 kilometer. We have recently developed a battery which goes up to 60 kilometer as well. So Mr. Abhishek is actually doing a Zomato delivery. He has earned about 90,000 rupees in 7 months, and which is a good income for the person with spinal cord injury. So we have impacted 4,000 people across the country right now. We work with everyone like CSR, governments, and organic people like people sitting at the village to towns and first-class cities. These are the some stories which I have to present here. So there are people who are able to use metro for a seamless multi-kilometers distance. There are people who are able to go and train themselves for parasports and representing India on our product. Yes. There are people who are going to farm and doing farming. He's a ex-military actually. He's from Indian Army. There are people who left their education when they got injured, and now they are coming back and completing their education. And like Abhishek, there are many other people, about 150 people, who have covered more than multi-lakh kilometer. I don't remember the exact, and total 15 lakh rupees of revenue total cumulatively. This is our factory. We have recently made 100 units delivered within 7 days. These are the new products, which is the new series: a powered wheelchair, new stand, a lightweight wheelchair, and a scooter for elderly people with lower limb challenges. And the goal is to impact 1 lakh lives per year. And that is where exactly the ask is also attached. We need your support to work together and impact about 1 lakh people per year. This is my team, 50 people overall, out of which 25% people are people with disability, especially speech and hearing impairment. This is our leadership team. So Mr. Swastik, Professor Sujata is from IIT Madras, myself and Siddharth Daga. And thank you.
So, thank you. I think what we'd like is there are a couple of you who have neuro hospitals, ortho hospitals, who have large practices or trauma, which could benefit if you could raise your hand so you could have a look and maybe come and visit. I'm sure, sir, you can also benefit. Hand up. I'm wondering, your hand needs a wheelchair, sir. There, lady at the back. So I think go spend some time meeting some potential tie-ups and get them done here.
Perfect. Yeah, thank you. Thank you.
Thanks a lot.
Thank you.
I'm passing it on to my dear co-host, Dr. Ganapati. Sir,
I have been given 480 seconds to give my comments on these 4 projects. Now, one thing which struck me was, which I believe in firmly, is a solution is not a solution unless it is universally available to anyone, anytime, anywhere, cost effectively. And I think all the 4 projects selected here today fulfills my idea of a solution. Now, the first 2 projects, I was intrigued by use of the word first in the world. I mean, I belong to the old generation. I think I'm very intrigued on how they managed to find out that no one on this planet Earth had made a similar project. Maybe their concept of the world and my concept of the world is different. So, we get the idea, but you don't necessarily have to say it is first in the world. Now, again, I'm talking of technology-enabled remote healthcare. I mean, you are all a converted audience. There's no need to convert the converted. We all know that there's no way OCTs are going to be available normally, even in Tier 2, Tier 3 places. So I think this is a fantastic method. And this retinal, I am not a specialist, but my general knowledge tells me that there is certainly, for the right patient at the right time, for the right thing, the extra additional information you get with an OCT could make a difference in the management of the patient. So I have always been advocating a hospital in your pocket, a doctor in your pocket, a lab in your pocket, and this fulfills it. I'm absolutely thrilled that you are going to the patient is not coming to you. So I think this is absolutely fantastic, and it's a great, great market ahead. Now, you give me 30 seconds more. Okay. The second one, of course, is socially relevant about smoking, but we have some long way to go. You need to understand whether recurrence is going to take place, how long it is, etc. It's not, in my opinion, ready for the market, but certainly we need to proceed further. Fetal heart rate monitoring, yes, even as MBBS students 50 years ago, we were taught the importance of fetal heart rate monitoring, and this is a very practical, viable technology which is required. The last one was absolutely amazing. The proof of the pudding is in the eating. All of us saw with our own eyes what it could be done, and most important, it is socially relevant, applicable all over the country and not confined to the elite of the elite of the elite. So in other words, I think all the 4 are great. One last message I would like to give. In an Olympic race, everybody talks about the gold medalist, maybe the silver medalist, maybe the bronze medalist. Most of us forget that in a 400 meters dash, the difference between Bolt and the guy who came 4th was probably 85 milliseconds. So please remember, it is a journey that counts, not the destination. And today, if you were in the 19, which did not come for presentation here, one doesn't give up. None of us would be sitting in this auditorium today if we had given up. So I'm sure the 19, next year will be the 4, the third year, the remaining, and so on and so forth. Thank you once again for this great experience. It's always a pleasure to interact with people without white hair. Thank you.
No, thanks a lot. I think I really appreciated something you said, sir. Most of our institutions never won awards for the first 50 years of our life. Right? I don't think Dr. Mehta has won anything for the last 70 years. Then all of a sudden now we've won like some 30, 40 awards in the last year.
Maybe
I'm pretty sure with Apollo.
Maybe you're too far ahead.
No, I don't think it's that. I think, guys, for many of you who presented, and this is a note to all startups, it doesn't matter which other awards that have recognized you. It matters that you're in this audience talking to potential customers here. So stop talking about the other awards you won. Focus on this group and think about what you can get out of this, right? I saw a slide that had exit options. What the heck are you putting it in front of potential customers for? Focus on what this group can give for you and make your customers happier, right? Which is why I think when you go to places, have clear asks, right? And a customer is always a better source of capital than any investor. And I say that as an investor, not as a customer, right? Please take that as serious advice. I'm not just picking on you, I'm picking on the others. I think with that, thanks a lot. You will hear the ultimate winner later today. We've got to hold some of you back for valedictory. But now you've all woken up, and I see Dr. Dilip and Dr. Rajkumar with huge smiling faces. So therefore, we've done something. Even Naveenji looks like he's fully woken up. Thank you, Dr. Chitkara. And I think with that, over to you. Thank you. And thank you, Dr. Ganapati.
Thank you, Mr. Samir Mehta and Dr. Ganapati, sir. We'll move on to the next session. For the next session on technology disrupting healthcare delivery, we invite the moderator for the session, Mr. Srinivas Ramanujan, onto the dais. Mr. Srinivas Ramanujan is the CEO at the Will Grow Innovations Foundation. He engages closely with the Government of India in nurturing social entrepreneurship and advocating for greater participation by commercial capital providers in this space. He serves as an executive steering committee member at Aspen Network of Development Entrepreneurs. Additionally, he volunteers as a committee member for the Startup Showcase at Startup India and as a technical expert for the BIRAC. Devashri, can you introduce the panelists for this session, please?
My pleasure, of course. Let me invite on stage our eminent panelists for this session. Mr. Rajat Jain, Ms. Divya Balaji Kamerkar, Mr. Girish Raghavan and Dr. Charuta Manke and Air Commodore Dr. Ranjan Kumar Chaudhary. Mr. Rajat Jain, a brief introduction about all our panelists. Mr. Rajat Jain is a founder and managing director of Sunfox Technologies. He's a social entrepreneur with a background in incubation management. His innovation Spandan, which diagnoses heart attacks on a smartphone for less cost than a cup of a tea, has been recognized by the Honorable Prime Minister of India. Ms. Divya Balaji Kamerkar, she is the CEO and co-founder of Pinky Promise, AI-powered digital clinic for women on a mission to make sexual and reproductive healthcare more personalized, compassionate, and outcome-driven through clinical decision-making models that are more representative of women. Welcome, Ms. Divya. Mr. Girish Raghavan. Mr. Girish is Vice President of GE Healthcare India Digital Engineering and is tasked with the mission to accelerate digital transformation in healthcare through technology. He led the molecular imaging and computed tomography engineering.
I'll take it over. He led the molecular imaging and CT engineering teams in India, where he made significant contributions to the evolution of Revolution ACTS and discovery of IQ products, two remarkable products that made PET and CT scans affordable to the masses in India.
Dr. Charuta Manke, she is the head Department of Ophthalmology, Hindu Hriday Samrat Balasaheb Thackeray Medical College, and Dr. Aaron Cooper, Municipal General Hospital, Mumbai. She is the founder member of Community Science Alliance, a collaboration between clinicians, academicians, scientists, and community-based organizations in India and the US, dedicated to improving rural healthcare delivery systems in India. Welcome, Dr. Charuta. And last but not the least, Air Commodore Dr. Ranjan Kumar Chaudhary, sir, Advisor to Healthcare Technology, National Health Systems Resource Center, NHSRC, India. Recognized for devotion to his duty of high order in the healthcare sector, and also the recipient of the Presidential Award of Vishisht Seva Medal in 2016. Welcome, sir.
I request a round of applause to the faculty as well as the moderator who is on stage. Over to you, sir.
I don't think any of us have a presentation, so I'm going to jump right into what we're here for. Sorry? Okay. I'm going to jump right into what we are here for. And now that we met our interesting panel, I want to pose a bunch of questions, and then nobody's going to walk out there to speak. I think all of us are going to speak right from this chair here. Commodore, I have a question for you. I think it'll be great to understand what the NHSRC does and what you do in getting technologies adopted across systems. Right? That's one. And the second thing, a follow-up, is how do you ensure scale and adoption? I think we've spoken a lot today about adoption. We've spoken about the trust deficit. How do you overcome these?
Thank you, Mr. Srinivas. I must place on record my gratitude to Caho to give this platform, to reach out to such a lovely audience here. Self-introduction, you must have heard. I actually work in a premier think tank organization that's called National Health System Resource Center. We are providing technical support and inputs to the Ministry of Health and Family Welfare to develop policy. And particularly, we look after the primary healthcare segment. That is up till the sub-center to the DH level. Now, in my division, Healthcare Technology Division, actually deals with 4 or 5 verticals. Let it be dialysis or the equipment management, the diagnostics, the AERB, but most importantly to this relevance to this thing is we are also managing the innovation health products. So you all must have heard about the National Health Innovation Portal. That is managed by us. We invite such type of innovative solutions and technology products innovation in the portal submission, and then we apprise it and put forward to the Government of India, which is a duly constituted technical committee is formed with experts from all over the industries and other institutes, and then we apprise it. So this is the basic job in nutshell in NHSRC we do. And for the technology disruptions, I can say before going to the adoption and scaling up, you see the technology depends, the innovative technology depends upon 3 A's, basically the need. Accessible, affordable, availability. Easy to use, reliable, trustworthy. And the COVID pandemic has shown that technology disruption just sneaks in because it's need-based. And sustaining the innovation in the system is a very difficult job, and adoption is yet another. You know, the technology with the Moore's law, it advances so fast, it's 6 times what you're thinking right now. If I say ki right now the technology has moved to technology fusion, it's the sensor fusion system, what we are thinking of. For an example to understand, it's the biomechanics, a person with a gait disability, you can do a sensor fusion technology with his wearable sensors, with GPS positioning system, the magnetoscope, the gyroscope, accelerometer. So he will be given. Similarly, sensors fusions, you are seeing only the part of the doctor getting the report of the patient, but the patient also need to get a predictive analysis of his condition in front of him. So these are the latest technology. We are trying to have the data lakes wherein you will have the AI enabled system for punching the right keywords to get what you want. And then you have a data analytics, of course, we are using it, and AI is being used in every day by us in every way of life. So it's going to enable, but this AI has to be now rooted in the right direction. For the adoption, I must say the difficulty lies in scaling up. Usually the innovations are patented. Until and unless the industry comes for the R&D, it supports the startups, and it give them a platform. They choose that yes, resource is a big constraint, and then it's the availability. I come across so many good, fantastic innovations, but they are in the pre-commercialization level. When I talk about how you can scale it up, they are clueless. Basically, they are waiting for some industry to take it up. Now, as I said, instead of a push, we should have a pull. And we should look after to those technologies which are very simple, easy to use, very acceptable by the community, reliable and replicable. So these technologies, you can have a GEM platform is there where you can put up. I tell the states as and when we go, these technologies are better than what technology you are using. For example, I'll just give one example, like for hemoglobin estimation, you all must be knowing that digital hemoglobinometers have come. Now, the health technology assessment is done by our department and along with the DHR. We know that, when you buy a hemoglobinometer, there are different brands and different varieties. So you have to tell them which is better, which is more reliable than the other brand. So these job functions, the ICMR does, the DHR, Department of Health Research, they submit it to us, we upload it, and we guide the states to adopt that. And I'm very happy that few of the states, because it's how you present it, like Andhra, Madhya Pradesh, they have already adopted a better system of hemoglobin measuring system. I'll stop here, otherwise I can keep on going. Thank you.
Great. I have a follow-up question to this. Because we are at a private sector, Cahotech event, and because you are looking at public sector and driving adoption, how do you think your system and the folks at Caho and the members of Caho can work together to bridge the gap that you just spoke about, that many people don't know whether it's pre-commercialization?
Okay, see, there are many hurdles in this. In advanced countries they have a system of T1. Here in our procurement system in the country, we have the L1 system, that is the LCS, least cost. That is one of the hindrances, I will say, in adopting a better and quality technology. A better and a quality technology will not come in least cost. It will come in a cost. So either exemptions from, the GSTs or giving them a preferential way might be one of the way to look at getting it adopted, or a technology, if it is so good and so reliable that the community seeks for it or the states demand for it, I think that is the best strategy to adopt a technology.
Great. Thank you. I think what I'm just picking up is number one is your portal. There are many startups here, many startups which pitched yesterday, which ought to be on your portal. That's first. And second, I also saw the amount of networking you were doing with other industry folks, and I anticipate more people are interested in talking to NHSRC after that. But I wanted to move on to Charuta. How do you're working to see how healthcare protocols can be more contextualized to rural under-resourced settings, right? So for far too long, and pretty much everyone in this room is so used to urban large hospitals. What are you doing to make it more accessible for most of India?
Thank you, Srinivas, and I want to thank Caho for giving me the opportunity of being here. It's a wonderful conference. So basically, I am an ophthalmologist from Mumbai, but
I am currently working with a group of physicians from all over the world, and we formed a collaborative with community-based organizations, setting up public health clinics in rural, tribal, and beyond. And what happened is, during COVID, we came together due to an ask from Swasth Alliance to create clinical protocols for COVID care in such areas, because tens of thousands of oxygen concentrators were going there, but there was no real knowledge of what to do, how to do. People would not even come to the doctors or the clinics. And many guidelines came about. They were not really scientifically proven or tested, and these were extraordinary circumstances. But our job was, all of our jobs, is to learn very fast from all that and move forward. And that's how a lot of tech has boomed in healthcare delivery systems also. What we realized, and what most medical practitioners today would remember, is that we studied clinical medicine in urban medical colleges mainly, and then after that were thrown into rural postings in a melting pot of, it was a wretched scenario with sometimes no drugs, no equipment, no investigations, and no mentorship. And we did not know what to do, and there was a big disillusionment, which still happens today. And we all, as we started working during COVID, we all realized that this is an intervention which is a very low-cost, ground-based, ground-level intervention, which is need-based. I'm all for technology. In ophthalmology, we are getting great, generative AI-based technology coming in, which is helping us to screen in rural areas. But a lot of technology that comes into healthcare delivery is supply side. And what is happening is that there are amazing solutions, and then we try to fit it to a need. But there are some needs which are not really immediately visible, so we need to also go a little bit demand side. And such a simple solution is that to create clinical protocols, care pathways, which are evidence-based as well as contextualized to the remote and low resource settings, where sometimes these pathways are just not available. I, as a doctor, and all of us doctors have learned Harrison, Davidson, Western medicine, because the guidelines are better, clearer, and also we have better, even now for the newer guidelines, it all comes through robust research which happens in the Western world, which has ways to do this research, while we do not have a lot of research in our rural settings. For example, I was telling somebody that I learned how to treat many things, but when I went to rural India, I do not know how to treat a snake bite sometimes, or I do not know how to treat heart failure when the best 3 drugs are not available, or when I don't get a troponin. So what we have done is, we have started working on 2 verticals. One is creating a fellowship, and one is creating these clinical care pathways, which we will make open source, so that even the urban physicians will benefit from it, because many of us learned 20 years ago and then still practice the same medicine, because we don't have repeated accreditation requirements, and sometimes not enough or accessible CMEs. What is going to happen is that we, with these protocols, we will give the best case treatment options and mentorship to rural doctors, and incentivize them to be able to treat better. When a doctor is able to treat better and reach the community benefits, and that is incentive enough for a good doctor to keep on continuing the treatment in the rural setting. One of the things that Srinivas was talking to me about is the challenges and acceptance. Yes, there are specific challenges when we started working to create these protocols. The one thing is that they have to be updated all the time. Secondly, they have to be accessible even sometimes when the internet is not available. And there are certain things where the acceptance from the community of doctors as well as from the patients may not be great. For example, even in diarrhea today also, we know that evidence says that give ORS, and yet many times the first line of treatment is antibiotics. How to go about that. That will only be done by, thinking about behavior change. Or there are pathways where heart failure, the first 3 drugs are just too costly or not available across rural India. Or for chest pain, if troponin C is not available, or you don't know how to read an ECG. So there are so many new solutions coming up, but all of these solutions integrated together with the basis of, the knowledge which can be provided at the touch of a button on the mobile phone, or podcasts, or something like that, which is what we are trying to convert our content into now. So this is where collaboration across digital health delivery systems and new tech is going to come, and that's what we are trying to do, and that's how we will help with disruptive healthcare delivery.
Thank you, Charita. I think what you're doing is trying to make health system, and I remember a previous speaker, Dr. Ganapathy, you were talking yesterday about instead of healthcare and medicine, we should be talking wellness, and I think what you're doing is converting protocols from textbooks into something accessible, relatable to patients and folks closer to the ground. Yeah, and maybe if you have time later, I know you have a case loaded up on the computer. We could probably show it on how the most simplest of technologies can decode, decode something which is more complex. But I want to move on from folks building the system and building infrastructure to someone who is creating solutions, right? Rajat, the founder of SunFox, if you got a chance to look at the booth outside, this really tiny ECG machine, fantastic guy, fantastic innovation. But I want to ask you today more on when you built this and you tried to sell, because a lot of Caho's, this tech conference is also how do we commercialize solutions, right? We are not here just to invent and keep it on a shelf. Neither are we sitting and saying that hospitals have the best equipment and it's always going to be that way, right? We had Karan from Bain talk about the challenges, and we also had this person from Dr. Indubhushan talk about how our cost of care is pretty high, right, compared to even a lot of other underdeveloped countries. What you're doing is quite disruptive. But what I want to know from you is who champions this change in the system for you, right? And how is failure accepted within the system? And lastly, how do you build trust within the folks here?
Thank you so much. Really tough questions to answer, but I'll try to loop in with my story. How do we do that? So when we talk about the advancements in the healthcare, I want to take you through those rural remote settings where we are today. So we are living in this era of IR thermometer, right? COVID में हम सब लोगों ने use किया है. You just put it at distance and you get the temperature. But if you go to the last mile, you will still find a lot of mercury-based thermometers and those conventional thermometers being used. So the challenge is we are evolving from the technology perspective, but the penetration at the very last mile is still somewhere, there is a gap. So related to my work, like in cardiology, so ECG is a mainstream and the preliminary solution which a cardiologist or a hospital need to screen any patient who is coming for that. But do we see any penetration of ECG machines at the last mile? Or if you look at the time to the first test by any patient. So I'm brought up in a small village. My place is about 100 kilometers from Delhi. But अगर आपको एक ECG भी कराना है, अगर आपको palpitation हो रही है, so either you panic in every small symptom, or you ignore the symptoms. These are the two cases. And you have to travel at least 50 kilometers to get the first accessibility. So now there is a delay in getting to know that you need a medical attention. Medical attention तो आप तब लेंगे ना जब आपको पता चलेगा. So now this is the problem, how we were solving it. So answering to your question is when, who champions the change here? So probably the change has to be, the champion has to be the founder, but the face is the patient always. You go with a minimalistic and the frugal approach to champion that change, but ultimately you will not be the face. The face has to be the patient, and the patient is somebody who can actually take your solution. So when we try taking our device, so people who don't know about what we do, so we make a portable machine, and all of us probably have seen ECG machines in our life, but this is a version of ECG machine which we make, which gives you ICU grade information just on your smartphone. So we started reaching to the hospitals. Hospitals already have the established infrastructure, and they don't see a need, to migrate to any other solution. Similarly, when we go to a patient, so there was a gap. Patient was not understanding, or even a patient is taking the machine to the doctor. So the question comes, why do you need this machine at home? So how it worked for us? We started going to the GPs. And हमारे यहाँ पे कहावत है कि प्रत्यक्ष को प्रमाण की आवश्यकता नहीं होती है. So when we started going to the GPs are the people who are the first point of contact for most of these patients. किसी को कुछ भी होता है तो we first go to our family doctor, somebody who is accessible around us, and then we go to the tertiary care. So when GPs started using our product, so now the report which is being circulated, so imagine a GP does a ECG, say at the clinic, and that something is abnormal there. So the report is circulated to a cardiologist as well as to the patient. So now if something is wrong and a cardiologist identify, yes, this is something wrong, and it is actually led by this basic test. So they actually, start understanding that need, why it is needed. And now eventually, without actually going into other channels, so just visibility in this huge case led us to, led us for the penetration, there. The failure, I think, has to be mostly accepted by, again, the founders only, because everything spilled over, and you go to a patient or a doctor. So I mean, we have actually faced the harshest responses, or you can say that criticism, if there is something related to the failure. So ultimately, you can't compromise the quality. You can't compromise the kind of care which a patient needs, because we are in a quest to provide the best of the care in the minimal possible way. So there is no scope of failure also. Ultimately, we only celebrate the established enterprises, but I mean, we hardly see any celebration of failures. So I mean, the founders or the enterprises or the team, they have to actually accept the failure and reiterate or pivot or whatever way they figure out. And the trust again comes from the patient. A patient comes to you directly. Doesn't matter how many clinical trials you do, doesn't matter how many users you have or whatever. But when you see a patient coming to you and saying, hey, I was not knowing what exactly is this, but due to your device, I have my father with me. Or I mean, the trust, somebody taught me that the device which you are building, can you use it on your father? Do you have that kind of trust on your innovation, that if that's the D-Day or that's the moment, would you like to use your product? Can you trust as a founder, as an inventor on your product? So I mean, I've been one of those founders where I actually diagnosed my father as a very first, huge case, and prevented the need of angioplasty ultimately. And so, I mean, the patient lead this whole trust game again. So, सब लोग तभी trust करते हैं if the patient can trust. Thank you so much.
I still remember there was an interesting case. I mean, just a disclaimer, Wilgrow is an investor in Sunfox. So with that disclaimer out of the way, I still remember a conversation when you came to meet me and we met at a Starbucks in MG Road, and you were telling me about a buyout, unsolicited buyout offer from this large established healthcare company, which apparently is almost the de facto solution in every hospital. And my response was, listen, I think they're coming after you because you've cracked something that they've not. They're going after only the hospitals, you're going after the GPs. And there are far more GPs, far more business here, they're just in the cream. And I think what is exciting for me, and I suspect that's going to be more so for the Caho members, is the disruption where you're taking on from what was happening early today morning. Things are going to get closer to the ground, right? Things are going to not work in the same pathway as before. And I suspect solutions like this, or like yours, Divya, who I'm going to come to next, where you're just completely changing the paradigm, is going to be a de rigueur. And on that, Divya, how did you build your 99 rupee consultation for women's reproductive health story?
Thank you. At Pinky Promise, what we do is we make it instant and extremely affordable for a woman to get a quality diagnosis for any reproductive healthcare issue she may have. And we do this using a lot of AI ML and with the right providers. The way that the platform actually works is if any woman, anybody, if she has a symptom or any complaint associated with her reproductive health, she can come to our app, and in a very, very conversational manner, she can actually describe her symptoms and her medical history. In seconds, our software has already analyzed this using the protocols of the best in class medical institutions. About 150 plus such protocols are actually used by us to build our base machine learning. And it comes up with a diagnosis, it comes up with a prescription, it comes up with a set of medicines, it comes up with a set of tests, everything, and sends it to a gynecologist who is the attending gynecologist at that point of time. She, on her app, is able to read all this. In 2 minutes, she can verify whether the information is correct or not, given the chief complaints and the medical history of the patient. She can also voice or video call the patient or do whatever she requires to come up with a medically sound assessment and verify the diagnosis and send it ahead. But basically what we have done is in 2 minutes, we have moved from a patient actually having a problem to having a solution. And in India, it actually takes weeks and often months for a woman to go to a gynecologist first of all, and then actually get a quality diagnosis. We have of course tied up with a range of pathology and radiology solutions. Wherever required, that is also prescribed. But the reason why we built this is interestingly because of a personal story of mine. In 2021, it was peak COVID, and I was pregnant, and I started developing some complications, and most medicine had just gone online at that point of time. It was risky to actually go in person to consult a doctor. So I went from one consultation to another, and it took me weeks to get a proper diagnosis. And in a world where you get a loan instantly, you can make a UPI payment instantly, in 10 minutes, groceries are delivered to your doorstep. Why does it take weeks for someone to get a diagnosis? And secondly, if you look at the landscape of India, about 75,000 gynecologists, FOGC plus others, 360 million women of reproductive age. Most gynecologists practice in and around the metro areas of India. So if you look at tier 2, tier 3 and smaller areas, there's really hardly anyone there for gynecological care. So because of access problems itself, if a woman is having a problem, her periods are delayed, or she's having a urinary tract infection or something like that, she does not know who to go to. Secondly, these issues are taboo topics in our country, right? So it takes a lot for someone to even say, okay, I want to go to a doctor. But the amazing thing is that today, thanks to sort of the penetration of cheap smartphones and India having the most affordable 4G internet rates, women are really going online to search for their reproductive healthcare conditions. So the interesting thing that we stumbled upon that made us build our Pinky Promise is that in India in a given month in English alone, reproductive healthcare keywords are searched more than 100 million times. So we built a solution that just goes directly to the customer. And I think for us, you had asked questions in terms of sort of who champions the change. For a disruptive technology like Pinky Promise, our champion has largely actually been, we've had two categories of champions. First is just the women who require care who don't go to a provider today. When we polled about 10,000 women on the Pinky Promise platform, we actually found that 67% of them had never gone to a gynecologist. So we were the go-to point of care for most women. And I think the second are actually the providers who work with us. So we get a lot of advisory support because our systems need to be trained, our artificial intelligence needs to be good from a really amazing set of doctors. And we also have doctors working with us. And all the edge cases, all these like really difficult situations are tested by them repeatedly to make sure that what goes out to the patient at the end of the day, there is no risk at all. So I think these two have been our major champions of change. And the diffusion of innovation has also happened because of three reasons. The first is environment. COVID really helped. People were used to going online and getting a diagnosis. The second was entrepreneurial doctors who were working with us to enable our technology to become better. And then, of course, the third were patients who today, this Gen Z, they demand the most patient-centric quality, like their quality of care standards are very high. It takes very little for them to be very angry with us. So we're able to provide the right quality of care because of these three sort of champions of change. That's basically been our journey so far. So thank you.
Superb. No, I think just a bit of a sobering thought for me though. What both of you said is your champion has been the patient, not the caregivers. And a very interesting fact, 67% of your customers actually are customers that the hospitals here have missed. I mean, if someone is looking at business, you guys just lost the money. Both are just very, very interesting in my mind that it's not doctors and not caregivers who are building trust, but patients themselves taking their, their health in their own hands. That's interesting. And the second piece is how many we are missing and which can be easily caught. Yeah. And the third piece, in fact, you said, instead of a gynecologist, you're talking about endocrinologists helping you a lot. Right? And logically, and this goes back to what Charita was talking, is in a way there are pathway that the medical fraternity hasn't envisaged. You have a problem in reproductive health, you would go to a gynecologist. Here, that's been skipped to an endocrinologist, but there are two different people could be supporting the same way. That's very amazing for me. Yeah, that's new stuff. And I want to move on to the industry, so to speak. Girish, not the last, I mean, not the least, not the last, whatever, but I want to, your take on how do you approach adoption and disruption of technology when you're trying to get solutions into the market? How does the industry build trust?
So, firstly, I want to thank Srinivas as well as Kao for the opportunity to be here. So before I get into the adoption part, we'll also talk about the issues we are referring to here, right? So as most of you know, healthcare is going through some massive transformation, right? The kind of reforms we are seeing in healthcare is unprecedented thanks to COVID. Actually, COVID exposed the vulnerabilities in a lot of health systems around the world. And you're seeing many, many countries throwing money into healthcare to such an extent that maybe 5 years from now when we look back, we won't be able to recognize the healthcare system we have today. Just the way we're talking about UPI and banking reforms and so on and so forth. Healthcare reforms are going to be unprecedented. So what is driving some of these changes is also the fact that the healthcare systems are very rigid today, right? So every year we are seeing a lot of people coming out of poverty into middle class, but the propensity for them to get healthcare access to healthcare system is very limited. So our healthcare systems are not so elastic enough. It can take all the folks coming from poverty into middle class, right? And of course, you go to many hospitals, you'll see issue with productivity, efficiency. In fact, there's a customer in Bangalore whom I met a couple of years back, and I asked him, what do you want? So do you want a 1,500 slice CT, 2,000 slice CT? He said, no, I just want, today I do 20 scans in a day, I want to do 21, right? So very simple. They're going out of productivity, efficiency, and so on and so forth. So of course, a lot of problems the industry is trying to face today, accessibility, precision care, precision health, precision medicine, all those things. But I'll pick up two things in the context of what Srini was talking about. One is about the availability of trained technologists today. we are having an acute shortage of trained technologists and clinicians and physicians around the world. And even if you have, it is more concentrated towards big metros. And as you go to tier 2, tier 3 cities, as they were talking about, you find less and less people, and the ratio is extremely skewed. And one of the reasons why you don't see healthcare penetrating to tier 2, tier 3 is not because of not having affordable devices, it's just that you don't have people who can use those devices in those markets. So one thing what companies like us, device manufacturers are doing today is, how do we democratize healthcare to a large extent? Which means that we want to, traditionally the way approach has been that the healthcare systems are considered to be dumb, right? The operator is super smart, intelligent person who's going to operate the system. The healthcare system is, the CTs or X-rays or MRs are dumb systems, and it doesn't know, it has to be told by the operator on what has to be done. We are just changing the paradigm, and we're making sure the systems are smart enough, right, and intelligent, that it doesn't matter who's operating the system. So to give an example, if you're an MR scan, the MR scanners of today are so smart that it can tell the operator that the patient has moved, right? And before the patient goes off the table, the MR scanner would just say, hey, look, there's a problem, you need to do a rescan, right? Or in a CT scan, it could even go and fetch the protocols and tell, for this patient who's obese, right? We can look at the hospital system or risk system. It can just pull the records and recommend to the operator, saying that for this patient, this is the protocol to be used. So systems are extremely smart nowadays, and that is what is going to make a huge difference to democratize the quality of healthcare. So if you look at the tier 2, tier 3 scenarios, obviously you'll realize that this makes a lot of relevance, right? The quality of operators. The second big thing we're going after is also outcomes. So clinical outcomes plays a huge role today, right? As we've spoken in the past as well, the third largest cause of death in the world is medical errors, right? It's very common because it is purely, we have very less assist tools available today in the industry. We go through a lot of challenges because there are not enough mechanisms available. There's a lot of variation in experiences, right? You have highly experienced doctor who spends 1.5 minutes looking at a patient record. The kind of outcome he gives may not be equivalent to another junior doctor or less trained doctor who spends 2-3 hours looking at the same records. So it's very huge variation. So what medical companies like us are doing is to provide, using AI, ML kind of technologies, to provide with assist tools which will help them to make it much more easier. So if you go back and see, 10 years back, 15 years back, right, a radiologist would maybe look at 10 scans or 20 scans. Today, the same guy looks 100 scans a day. From morning 8 o'clock to late night, he has to go after records, and it's so difficult for him to have the same attention levels. So using these technologies, we're able to help assist tools through which he can make the right calls, and thereby again try to democratize the quality of healthcare. So two big problems we're going after, and the trust comes purely by data, right? So one, that is a big need. We are not seeing resistance in the industry today to take these technologies because it's going to help them to give better outcomes. But what is very important in the healthcare industry is to provide the kind of data and I would say clinical proof that it gives trust. So a lot of companies today, we spend a lot of time building those proof, right? Proof for us to be convinced is the right thing to do, and also proof for our clinicians to make sure it makes a lot of sense for them. Thank you.
What I'm actually taking away is consistently the theme is a reality that we're facing in India is that we don't have people who have the requisite skill. And that's not going to go away anytime soon. So pretty much the trend on what all of you spoke is, okay, how does we interact with the patient directly? How do we make the machine smart? How do we make using AI and digital solutions to build in a certain amount of intelligence that otherwise a human being was expected in the normal paradigm. Yeah. And I think that's a big takeaway, frankly, for me and from what I'm taking from the panel, especially in the context of what we're talking today about, making it accessible, efficient, and affordable. My conclusion is that the machines are here to stay, and the machines are going to do a lot of the job, and that's because none of us here we don't have that scale in talent and skill, which is not going to get solved by more colleges. So let me pause there and take any questions. Yes. How do we get mics to people? Yeah, we have enough mics if you want to hold on.
Myself, Dr. Ashok Kumar Khandelwal. I just want to ask you, because as the radiologist is using 7 or 10 AI app, for reporting MRI. Why not the tech industry is going in for emergency? Again, we can use the 10 apps and then make a diagnosis early and start treatment, because most of the emergencies managed by the junior doctors and they don't have enough experience. So why you are not venturing in these areas?
Sir, may I respond? You will be happy to know that the work is going on. We are in lookout for robust clinical decision support systems. And there are SDGs, workflow SDGs developed by ICMR. They have been integrated. And this is also will become a reality. We are talking of a technological advancement of virtual e-care, e-ICUs, what we had in COVID, and remote nursing. So these are all in the pipeline, and it's only a time. It's the time is that you will all see these.
Thank you.
Okay, I don't think we have any more questions. Awesome.
Thank you, sir. We request all the dignitaries of the session for a photo shoot, requesting them to come forward. Thanks, Mr. Srinivas, for keeping it very crisp and to the point. And thanks all the panelists. With this, we'll conclude the session on technology disrupting healthcare delivery. The next session on best of hospital innovations and technology adoption will be hosted by Dr. Reema Bari and Dr. Dhruv Chakravarti. Over to you guys.
Thank you, Dr. Suvin. So we start with the session of Best of Hospital Innovation Showcase and Early Technology Adoption. And for that, I would like to invite Dr. Narendra Pense, our moderator, speakers, sorry. He's moderator. Acha, moderator, Dr. Narendra Pense, and Mrs. Upasana Arora. Welcome, Doctor. Dr. Narendra Pense is VP Medical Strategy and Operations, Fortis Healthcare. He's also Principal Assessor and Lead Faculty for NABH, Advisor Medical Operations, Fortis Healthcare, Advisor Medical Strategy and Operations, King's Hospital, Colombo, having immense experience as Head Medical Program Management and Clinical Talent Management, Functional Lead Design and Implementation of Enterprise Level HIS and EMR, Medical Lead Projects, Healthcare Facility Design, Medical Program Planning, Infrastructure, Equipment Planning, Head Clinical Outcomes, Design, and PAN Network Implementation covering all key specialties. Collaboration with International Consortium of Health Outcomes Measurement, and also Functional Lead International Medical Operations. Let's give him a round of applause, please.
I also invite Dr. Sunil Ketripal, sir, onto the stage as our second moderator. With 35 years of rich experience in the area of hospital administration and strategy, he is a medical graduate from Kurnool Medical College. He is a director of AHPI presently and is in charge for special projects and policies of AHPI. And he has also many awards and accolades to his credit of his experience. We welcome Dr. Sunil Ketripal, sir, on stage. Sir, yeah, now you people can take over the session, sir.
Thank you, and very good afternoon to all of you, ladies and gentlemen. I think before we formally invite the hospitals and innovators to come and showcase their presentations, I think a big thanks to Caho, particularly Cahotech, for putting together this forum for people to come and showcase their innovations, their products, their path-breaking disruptive practices, and also to hospitals and healthcare organizations who have adopted them. And this particular session is devoted to listening to them, their stories. These are some of the shortlisted presentations for the various award categories which are there. So we'll be inviting the presenters one by one to come and talk about their presentations, their areas of work. Request all the presenters to please stick to the time. We are running behind schedule, so we'll request that the time taken be 3 minutes for each presentation. time permitting, we'll have one or two questions with Dr. Khetrapal here and maybe with the audience. So that will be the sequence in which we run. Dr. Khetrapal, anything from your side, sir?
I think we will listen to the presenters, and they are the shortlisted presenters. And of course, if there are any questions to be asked to them, I'm sure they will be doing their best. And if there are any questions to be asked after their presentation, we will be asking them, or we will even ask the audience to, put a question if they want. So that's it, I think, from our side. And best wishes to all the participants.
Thank you. So the first category of awards which have been shortlisted here for presentations is the early adoption of technology. I invite Ms. Jennifer Priya from CMC Vellore to come and give a presentation on their topic, which is on in-house calibration of biomedical equipment.
Very good afternoon, one and all. I am Jennifer from CMC Vellore. Here I am going to present about a model center for fully automated in-house calibration lab. On the topic, a model center for fully automated in-house calibration lab, biomedical engineering of CMC Vellore, NABL accredited. We are proud to say that we are India's first NABL accredited healthcare biomedical engineering calibration lab. Our main objectives is to ensure safety of patients, minimize downtime, extend lifetime, increase efficiency, reduce maintenance cost, ensure accuracy, reliability, and availability. Our journey started way back in 2010, where we were presented with a non-conformance and pre-assessment of NABH medical equipment calibration. In 2011, the calibration of medical equipment were outsourced. Charges were very high for minimum quantity of equipment. Calibration performance by the external vendor is not at the desired level. In 2012, BME planned the in-house calibration at the existing facility of 6 analyzers. In 2013 to 16, BME executed manual process. 2017 to 21, it is a semi-automated implemented by ANSYS software. And 2022, we are NABL accredited in medical device calibration with 6 advanced analyzers covering 9 categories of equipment and 24 parameters. And we were now currently associated with Fluke Biomedical in the development process of 1K, where we started the calibration of full automation. Evaluation of calibration, it was a 3 different stage. First is a manual calibration, where we had manual data entry, no control on the procedures, and manipulation was possible with no digital copy and multiple manual evaluation. With the ANSYS software, we had some manual auto data capture and limitations in the template, corrections due to partial manual entry and partial evaluation. And full automation, it was complete auto data capturing, standardized and customizable templates, no manipulation, and auto decision and evaluation making. Here we present with the highlights and challenges. Pre-automation, it was a step-by-step procedures with multiple connections and reconnections, manual capture and verification, no restricted access, manual approval and calculation, handwritten report and manual upload to dedicated data storage server. Template design limitations was not as per NABL or ISO standards, possible manipulation of reports, and the limited capacity of equipment calibrated per year was 2,000, and with an average time of calibration 30 minutes per equipment. When post-automation of where we had fully automated procedures, and it's just a one-time setup with auto advanced sequences. Auto capturing and validation, completely password protected, automated verification of algorithms, reports are auto-generated and integrated with the CMMS software in cloud-based storage. Templates were designed to meet the NABL requirements, and nil manipulation with increased capacity of equipment, where we had 6,000 equipment with a decreased or average equipment per calibration is 10 minutes. Here we present with the cost effectiveness with one-time initial investment. ROI can be retried in the first year itself, where the manpower was minimized, one software for all the masters, single license for 100+ users, accessibility to the crowd, not a PC dependent one, and its software upgradation free of cost till the license validity, and suitable for medium large scale facility. We have projected the average equipment calibrated in a year, where we had 1,900 equipment per year way back in a manual calibration, which tripled the amount to 4,600 equipment currently. And the downtime has decreased from 60 minutes to 10 minutes per equipment. Way forward, we are the first to enable accredited hospital calibration facility in India with full automation of procedures and calculation, and we are moved on to mechanical and thermal parameters. And again, ahead in 2024, we are moving on with the full automation of lab equipment calibration, and we are going forward to be a proficiency testing provider for medical devices equipment. Thank you.
What about the critical equipment downtime? Is it a part of your thing? No.
No, sir. This is fully automation of our calibration procedure.
The downtime you have mentioned, you have measured the downtime.
Critical downtime of the equipment, we maintain a software, in-house developed software, where we maintain the response time of the equipment.
Okay.
Thank you. You mentioned that the software that is being used,
Yes,
is
sir.
it a third-party software, or that software is also developed by CMC team itself?
No, sir. We use Fluke Biomedical Master Analyzers, and we are using the software developed by Fluke Biomedical.
Thank you. I think in the interest of time, we'll continue with the
you.
presentations. The presenters will be available in-house for any questions that the audience may have, can be taken up later on one-to-one basis. The next presentation is from Max Super Speciality Hospital, Vaishali, on Hemovigil, a step towards safe blood transfusion to the bedside. Dr. Abhinav Verma, please.
So good afternoon all. At the outset, I would like to thank the organizing team for giving me opportunity to present this very, very important topic and study project. Hemovigil, a step towards safe blood transfusion to the bedside. Now before starting the presentation, I would kindly request you all to just search on the Google, wrong blood transfusions in India. And you will be surprised to know that serious, potentially fatal issues exist in the transfusion process due to human and clerical factors. Recently, a hospital has to pay 1.4 CR as a compensation to the patient for wrong blood transfusion. Studies have indicated that bedside errors contribute between 80 to 85% of the transfusion errors. A number of studies and reports from National Hemovigilance Program, SHORT, that is Serious Hazards of Blood Transfusion United Kingdom, and HVPI, that is Hemovigilance Program of India, have indicated that the risk of mistransfusion is many times greater than the risk of transfusion-transmitted infections like HIV, hepatitis B and C, and typically results from the errors made at the bedside. But it is very sad that transfusion process has traditionally received very less attention. So patient safety initiatives needs to focus more on the bedside. So aim of the study projects was to highlight the importance of Hemovigil, which is a set of surveillance procedures of the whole transfusion chain that ensures patient identification and reduces identification-related errors of transfusion. Coming to methodology, it has got three key components: a Hemovigil wristband, a software, and a digital transportation box. Now coming to Hemovigil cycle. So whole Hemovigil cycle is very easy and it is in 5 steps. In the first step, we'll attach the transfusion wristband to all the patients admitted in the hospital who require blood transfusion. In the second step, we'll peel off one label from the transfusion wristband and attach to the samples. Generally, we collect 2 samples, blood samples, one for blood grouping and one for cross-matching, and they will be sent to the blood center. In the blood center, the technician will scan the barcode label attached to the sample tube, and the Hemovigil software will automatically generate a unique transporter key. In the fourth step, when the issue slip is generated and the support staff come down to the blood center to collect the blood products, The technician will put the blood component into the digital transporter and lock the digital transporter using the generated transporter key in step 3. And in the final step, once this digital transporter box reaches the transfusion site, the nursing staff will open the digital transporter by entering the number on the transfusion wristband. Coming to results and discussion. So in our study, Hemovigil was able to bring down blood transfusion sampling errors to 0% from 71, that is 0.79%. No wrong blood transfusion was reported. We found in our study that Hemovigil transfusion safety system ensures that even when similar named patients are admitted in a ward, even with the same blood group, no wrong blood transfusion will be given, as the specific risk code which is there on the Hemovigil wristband is attached to the concerned patient. And if a nurse or a clinician in the ward tries to open the Hemovigil digital transporter box with the wristband code of a similar named patient, the Hemovigil digital transporter box will not open at all. And it will indicate that he was going to a wrong patient for transfusion, and due to the Hemovigil system, an undue or near miss event will be prevented. So to conclude, I'll say that Hemovigil system is the need of the hour. Firstly, because it helps in curtailing the blood transfusion errors to 0%. It is very cost effective and it costs less than 50 rupees. An easy method that makes use of a combination of a hardware and software. It ensures a final and repeat check of the patient identification before blood transfusion, and it does not hamper the blood transfusion workflow process at all. So in the end, I would like to say it's always better to prepare and prevent rather than don't prepare and repent, and it is you to decide whether you agree to pay 50 rupees for patient safety or 1.4 CR. Thank you.
Thank you, Dr. Abhinav. One question, the Hemovigil box, I believe would require some batteries or something to be, to be functional. So any issues with that or with the charging process, or if the battery runs out, example?
Batteries can easily be replaced actually. So with a new battery one, that's it.
Okay, thank you so much.
Thank you so much.
Dr.
Thank you for your time.
The next presentation, Woodlands Multi-Speciality Hospital, Kolkata. This is on use of RFID in linen management. Request Mr. Arindam Sarkar to please come on stage.
Hello. Good afternoon, and thanks to Cahotech for giving the privilege to present this particular thing, though it is in a non-clinical category, and how the linen can be properly utilized in the hospital where we have thousands of linen in the circulation. So the main core capabilities of this particular project was basically to identify and automatically track the linen which is being circulated in the hospital. Since we have an outsourced laundry, so it was most important to track those linen, that how it is going to the linen, the other outside laundry, and when it is coming back, and also the number of washes and the lifespan of the linen. So manually it was very difficult to handle around 30,000 pieces of linen in a hospital. So what were the challenges before implementation was basically the inventory accuracy, the laundry cycle tracking, locating the assets, the employee productivity who are handling the linens, dependency on the worker or the employees, wash cycle tracking, and document tracking. So the stages that we have taken into the solution is basically we have got a dirty linen room which we call as a dirty utility, and then it should go to the fresh linen room after the wash. And also what we have done, we have put, instead of manual counting, we have put a fixed RFID reader gate, and also we have used it in the area where from the soil and the fresh linen goes and comes out. So the system, we have actually partnered with the Great Eastern Infotech and our IT team of the hospital. We have integrated the solutions, and it was customized as per the usage of our hospital. And then we have done a trial run for about 2,000 pieces of linen across the hospital, and we found it successful, and then we have gone for another 28,000. So total of 30,000 pieces of linen we have stitched in-house with the RFID chips, and we have started tracking these linens inside the hospital. So basically what we have done, we have put a fixed reader gate, and there is a handheld device for tracking this particular linen. So mainly it is the RFID tags we have used, and where the solution models actually given as basically the tag writing, encoding and mapping through the desk and the USB readers. We can track the fresh washed linen that is coming from the outsourced laundry. The departmental issue based on the requirement of the nurses from the different departments through the system, we use these handheld device to actually give the same number of linen by not manual counting through these scanners. We scan and then give this linen, so it automatically auto-populated into the system. The soiled out that goes out from the hospital to the outsourced laundry, that is it automatically collected, and the auto challans are prepared. And the gate pass is also being prepared based on this report. The physical inventory, which we do on every month, is basically now we are doing through this handheld device, not even touching the linen. So these are the few practical scenarios that the linen room people, they does it. These are the indent selections. Based on the indent selections, the departmental issues are given, and this particular all the data comes into that particular handheld device, and it is get auto-populated into the system and the software. And this is the fixed reader gate through which the soiled as well as the fresh linen goes and comes in. So item basically used was around customized RFID readers, the desktop, the handheld terminals. We have 2 terminals handheld, the think memory sinks, the fixed readers, and also the antennas on the fixed reader gates. And we have got 28,000 pieces of RFID chips which are stitched into all different types of linen used in the hospital. The reports generated was basically the washing report, departmental issue, soiled out, wash count, non-written items, which is, we have taken a time of 72 hours. If that particular nomenclature of linen doesn't come back to our hospital, that is also being tracked. So that in the report will show as a red particular color. The physical inventory is also done. Even suppose a doctor has locked his scrub suits into the locker and we are on the date of inventory, we don't have to ask the doctor to open the locker. We can do this tracking with the handheld device within a distance of about 10 feet also. So basically, if I look at the return of investments that the particular technology that we have adopted has improved the interdepartment engagement, reductions of the pilferage, support omniculture fulfillment, reduce out of stock up to the fresh linen, increase the inventory of the replenishment, improve the inventory accuracy, and also reduce the operating time. Mainly what we have got advantage of it is the accuracy of the count and the time that we have spent on the manpower for doing collection of the soil linen and then calculating it, counting it manually. We have just reduced around 30 to 40% of the time. So the benefits are basically the time saving, real-time record, operating efficiency, manpower savings, accuracy on the linen inventory, and also we know that which particular linen has got how many washes, so accordingly we can do the discarding or the condemnation of the linen. This particular technology, we thought that since everybody does in the clinical part, but being head of the non-clinical divisions of the hospital, I took this opportunity to utilize it so that this particular thing will actually help these 30,000 pieces of linen to be tracked at any moment in a real time. Thank you very much.
Thank you, Arindam. Excellent presentation. Just one question that you mentioned here, reduce the operating time. So this operating time, what is this referred to, the operating time? Is it related to the time between procedures, or is it the overall cycle time that's being talked about?
See, it is basically the soil linen collection by the linen department people across the hospital, which takes about 5 hours. So that has reduced to about 2.5 hours. So that's the savings of timing and utilization of the manpower that we have done.
Okay. And what was the total cost of implementation of this technology?
With the hardware, software, and the RFID tags, it was about 21 lakhs.
Okay.
Very good presentation, Arindam. How has it improved the operational efficiency? You mentioned in the benefits. So,
see, sir, for these particular collections of the soil linen, we have got 5 people to do initially. Now we've reduced it to 2. So because of the manpower counting across the facility, it is now done through that particular readers. So they don't have to count. So whenever they put it into the gunny bags, it passes to the RFID gate and gets automatically calculated.
Okay, good.
Thank you.
Thank you. We now move on to the next category, which is on hospital innovations. Would like to invite Mr. Balaji SV from Kaveri Hospital, Chennai. The title of the project is Project Real List, Digitization of Checklist, QR code based digital checklist to stay up to date. Over to you.
Thank you. Honored to be here. I would like to thank Caho organizers for presenting us with this opportunity. I would be presenting Realist, which is a mobile app enabled QR code based digital solution. When I talk about checklist, I can't stop myself from quoting Dr. Atul Gawande, the famous author of the book Checklist Manifesto. In that book, he prescribes checklist as a solution to prevent human errors in hospitals. The current pen and paper methodology, the traditional checklists that we use in hospitals, do not give the intelligence or organizational wide view of what is happening in a hospital. And it's prone to errors, and it is reduced to a mere tick list during audits. Those are the pain points that we face by using a paper-based checklist. What we have done at Kaveri Hospital is we've taken paper-based checklist and digitally transformed it into a mobile phone app-based QR code-enabled digital solution. What you can see here is an oxygen cylinder checklist before digital transformation and after digital transformation. Before transformation, you can see the checklist hanging by a thread from the trolley, where the nurse completes the checklist during her shift. And post-digitalization, you can see a QR code replacing the paper checklist, and the nurse would scan the QR code and the checklist will render digitally. It's been a 1.5-year journey for us post-pilot. We have digitized 50 checklists and deployed 850 QR codes, both clinically and non-clinical areas. If you walk into Kaveri Hospital, you will find QR codes from operation theaters. We have digitized WHO's surgical safety checklist to the ubiquitous washroom cleaning checklist used by housekeeping department. This is another image of before and after digital transformation of washroom cleaning checklist. What I will do now is I'll play you a video demonstration of a nurse completing the checklist. And on the technology front, in the past 1.5 years, we have actually released a second version of the app with better features also. This is the app that you see on the screen, which provides real-time intelligence of what is happening in your hospital. This is a demonstration of a nurse completing oxygen cylinder checklist. You can see the nurse scanning the QR code. The checklist renders digitally in the mobile phone app. The nurse completes the checklist. She takes a photograph of the flow meter as an evidence. She attests a signature and submits it instead of using a paper. And once submitted, the line manager sitting at the desk using the same mobile phone app can monitor the real-time status of all the checklists that are present inside the hospital. The completion status is quantified in the form of a percentage, and the line managers can drill down further to see where the checklists are pending for execution, and also can see the completed checklists. Line manager would be the nursing superintendent, medical administrators, functional heads, and of course the quality head. So the line manager can drill down to the spot to see for which spot the checklist was not executed, and they can also drill down to see the completed checklist. And this is the checklist that the nurse had completed in the demonstration video. And apart from that, you have access to detailed analytics and reports through the web portal. Again, the 9 line managers have access to this. You have colorful dashboards, which gives you real-time insights. and you have a huge repository, goldmine of data available to you in this web portal. You can again see the completed checklist. And you have further 20 plus customized reports. The tangible impacts of benefits of digital transformation of paper-based checklist into a mobile phone app-based checklist is before digitalization, we had 15 checklists being used. It has now improved to 50 plus and still growing. And we have deployed 800 plus QR codes. And the complaint reduction, both internal and from the patients from where we have deployed the QR codes, had come down from 80 to 35%. And the cycle time reduction of completing a checklist has reduced from 8 minutes to 3 minutes before and post digitalization. And total man-hour reduction per day in using all the checklists have reduced from 110 hours to 27 hours. The last but not the least, the cost saving from preventing printing costs was 3.87 lakhs. And the most important benefit that I would flag here is the intangible benefit that checklist has regained its lost glory at Kaveri Hospital from being a mere tick list. Another thing is, for us, it is a huge cultural change where all category of staff, from doctors in operation theaters to janitors, they know that there is a QR code they have to scan and submit, and the report goes to the line managers. Thank you, ladies and gentlemen.
Thank you. Is it also applied in, let's say, clinical activities like surgical safety checklists and even some
Yes,
of the
sir.
handover checklists?
Yes, sir. 15 departments use it, including maintenance. Maintenance department is one of the robust users of the checklist. They have diesel generator checklist, extinguisher checklist, and all those things.
Okay. And while it's good to have alerts in case a checklist is incomplete, but does it also stop some transactions, say, in your information systems or in your EMR, etc.? It doesn't allow, some activity to take place because the checklist has not been, say, completed?
Sorry, sir, could you rephrase?
If a checklist is incomplete, does it stop some activity on the patient from happening, maybe on your information system or in the EMR, let's say data entry or something like that?
No, sir, at this point, we have not integrated this checklist to our EMR, no.
Okay.
All right.
Thank you.
Thank you.
Sorry.
Yeah, just one question. I'm sure you must have included all the important parameters in the checklist, the standard checklist. But suppose you find something which is not in the checklist. Do you have any provision to add that?
So what happens is we have an administration team, sir. We are the ones who curate the checklist. So the user, let's say, I'm going back to, say, a housekeeping department. Right now, they came up with a requirement, they need a room-ready checklist. So they give us a list of parameters to be curated. We would set up in the backend, we would give the user training, install the app, and they would start using. So the list of parameters are given by the users. And if you look at NABA checklist, it's given by the quality department, sir. So subject matter experts contribute the parameters to us.
That's fine, but can you add anything if something glaring you find with?
Definitely, sir.
Okay.
It can be done. It's in editable format at the back end. We can add, we can do all those things. Usually what happens during pilot process, whenever a department HOD says, I need a new checklist, we give them as pilot for 3 days, and during that process itself, they'll add certain checkpoints, remove based on how it pans out on the ground. So we can add the checkpoints. Right?
Thank you. Thank you so much. The next presentation is on innovation of NIV mask with inbuilt feeding tube for patients on prolonged ventilation. This is from the Department of Anesthesiology and Critical Care, AFMC, Pune. Request Colonel Dr. Shamik Paul to come and take the stage, please.
Good afternoon, everyone. Thanks, Kaho, for giving me the opportunity to come and speak here in front of this August gathering. Very overwhelming to see eclectic minds sitting all together. A warm welcome from the Armed Forces Medical College, Pune. I'll be talking about the use of a feeding port in a non-invasive mask. Now, how did the idea come? So I'll be very frank. The COVID hit us And I was in charge of the ICU of one of the biggest hospitals in Delhi. We flew in from AFMC, and we were managing all the waves in Delhi. So here is what the data shows from the last wave in which we lost many patients. So we do have the red line showing bar diagram showing patients who are on invasive ventilation, the blue on patients who are on non-invasive ventilations, and of course the gray is the total. It was seen that the ratio of invasive and non-invasive ventilation patients remained almost constant because most of our patients on invasive ventilation were dying. And there was a lot of conversion from non-invasive to invasive ventilation. The rate was around 60 to 70%. So we made a matrix. So this was in the COVID ICU with a mobile that has got probably a transparent cellophane sheath, and we used to do this in every shift, that is 4 times a day. So if you can appreciate, there are 3 lines, the yellow, orange, and red line. The yellow is basically the patients who are on NRBM, high flow oxygen, the orange on non-invasive, and the red on invasive. We were trying to prevent patients going to the red line. And the basic data we are getting is like, for patients on NRBM, it is the respiratory rate divided by the denominator was the bed number. Similarly, on non-invasive, it was the percentage saturation, then the respiratory rate, and the bed number. And similarly, invasive ventilation, it was the percentage saturation only. So we are making it very minimalistic so that we can intervene in the right moment and prevent the patient going to red by early intervention by giving a good amount of care between NRBM and NIV. So this is the data, very, very disturbing because we are getting severe COVID patients and we lost 48.1% of our patients. The death toll was 810 in just 40 days of our hospital in the last wave. So why were our patients going into invasive ventilation and further dying? Why was non-invasive ventilation not effective? And it was due to nutrition or the lack of it. So because the patient was on ventilation, NIV ventilation for a long time, giving them nutritional breaks is to desaturate them, and the athleticism is to set in so fast that it was very difficult for them to come back and oxygenation to improve. So by the nature of it, patients were kept on NIV for hours together, days together, and only nutrition was an IV fluid running. There was no parenteral nutrition available because of the cost factor. So malnourished patients who were having a high cytokine drive, hypermetabolic state, used to get tired, and they used to get hypercarbic, they used to get disoriented. The ventilation is to go to the stomach, then the lungs, they used to vomit, aspirate, and they used to shift into invasive ventilation in an emergency way, and no way we could salvage them out because the lungs were already sick, and we are already having patients who were getting aspirated. So the existing solution was basically putting a Ryle's tube, and the Ryle's tube used to come out from the side of the NIV mask. So this Ryle's tube thing was very good. We used to give, but the problem is that there's a significant amount of leak, a lot of aerosol generation, poor ventilation. The Ryle's tube used to irritate the patient's skin, causing maceration of the skin, and the mask used to shift to refix the mask again and again. Very difficult for the nursing staff to do it. So there was this renowned company, this is available commercially, where the Ryle's tube comes out from the margin of the mask with a small hiatus that is present that allows feeding during ventilation, but this also had a problem and the cost was exorbitant. So what we did is we had a glandlet assembly system, initially made it 3D printed, put it on that mask and allowed the Ryle's tube to go through this conduit to the patients in the either nasal cavity or the oral cavity, mostly nasal, and give the patient nutrition. Early initiation of nutrition prevented a lot of patients from going from non-invasive to invasive ventilation because the calorie requirement was met. Moreover, the price was extremely cheap. This $600 to $700 includes the NIV mask also if we got in a large scale. So we did do a clinical trial. We filed Institutional Ethical Committee clearance from the Armed Forces Medical College, and we tested the mask as a pilot study on patients on chronic ventilation. First gave them the normal NIV mask, kept them for about 2 days, 36 hours to 48 hours. And then when we saw that the NIV mask is not fitting properly or the patient is not getting adequate nutrition, we shifted to the NIV mask feeding port and put the Ryle's tube through it. So here we are having this patient on who's an ARDS COVID patient, he's a COVID patient, and we were able to give adequate nutrition to the patient. We did file a provisional patent in collaboration with IIT Bombay for this particular device. So if you see this ventilator graph, it is clearly stated that the leak is minimal. There's a leak of only 63 ml of oxygen-air mixture, and in the second case, there was no leak at all. It was not only about COVID, it was about patients who are on long-term NIV. These patients, especially who had 60% of burns, was subjected to recurrent surgeries from hysterectomies and repeated 3 times she underwent surgery. And she was in a hypercatabolic state, running fever, and her lungs are packing up because of the initial extra load of fluids. While the burns management, the lungs are also filling up. So we did give her an IV, we gave her adequate nutrition, and she came out from the NIV mask and weaned off and was not shifted to invasive mechanical ventilation. So these are the first pilot study of 3 patients in which we see clearly that initially in the first column you see the leak was substantial, and the second column the leak was minimized. The third column was the nutrition which we were able to give normally. That was quite 650 to 800 kilocals, and the last was actually what we achieved after putting this mask and successfully weaned the patient off mechanical ventilation, that is NIV, and the patients were not shifted to invasive mechanical ventilation. So on conclusion, poor nutrition was the reason why, one of the prime reasons why patients were being shifted to mechanical ventilation, invasive mechanical ventilation, and longer stay in the hospital, and we had a very, very poor prognosis as far as COVID was concerned. It had high morbidity and mortality. With this mask, it was not only reproducible, cheap, economical, but it could have been used in all levels of care, from primary to tertiary. And it is, the requirement of invasive ventilation is very less. It was proved beyond doubt the addition of this nut assembly actually helped the patient come out of this poor ventilatory condition and was extremely effective. With this, I come to the end of my presentation. This is our team, and thank you and Jai Hind.
Thank you, Dr. Paul. I think we all witnessed the pandemic and the crisis that was there, both in terms of resources, physical, as well as particularly oxygen scarcity, etc.
Sure.
And the applicability, the universality, and the reproducibility of the innovation speaks a lot about what has been done. Thank you.
Thank you so much, sir.
Would like to invite the next presenter, Optimizing Medical Inventory Management, a data-driven approach with advanced machine learning techniques. This is from Dr. Rela Institute and Medical Center at Chennai. Would invite Mr. Bharani Kumar Depuru to come and take the stage, please.
Good afternoon, everyone. My name is Bharani Kumar, and I'm an IIT grad. I'm a computer science engineer. That probably gives me a unique edge over the doctors seated here. And that edge is that I can just walk up to any doctor and say, "Hello, doctor," and I can start off a conversation. But for you all, on the contrary, you need to remember the names of the other people. Okay, so this is one of the solutions that we have built using advanced machine learning algorithm. And since I'm also from Indian School of Business, I blowed a lot of business into this. When a patient goes to a pharmacy and asks for medicines, in a few occasions, what happens is pharmacists will say, "We don't have this medicine," or they might say that we have a different brand. In either cases, patient would be dissatisfied. They don't have the intelligence to look at the composition of the drug and then take another brand. Right? So this causes a lot of dissatisfaction in terms of patient. And to counter this, to minimize this scenario which is called as bounce rate, you can stock a lot of drugs. in your inventory, but that would just increase the inventory cost. Point number one. If you understock, patients are unhappy. If you overstock, hospitals would be unhappy because you'll be losing a lot of money there. So what we have done is, we have built a model by picking up close to 5 million transactions, and then we have used a lot of advanced algorithms, such as deep learning models. And then we have deployed a solution which is integrated with the hospital information system of Rela Hospital. And this would, I mean, these are the various accuracy values, etc. We had a challenge wherein there were a lot of specialities. Right? There were drugs again classified as desired, vital, critical, whatnot. And then we had to figure out on how do you shortlist the important drugs. We cannot obviously focus for each and every drug. So we have looked at the cost of procuring that drug. We have looked at the quantity that gets sold. And these are from the patient standpoint. What from the hospital standpoint? So we have also considered profits. How profitable a specific drug is, and then we have shortlisted the top drugs, and then we have built this model. And these are a few values, And to back this, since I'm from computer science background, I don't have any know-how about pharmacy, etc. Throughout this, the doctors and pharmacists from Rela Hospital were backing us. They were giving us the desired domain knowledge needed. At the end of the day, this AI solution is a culmination of not just AI, but also the domain expertise of the doctors. And this is the solution that we have built, and it has brought down the bounce rate to, by 90%. The improvement was about 90%, and it has obviously saved a lot of money as well. So that's in short about the solution that we have built. And it is also available on the public forum now, so people can use it. The solution and the approach, everything, we have published it on one of the research articles. Thank you all.
Thank you. Has it also had a positive impact on the stockout rates for the hospital?
Yeah, absolutely. We had those benefits as well, and there was a cost-benefit value also associated, but I was asked to refrain from using that here.
Okay. And you would have done a disaggregation based on different specialties or class of drug like OTC and others.
Absolutely.
So any insights on that, or this is across the board that you have been able to see the benefits?
No, this is across the board. Okay. But we have actually categorized in that way, based on specialties.
Okay. Right.
Thank you.
Thank you. Sir has a question.
Have you categorized the emergency drugs separately? Stockouts of emergency drugs?
Yeah, we have looked at something called as base value, base point, stock point. If a drug falls below that, that means it's a risk, basically for the hospitals, right? So those drugs, we have segmented them separately, and we have implemented, there is something called as confidence interval, right? And we told that as opposed to taking the forecasted value, take the upper limit of that. That's 5% above that. That is how we are countering the emergency drug scenario. Okay. Thank you.
Thank you.
Thank you. We now move on to the last category of awards. These are shortlisted for the Special Jury Award. Would like to invite Dr. Manish Arora from the Indian Institute of Science, Bangalore, and St. John's National Academy of Health Sciences. He'll be presenting Secure Ultrasound, a local scanning remote screening solution for antenatal care. Over to you, Dr. Manish.
Thank you, Chairman. Good afternoon, everyone. My name is Manish Arora, and my colleague, collaborator Dr. Dinakaran is also in the audience. I'll be talking to you about Secure Ultrasound, a collaborative developed innovation at IISc and St. John's National Academy of Health Sciences. All of us know the problem of ultrasound access. There are two problems actually. One is the problem which is related to social cause, which is it's being misused, and that's why there is a lot of regulation and control on how ultrasound is used in remote areas and even in bigger hospitals. That has led to PCPNDT Act and all kind of controls. The other problem is also of access, because we don't have trained doctors available in remote areas who can do ultrasound properly in this area. And that leads to a lot of problems in terms of us not being able to improve our health indices, particularly maternal mortality rates. So we have worked on a solution which is a low-cost, secure, point-of-care ultrasound solution, which is meant for limitedly trained professionals, technicians, who can collect the data, but the analysis happens at a remote site. Of course, the solution is depicted here, where the data collection happens at one location. It's sent to the cloud in a 3D data format, which is unlike other ultrasound imaging systems, and that's analyzed and sent back as a report. Of course, you will worry how to take care of the PCP Act. We have, of course, we need to consider that, and we need to talk to government officials about it, how to get this regulated. But we have been in some talks and looking at how the pilots can be done. The secure ultrasound system collects the data and sends it to a radiologist, and it sends back only a report of the desired or the assessed outcomes. Maybe some representative images, but not something which is disclosing the gender. And of course, it's to be hosted on a cloud. We have not implemented that part yet, but there is a possibility of even sending the data as anonymized data to the other site. This is a system demonstration in the hospital setting, the data being acquired. The user of the system does not actually see anything on the screen, as in there are no ultrasound images to be seen on the screen. It's protocol driven, but the system also warns the users if they're going out of the usable range of the system. So it has sensors built in, additional sensors, which guide the user of not exceeding those limits so that the data quality is assured. There's an assessment of quality also done at the time of acquisition, so that if a repeat scan is required, the system collects that or asks the user, the technician, to collect that at the same point of time. It acquires volumes, so that when the data is reaching the radiologist or the assessment site, the particular planes of interest can be taken out. From those planes, we can take out the clinically relevant information, and the volume can be analyzed. Of course, radiology, the ultrasonography right now is based on 2D images, so 2D images are of course available, but we also have a volume from which analysis can be done. And found good agreement with the clinical outcomes which are reported with a standard machine, a gold standard machine done at the site versus analysis being done at the remote site. We've done limited studies right now, only 21 patients, but we have ethical approval for doing over 150 plus subjects in this study. So essentially, our system is aimed to reduce maternal mortality. I'm sure all of us are working towards getting better standards, and also addressing the social evil, which is kind of preventing usage of this important technology being available in remote parts, as well as its usage properly. We have made plans to extend this across multiple centers. Therefore, we need your collaboration. We're looking for centers who can help us scale this. And also, of course, funding to develop this further as a proper product to take it forward, and also connect with PCP and government authorities to make sure the regulation for this is properly in place, including appropriate pathways for PCP to be applied to this. I thank you for your attention. This is our team, which is multifaceted, including designers, technologists, radiologists, and of course, people with senior experience. At the end, I would say that this novel displaced technology should be suitable for antenatal screening, and hope we can make an impact in saving lives which matter. We thank support from EPSRC, which supported this project in the past, and we look forward to further support from you, all of you as well. Thank you.
Thank you, Dr. Manish. I think very interesting, but a couple of questions. One is that ultrasound still continues to be very subjective, because there's a person holding a probe, and you actually see what the person wishes you to see, unlike most of the other 3D imaging. So how does that part get addressed? How does the subjectivity part, get removed from this?
So that is true of many radiology technologies. In ultrasound also that is true. Since we have the data available now in a 3D format, you can actually reassess it, and you can take the annotations on that itself to get it assessed by more than one person. And since the data is available as a volumetric data set, we have not implemented it yet, but there is also potential of using AI-based tools to get the right scan planes through a computer-generated algorithm to get some more objectivity in the assessment process itself.
Right, thanks. And last question probably, that because health is a state subject, so where the scan is actually being done and where it's being interpreted, So how does that part get managed? Have you had any?
We have had discussions at the Karnataka state level, the NHM there and the local municipality which manages some of the clinical care settings. But of course, this could be used nationally as well, so therefore maybe some intervention from the government side would also be required to enable that.
Okay. Thank you. Right. Thank you. Thank you so much. I would like to now invite Professor Upendra Kaul. Sir is from Batra Hospital and Medical Research Center, New Delhi, well-known clinician cardiologist. His topic is Earth Movers distance-based tool for rapid screening of cervical cancer using cervigrams. Over to you, Dr. Kaul, sir.
Thank you very much, and I'm very grateful to Cahotech to bring me here. And you might be wondering what is a cardiologist doing here to, screen the cervix. Our basic idea is that, this simple algorithm from artificial intelligence has to, be disseminated to all the physicians and healthcare workers, especially those who are working in the periphery. Because as you know, cervical cancer is a major problem and it's a big killer. About 67,000 deaths happen because of cervical cancer in India, and this is just a very conservative figure. Such figures are not easy to obtain. And despite having, a vaccine available, which has a very low use, lack of education, facilities for early diagnosis, because unless you diagnose it very early, it goes on and then gets into a major problem, and there is a social stigma, and very often we see very late presentations, fungating masses and other things. So challenges in the diagnosis, especially in the periphery, in the smaller parts of this huge country, is number one, actually you need a pap smear, you need a good colposcope, and you need a pathologist, which is available in the major metropolitan cities or even towns. But if you go to far off areas, it's easily not available. So the idea was, can we somehow get in artificial intelligence into a colposcope, and so that anybody who uses a colposcope with a good imaging facility gets something out of it, and you can screen normal from abnormal. So what we did, we had this idea in mind, and this concept I had already tested in ECGs, normal versus abnormal and the degree of abnormality. So we thought, why not bring this concept of earth mover distance, which I'll just tell you what it is. We had a target population, we had some inclusion criteria, and we also had some exclusion criteria, like pregnant women and women who had had hysterectomy and other things. And what we did, we had a software platform for the development and validation of the colposcopic images, high-grade images, and we did it in Batra Hospital and also Delhi State Cancer Institute. And I'm speaking on behalf of the whole department, Dr. Shaili Batra, who is the gynecologist, and Dr. Kumar Drone, who is the artificial intelligence man. Both of them are sitting in the audience. We collected the data, and the cervicograms, high-quality cervicograms were obtained from an Israeli company-made digital colposcope, whom they had sent it for an evaluation to us also. And then we had the clinical data and the epidemiological data. So what basically it is doing, you obtain the image of the cervicogram, remove the noise, make it, noise-free, better image, and crop the distance so that you get the area of interest, and then put it on the EMD. EMD is what? It is earth mover distance is a concept which measures similarities and dissimilarities. Similarities go on one side and dissimilarities go on the other side. If it is similar and more like normal, and dissimilarities, more abnormalities go towards the right side. I'll show you that. And this is something like, normal colposcopic cervix on the left side, and this is color-coded to give it, better picture in green, and you see these yellow markings, which are some, abrasions or some artifacts. And on the right, you see an abnormal cervix, and this is made into this picture. And finally, what it does by the method of EMD, that is Earth Mover Distance, you calculate the numbers. The numbers which are similar, you will get 0 to 26.7, you find on the left side those green dots. And as you go towards the abnormal, it goes towards the right, different shades, and finally into different shades of red. And the maximum red is, very abnormal. Suspected cancer, precancerous, cervicitis. So basic idea is to differentiate between the two. So what you have to do is to impregnate this software, which we already have a copyright for this, into the colposcope. So as soon as the image comes, it gives you the numbers. If it is number 2, 3, 4 or something normal, you know it is normal, you don't need to have much. Wherever it's abnormal, you pass it on to a higher center. So we also cross-check this EMT data and its reproducibility with colposcopic findings. Where we found it's abnormal, we again went to the gynecologist and found out. And basically what we did to make this what we call as the oncometer, we had the data from one of the repositories. And we first did our experiment there. Once we found it's very good, then we went on to these 396 persons, out of which 100 were normal. If we go on into larger and larger numbers, the sensitivity and specificity, I'm sure, is going to be very good, because when we checked it on the, the images obtained from, large numbers, it was working very well. So basically, we feel this is very scalable. It can start from the primary health center. Healthcare workers could be given these colposcopes with good image, and on which this is impregnated, and the numbers come there. The numbers which are very, 1 to 10 or 15, we know it is not abnormal. And when the numbers which are coming on the higher range, they go to contact-led tracing. It can go to primary health center, it can go to the cloud computational platform, and then passed on to a center in a metropolitan hospital or in a district hospital. That is a service layer. And what we found that it's this concept, we were able to get early detection and improved outcomes, quality improvement, targeted interventions, so that a large number of population can be screened by this. And we have been doing it, and I have been taking, along with my colleagues, into various parts. We've gone to Kashmir, from where I come, and you see we've gone to areas which get totally snowbound for 4 to 5 months in those areas, and you just have to provide this. And then you can see on the right, we went to one of the camps, which was a free health camp for cervical cancer screening. And on the right, you can see Dr. Kumar, Drone, Priyadarshini, and Priyaranjan, who are the architects for this. So our whole idea is to have a colposcope indigenously made with a very good imaging, say 100 megapixels, incorporate this, and this can be incorporated through a mobile phone, through a laptop, into the colposcopic image. And from that, you can screen it on a very wide population, because this is needed to be disseminated and go to a very wide population, so that you can detect normal, you can detect abnormal, and high degrees of abnormalities can be referred. Thank you very much.
Thank you very much, sir. And I think in the interest of time, we will not go with any questions. I think the slide deck itself showed the promise that this holds, and the widespread nature that it can be used to prevent cervical cancers and detect early. Thank you so much, sir. Thank you to all the presenters, and wishing them good luck for the awards. And thank you, Dr. Khetrapal, sir.
Thank you, Narayan sir and Khetrapal sir.
Very good afternoon again, once again, an evening. We have been listening to wonderful sessions throughout the day, and now we come to our last session, Harnessing Technology to Empower Vulnerables. I request Dr. Naveen Chitkara to moderate this session. Dr. Chitkara is Director and Consultant Neurosurgeon, NHS Hospital, Jalandhar. He was Director of 2 Petals Innovation, former Technical Committee member of NABH, was winner of Dr. D.L. Shah Award during 2014 and 2015, having 48 international and national publications and 8 innovations accepted in various journals. Dr. Naveen, you're requested to come on the dais, please. Let's welcome him. Yeah. And over to Dr. Naveen for calling upon the panelists. All right. Yeah. Mr. George Abraham. Our first panelist is Mr. George Abraham. Please come on the stage. Dr. Grish Srinivasan. Mr. M.A. Desai. Mr. Vivan Manohar. Ms. Nanki Lakhvinder Singh. Ms. Aishwarya Karnataki. Ms. Anjali Dada. And the last panelist, Professor Arun Khosla. We welcome you all on the dais, please.
Thanks. Probably, as you said, this is the last session, but I would say this is not the less important session. And it is as important as a hungry person who knows the importance of food. A person who is not healthy knows the importance of health. And a person who is running through bad luck knows the importance of good luck. So in this session, we are just talking about how technology can help the vulnerables and be a catalyst in changing the life of these people. So without wasting much time, I would invite Aishwarya. Aishwarya, please come here. Aishwarya Karnataki is, you can go to the dais, please. Is the co-founder of Glovatrix. She's a visionary committed to transforming the lives of deaf and speech impaired people. Her brainchild, Fifth Sense, is a wearable device that translates sign language into speech and text. She has won many prestigious awards. Actually, in this field of role of technology for the vulnerables, there is a huge amount of work which is being done. Large multinational companies, Apple, and all these people have developed so many things which help the vulnerables. But I could try and pick up some good, naive and innovative things out of all of these. And Aishwarya, please, you can present your.
So good evening.
We'll stick only to the solution.
So good evening, everyone. I am Aishwarya Karnataki, and I am the co-founder of Glovatrix. So we are here to empower the deaf and the speech impaired people who rely on sign language to communicate. Most people don't understand sign language, as a result of which sign language users are left out from the mainstream society. They are disconnected. So we live in a world where words build bridges and connect cultures and fuel innovations. But what if you couldn't hear those words at all? What if those bridges were never built? So that's where Glovatrix steps in to solve this pressing issue and build a bridge between sign language users and the mainstream society, and thus create an inclusive world. So I came across this problem back in 2008 when I was in 8th standard, when I met this 6-year-old deaf child named Atharva, who was standing on the outskirts of his own world. He used to play alone in school while his classmates chatted and laughed together, and it was not like he didn't want to make friends. It was just that nobody understood his language, the sign language. In classroom, he knew most of the answers, he knew them better than the most, but his voice remained unheard, his brilliance was unrecognized, and his confidence was eroded. So I started learning sign language to interact with him. And when he realized that I could not only understand him but also reply back in his language, he was so happy. He had tears of joy. And his reaction is etched in my memory forever, because it was in that moment when we were signing together that I realized that communication can transform lives. And since that day, I had a burning desire to help deaf people communicate. So when I investigated the problem further, I realized that, like Atharva, there are millions of deaf and speech impaired people who are left unheard because a majority of the people don't understand sign language. And this communication gap is just the tip of the iceberg, which leads to many underlying issues such as repressed emotions, insecurity, anxiety, and even depression, which lead to grave outcomes such as social isolation, improper education, discrimination at workplace, and inadequate access to healthcare and legal care. So in order to, so according to WHO, there are 466 million people in this world who are deaf, which is more than the total population of USA, Canada, Australia, New Zealand, and UK combined. And we aim to unleash the potential of these 466 million deaf people who are left out from the mainstream society through our device, the Fifth Sense. So introducing Fifth Sense, it is a wearable device that bridges the communication gap by translating sign language gestures to voice so that we can understand what deaf people want to say. It also has a microphone inbuilt in it which converts conversations to text and images so that deaf people can understand what we want to say. So Fifth Sense resembles a smartwatch with strings attached to the fingers. It has an inbuilt speaker, microphone, haptic motor, and screen. So the user wears the device on both hands and expresses himself or herself in sign language. The sensors map the movement of the fingers in 3D space and convert them to voice, which is transmitted through the speakers of the user's preferred output language. It also alerts the users of important background sounds such as baby crying, fire alarm, cooker whistle, so that the deaf user knows what's happening in its surroundings. So let me just show you a quick demonstration of how it works.
Hello, doctor. My name is Parikshit. I am deaf.
Hello, Mr. Parikshit. How may I help you today? So that's when the text appears on the screen and two-way communication is established.
I have back pain.
So Fifth Sense enables deaf people to have a private conversation with the doctor without an interpreter in the room. It will enable a speech impaired professional to give a lecture to a room full of people confidently. It will help a deaf job applicant nail the job interview without any communication barriers. So these are some of the transformative possibilities that Fifth Sense can have on the lives of deaf and speech impaired people. So in conclusion, Fifth Sense is not just about innovation, but it is about empowerment and embracing our responsibility to ensure that no one is left behind in this digital age. It is about transforming vulnerabilities to strength, one solution at a time, so that no Atharva has to face social isolation again. Thank you so much.
Thank you, Aishwarya. Next is Amey. Amey is founder and CEO of LifeSpark Technologies. He leads a young startup and he's working particularly in the field of prevention of risks of falls in Parkinson's and other neurodegenerative diseases. Yes, Amey.
Thank you. A very good evening, everyone. I'm Amey Desai and I'm part of LifeSpark Technologies. Now, while we work in the narrow niche of neurological diseases, today I just want to start on a slightly broader note and then show you what we've done in this field. 10% of the global population is over the age of 60. This means that 1 in 6 people that you see will be over that age, and all of the accompanying problems that come with that are something that our health system and all of us personally will have to face. This population will double by the year 2050. And the Indian elderly population in particular is rising by 41% over the next decade. Now, I don't see the number of doctors rising by that amount. So there is a current gap between the number of doctors and patients that need to be addressed, and that gap is only going to get larger. Now, one tends to see this as a liability, but I see that it can be an asset actually. The elderly add a lot of value to society beyond what economic value you can directly see, beyond tangible measures. And all we need to do is improve the health span and make sure that healthy aging is a priority in order to handle this and turn this into an asset. Specifically coming to falls. Now, it is one of the largest causes of disability, one of the reasons we are focusing on falls. And it's a major economic stress on low and middle income families. Even without injuries, the fear of falls leads to reduced caregiver productivity, increased costs. But I don't need to tell you all of these facts because I've dealt with it myself. My grandfather, who passed away a few years ago, was around in his 80s when he started to have reduced gait, imbalance. He had fallen once, gotten a hip fracture, and all of the issues with that. Now, both of my parents are medical doctors, but we still had a lot of trouble. Somebody had to stay home, family holidays were curtailed. So this sort of situation is what we want to solve. And in geriatrics in particular, the current model for healthcare, the current attitude is still acute. Right? It's an event-driven thing. Something happens, we go somewhere, get it solved, come back.
Sorry, Amey, can we rush to your solution first?
Yes, sir. Right. So if we come to a chronic way of looking at this, we see that AI and devices have a big role to play in this. They can save a lot of money and they can reduce a lot of issues that we face. Now, I'm going to quickly come to a solution that we've developed in Parkinson's disease and something that we see is scalable to a lot of other conditions. Here on the left, we see an individual with Parkinson's disease having familiar bradykinesia walking issues. I've sped this up a little bit, so you can see that 40-50 seconds later, he's just very started. This is the first session where we treat him with our device. It's a non-invasive wearable mobility aid for individuals with Parkinson's. On the right, after 13 sessions of therapy, he's a lot better. In fact, he's good enough to want to attempt squats by himself. Now, not only does diagnosis have to come to the patient, therapy also needs to travel to where the person is. And especially true in situations like these, where age is advanced and multiple morbidities can be seen. Thank you very much. Have a good evening.
Thanks, Amey. Actually, my father has Parkinson's. I used this device and my father worked very well. And Amey told me that it works in early detection of falls also.
Yes, sir.
Thank you, Amey. Next, I would invite Professor Khosla. He's head of the department at NIT Jalandhar and founder of Cairo Technologies, and he's got his work in autism. The first two presenters had their wearable devices. Now I'm talking about platforms. So talking about autism, the incidence is 1 in 40 in the world population. The screening of the patients with the autism, the early diagnosis, the detection of the challenges in the autistic children, and knowing the strengths in the autistic children is something which is at the moment very disorganized, and it's not an organized structure. So let's see what Professor Khosla has to tell to us.
Very, very good afternoon. Thanks for the opportunity, Dr. Chitkara. Let me give you a little background how I entered into this space accidentally. So about a couple of years back, I got an opportunity to visit an NGO which was taking care of autistic kids. And I looked at the manual interventions which are being carried out. So coming from a technical background and our understanding about technology, so we thought of let's try to do something so that these manual interventions which are being carried out locally at one place, so which are very tedious to handle, so can we make use of technology? So from that point onwards, even I was not aware about the autism. Then I went back, looked at the literature, see what others they are doing, and then we started working on this with the local NGO that is based in Jalandhar. These days, there's a adequate awareness about autism. Anyway, still, I just want to, many times we talk on different platforms, still many people, they are not aware of that. So it's a neurological disorder. There are certain impairments like difficulty with communication. There's a poor social interaction, repetitive behavior. And why it is called autism spectrum disorder? Because this is a spectrum. Every child is different. Every child has a different levels of impairment. So this is the prevalence of autism in India, this figure I have taken from a newspaper. We don't have a data. Literature says we don't have any details which have been documented. But if you look at in US, it's 1 in 48. In Canada, it's 1 in 66. And this prevalence is increasing. So largely, this increase in the prevalence can be attributed to the awareness which is there right now. So people, they are aware of autism. So one is the reason. So other factors are also being talked about, like, environment, but a lot of research is still required to be done before, those parameters, they can be considered, they're considered to be, evident parameters. This is the economic burden of autism.
Can we rush to the solution?
Yeah. So this is a very important thing because, the therapies which are available, they're pretty expensive. So based on our understanding about technologies, we are trying to make use of technology so that all requirements of autistic individuals, their families, they can be met. So one of the solutions we have tested, we have developed, it's an AI-driven solution. So it's a tool for autism and screening, and we have made use of hierarchical fuzzy system so that expert advice which is available, it can be translated in the form of ifs and rules, and this has been clinically tested also. Then we are making use of eye trackers. Eye trackers is a tool through which if you install, you have an eye tracker, so you can see where the individual who is using the screen, where he or she is focusing at. So these gaze patterns, they can be used for screening of autism as well. And we are trying to make it cost effective so that this webcam can be used as an eye tracker, so that these services, they can be replicated very quickly, because if you look at the eye tracker, this is pretty expensive. Then again, we have been making use of existing these gaming consoles like Kinect device for improving. So we have developed games, and those games, they have been tested with the autistic individuals. So how their cognitive skills, motor and sensory skills, and cognitive skills, they can be improved. So we have developed a couple of activities around that. Then some of the projects we have initiated. Currently, if we talk of where we are gathering data, we are seeing the progress of autistic individuals, how they're improving. Largely, the data is gathered in the clinical setup. So we are developing a solution so that these kids, they can be monitored around the clock, 24/7, so that this data can be gathered, and in case there is any meltdown or any sensory overload is there, it can be predicted beforehand, making use of AI and deep learning. Again, this is part of the similar solutions that we are developing. Then again, we are making use of virtual reality, not immersive largely, it's non-immersive. We are a lot of games we are developing to teach some vocational skills and cognitive skills to the individuals. So we have started this startup, this Cario, with a vision to develop evidence-based, innovative, creative, and affordable technological solution for autism, so as to augment, enhance, and extend the reach of existing autism services through technology. So thank you so much.
Thank you, Professor. I would want to add to that this solution particularly differentiates when we are screening the patients, making an early diagnosis, because this is a subgroup of the autistic children in whom, if we intervene early, the development or the progression of the disease can really be checked. Thank you, Professor. Wonderful job. Next, I would present Mr. Vivian Manohar. He is CEO and co-founder of Grail Innovations. And they have developed a very particular solution in the name of Vision Nanny. And it basically entails cortical vision blindness. The incidence is high, which is like 36 million in the world. In India alone, it is 4 million children who are suffering from this cortical vision blindness. And in these patients, there is no structural treatment which is available. It is just a form of rehab which is to be done. And this again is a disorganized and a non-organized sector. So Vivian, over to you. Thanks.
So thank you, Dr. Naveen, and very good evening on all. For a moment, just imagine, you just see this panel and the screen behind and these chandeliers like a Picasso's painting, or maybe Dali or Van Gogh. So how would it be? all the shapes and colors all mixed together, you won't understand anything. It's going to be completely chaotic, right? So if a child with CVI had come to Cahotech today, the child wouldn't be able to recognize his or her own mother in the crowd because of the complexity. Now, this visual complexity is just one aspect of CVI. Likewise, there are like more than 10 parameters. Now, do we have a solution for it? Yes. That's called early intervention. Just like you might know about the speech therapy or physiotherapy. Likewise, there is vision therapy to improve the vision. So since this is not an ocular problem again, it's a brain-based problem, the visual impairment which happens because of the brain, and therefore you can't solve it with the glasses and other regular procedures. The problem is we don't have enough special educators in the country, and the sessions are expensive. Just to give you an idea, the average salary I think in the country is like about 4 lakh rupees per year, and about 2 lakh you have to spend it for these kind of therapies, and this will be going on for years and years till the vision improves. So because of that, there are so many dropouts. Many parents, we have seen it in Hyderabad, our startup is based in Hyderabad. Many parents, they just come for the first assessment, and then afterwards they understand they have to sacrifice a lot of things, their wages and everything, so they don't come for follow-ups. So what we try to do, now this kind of therapy which is there in tier 1 cities, we are digitalizing it and presenting it as a SaaS platform called Vision Nanny. So it's a SaaS application, it's a web-based application, which means you can use it on your smart TVs, your laptops or tablets. All you need to do is to have a device which has a browser, and you need to have internet connection. In simple terms, we are building Netflix for vision therapy. So you subscribe to the platform, and there are like several categories of activities based on the age group or the phase of CVI. In simple terms, the severity of CVI, the activities are, see for example, this is a complexity activity. It's a very simple activity where the child is asked to identify where the rubber ducky is. Now this rubber ducky can be customized into any object of the child's favorite. It can be even a picture which a child is fond of. Another activity here, you can see there is a customization panel on the right side. Just with the click of a button, you can personalize the activities according to the child's need. Some child might react only to the red color, some to the yellow color. Just we heard about the autism, right? Each child is unique. Again, with the same case with CVI. If you have met one child with CVI, you have met only one child with CVI. For the other child, you have to customize the intervention. And it is very extremely difficult in the clinics because you have to have an arsenal of activities, the intervention materials to do this. But by making it digital, you can make it interactive, you can make it customizable and so on.
Vivian, and, I think I'll have to cut it short because we are running very bad on time.
Okay.
So
yeah, I understand. So this is the crux of it. We are building a Netflix for vision therapy, and we want to take it beyond CVI into the other areas as well. So if any of you are interested in learning more about it, I'll be available after the talk. Thank you so much.
Next on the line is Dr. Girish Srinivasan. He is co-founder and chief scientific officer, Behaviorance, with 20 plus years of experience in developing medical technology. He is working on role of technology in early detection of psychological changes in adults and the vulnerable. Over to Girish.
Thank you, Dr. Yes, before noting the behavior of what's going on here, I will be as fast as possible. So we're looking at a tool that is available and can be available in anybody's hands. It's basically a smartphone-based solutions. And I'll cut to the chase directly, where today we have biomarkers or elements that are easily able to identify many diseases like diabetes or other kinds of sort of diseases that's very well known. But psychological and mental illnesses are actually a challenge because I think there is no behavioral or biological marker today, and I think that's the biggest challenge in this. And no offense here to any psychologists or psychiatrists in the crowd here, but the reliability of being able to detect a psychological problem is less than 30%, which is actually
we would rather flip a coin and get a better chance in diagnosing this. And there is a lot of patient distrust, fuzzy constructs, and very significant challenges in false positives and stuff like that. Digital data today, as everybody knows, is quite prevalent. Something like a Facebook can actually predict what you're going to buy in the next few days, and Netflix knows what you may be watching based on content that is that you are digitally putting there. So why not use digital presence and the digital footprint that we all leave on the phones to basically analyze and assess behavior and psychological. This is exactly what Behaviorance and the team has created. So being able to use phone usage information to be able to assess what your mental health and psychological presence and state is probably is. So it uses non-invasive passive data to then assess it using machine learning and AI techniques to generate scores that are indicative of conditions such as depression, anxiety, stress, PTSD, and so on and so forth. It's 100% safe. There is absolutely no personal information that's being collected. It is HIPAA compliant. We've done some clinical studies on it, and it's available in the App Store or the Google Play Store for everybody to sort of look and download. We've built multiple models based on the data that's been collected and participants and patients that we have onboarded onto the platform: anxiety, depression, ADHD, stress, postpartum depression, and there's a bunch of lists that is still ongoing: opioid use disorder, autism spectrum disorder, burnouts, and further improving those things. There is a back-end platform that doctors can use to connect with their patients and continue to manage and monitor their scores so that you know what your patients are going through and accordingly schedule and sort of intervene as required there. So one quick sneak peek into not just the fact that there is a behavioral tool on your hand, but there is actual underlying clinical and neuropsychiatric circuitry mechanisms that underlie some of these conditions, and this is what some of the early pilots are showing. So what we've been able to do is combine this smartphone data with patients who actually then get scanned, both structural and functional scans, and collect this information together to understand the underlying neurobiological, behavioral, and circuitry behind it. So we have actually conducted an early clinical study. The protocol is basically to give these patients the Behaviorance tool, make them have this for about 30 days, and during the 30 days do a scan of like a structural and a functional. And these are early results which you're seeing where you can see that this patient actually scored a severe score on the PHQ-9, which is a standardized score for depression. His score has been tracking pretty high on not only on depression, but also on stress, anxiety, and other sort of factors. And we're looking at their corresponding volumetric data on the scan and some functional data on the MRIs, which actually show significant changes and deviations from normative profiles, which shows that your digital profile has a signature that actually can indicate certain underlying phenomena, and this will, if put together, actually can help the physicians and the clinicians to make a better judgment and better assessments. Thanks to Dr. Chitkara here for the collaboration that we've been doing with him at his hospitals for some of these data. The app is available, as I said. Scan this code. You would be able to sort of try this out as an initial. And for anybody as a clinical provider, there is this access the care.behaviorance.com platform. You would be able to try this backend site and connect your own patients to us, and hopefully it'll work out and we'll have a better mental health overall. Thank you, appreciate that.
Thank you, Girish. Girish traveled from US for this lecture, and he's lucky that he's been watched by his parents while he was delivering lecture. Thank you, Girish. And now we have Ms. Nanki Lakhvinder Singh. She's founder and CEO of ProTribe Senior Care Services, and she has a platform which enables and helps the elderly and the vulnerables.
Good afternoon, everybody. So we work in the subacute space, and I know we are very short on time, so I'm quickly going to talk about our platforms. We work in the subacute senior care space, to be very particular. I've been in the industry for about 4 years now, and we have come up with some very practical solutions on how we want to deal with senior citizens and the issues that we have. So we have actually developed two technologies. One is to accelerate quality, and the other is to enhance the customer experience. And I'm talking about both of these in the home care space for senior citizens. Can we move the slide, please? So you all know the senior care market is big, and I'm not going to get into it because we just spoke about it. We are going to be 20% of the population in India. I'm going to talk about the first product that we have, and can I go from here? Okay. The first one we have is something called the ProTribe Smart Care Booking Platform. This is basically home care services that you can call for on your smartphone. It can be as little as a GDA or a nursing assistant or a therapist. Whoever you want can come home. The data will be collected from you. Somebody will call you. And the most interesting part about this is we have three interfaces to this. The interface for the client, the interface for the administrator, and the third interface is for the actual human resource who's going to go out there and provide you the service. It's like an Uber aggregator platform. The service provider is registered by us already. They are registered by us. They have been certified, trained, police verified by us. The job will only be showcased to all service providers or human resources really within 5 kilometers of your home, and they will volunteer for the job, and we at the admin end will go ahead and say, okay, this person looks fit for this requirement and should go home and pick up this job. So that actually really helps us in maintaining quality in a big way, because there is very minimal commute and we have more control on what is happening in the house. The second aspect is, of course, the admin, and the third one is how you set up your, how you really ask for your services, which is right here for you to see. You can pay online, it's very easy. The only catch that we've put over here is that you have to make some advance payment, otherwise nobody pays. That's the reality of India, but anyway. This is the admin interface. Once we've allocated an attendant to you, you will get a profile, you will get all the verification, you will get the government ID, and all of that will come straight to you on your phone, so we are all secure there. The second platform that we have come up with is essentially for quality assurance. This is an association with a company called Doxy, a very young, brilliant doctor who is trying to digitize the Indian healthcare space. What we are doing here is we have digitized 10 basic forms in the home care space, starting from as little as your intake output form, your care plan, your total summary of what is required, your medication management, your handover form, your discharge form. Now, this tool basically captures your data on your handheld, and the most interesting part about this is that this can be done by a GDA who is barely 10th pass and doesn't know more than just about filling out the form in the format that we give him. The early adoption has been very high, and a GDA can fill up this form on a daily basis within 5 minutes, 5 to 6 minutes if they do it regularly. It helps us to track vitals, it helps us to track quality, it helps us to take care of all the accreditation requirements that we need for our accreditation certifications that we carry. And we also end up looking at a lot of data, which at a later date we will use to see what we can do with it for better services to senior citizens. And that's where we are with these two platforms. Thank you.
Thank you, wonderful. And after this technology, I have got two people to be presented. They are the champions who have championed the causes. First, I would present Ms. Anjali Dada. She's co-founder of Soch Autism Society, and she's an autism mom for last 12 years. And she, let her tell about herself.
Thank you so much for this opportunity to listen to all of you and share a bit about what I have been doing. So like Dr. Naveen Chitkara said, I'm an autism mother. And like Dr. Khosla had shared, initially my son was misdiagnosed. There was this huge debate about whether he had ADHD or autism. And because of that dilemma, I finally stepped into the field. But that is why it's so important that things like this are happening today, because I'm a mother who received a late diagnosis and then got very panicked as to what would happen to her child. Because Punjab has very small cities, and at that point when I started with my son, had absolutely no knowledge about autism. No autism specialty NGO existed there or an institute existed there. So because of that, we had to create our own. I trained myself as an educator and started the first NGO dedicated towards autism in the state of Punjab. We realized very soon that there was a lack of educators in the state as well. So we decided to do the best with whatever resource we had, and that was the mothers themselves. So we began to train mothers, and they happen to be our biggest asset at Soch today, because they work better than any educator. No offense to the educators out there. However, they took the lead, and at present we have trained more than 500 families. Thanks to COVID, I think I'm the only person who says that. We went global because a lot of NRI community have a language barrier in whatever place they may be. However, autism is prevalent there too. So we helped a lot of NRI families across the globe, from America, New Zealand, and there were families who reached out to us during the years of COVID, the pandemic, and they requested our help because they did not know what to do with the children who were sitting at home. That's when we went, where technology helped us. We took our trainings online. And might I say that we thought that would never happen. However, our online training showed faster results than the practical ones. So that was something we absolutely were amazed by ourselves. And like Aishwarya was talking about here, we noticed as we progressed with our children that there is still a big bit of exclusion for them. You know, we do want to be an inclusive society, but we are not so yet. So one of the biggest endeavors that we set forth on was building up the roles of those we serve. The most vulnerable are in the outer strata of society. Just like Atharva, as she had mentioned, very often nobody takes notice. So we started building a role building for them, in which the aim was deinstitutionalization. So now we wanted to step out of our autism specific institutes, move out into the community and work towards bringing our young people out there. One of the endeavors by Soch was, again, to help this effort that is called Soch Ke Rang, the first inclusive art show of our state. We have traveled and done 2 editions of that art show and going to have many more, where artists, neurodiverse and neurotypical, put up their art on the same platform, and then we put it out to people without mentioning who has autism and who is typical. So that is one of the platforms that has really been the first.
I take it from here. She's been humble enough to conclude. During COVID days itself, they touched around 600 plus families, not just in India, across the world. And she's one of the figures who is known in autism circle in Southeast Asia as a person who is doing something for autism. Thank you very much.
Thank you.
And lastly, Mr. George Abraham. He is CEO of SCORE Foundation. And Mr. George, over to you.
Hello, check. Good evening, ladies and gentlemen. Thank you for giving me this opportunity to come before you and speak. I've been very carefully listening to, keenly listening to the various presentations that were made by the panelists, and it's very fascinating to see how technology has come up with solutions. I've also been in this disability space for many years, and what I've realized is there is a lot of technology that keeps coming out, but there is a problem in sustaining those products. Some of those products are really fascinating when it's talked about, described, but the sustenance, there are nobody to market it, people don't come forward to market it because they feel that it is a market where people are not willing to invest. Buyers, especially in the disability space and the elderly, a lot of them would be well served by these products, but may not want to invest the kind of money that is required. So that is a major challenge. I would just like to very quickly tell you, since I say this with great conviction, technology has totally transformed the way I live my life. When I was growing up in the 60s and 70s, I was dependent on other people for gaining information, reading books, travel, following lectures in class, in college, in school, and mobility was a challenge. But in recent times, say the last 10 years or so, there are many technologies, but I'd just like to point out three key technologies which have actually been revolutionary in my life. One is the screen reading technology, which has given me great access on laptops and the cellular phone, the smartphones. The second advancement is, especially from 2014 onwards, when the government of India has committed itself to Digital India. That has opened up a whole lot of platforms for where technology has opened up doors for me to be financially independent in terms of my interaction with financial institutions, with the newspaper industry, with the sports industry, with various passions that I have, books, reading, all that has been very, very accessible. It all happens on my phone. So that is the second thing. And the third thing which I'd like to put up here is what they call the artificial intelligence. Everybody is talking about AI, and a lot of the products which have been discussed today are AI based. Now, artificial intelligence has created so many fascinating possibilities. I'm walking into a shop, I switch my phone on and I just flash it onto the shelf. The AI processes the picture and tells me what exactly is on the shelf. I'm sitting in a hall and I take a picture of the hall, and it kind of describes to me what's in the hall in terms of people. And also, if on my phone I have the pictures of the people, it will also tell me who the people are. So it's amazing what technology is likely to do. And I believe the 5.4 odd million blind people in this country, I think doors to education in the mainstream classroom will be opened up because of this digital technology, screen reading technology and artificial intelligence.
Thank you, Mr.
Employment.
George. Yeah, sorry. Thank you, Mr. George. I'm sorry I am interrupting you in interest of time. There's one missing link which actually would define what he said was he lost his vision at age of 11 due to meningitis.
10 months.
10 months?
Yeah, not 11, 11
Okay.
years.
Okay.
10 months, yeah.
And ever since he has used technology to his benefit to do all the works, most of the works independently just by use of technology. So now it seems all relevant what he was talking about.
If I might just give one sentence, with the total vision impairment, I organized the first ever World Cup of Cricket for the Blind in 1998.
Perfect.
So blindness need not be a hurdle or an excuse for not living life. Thank you.
And so what better note it could be to end this technology related event. Thank you very much. Thanks all of you.
Requesting all of those involved in the session to pose for the photo op. Thanks everyone for being patient with us and being part of the last concluding session of the conference. Thank you, everyone. Thanks, Dr. Chitkara. For the valedictory and awards ceremony, which is a concluding session for the conference, we invite and request the presence on the dais of Dr. Ash Mahajan, Organizing Chair, Cahotech 2023, Dr. Vijay Agarwal, sir, President CAO, Mr. Samir Mehta, Vice President CAO, Dr. Lalu Joseph, Secretary General CAO, Dr. Anuradha Pichumani, Chair, Quality Professional Wing, CAO, and Dr. Aparna Jairam, Secretary, Diagnostic Wing, CAO. Also, for the valedictory and award ceremony, we are honored to have Professor Govindan Rangaranjan as our chief guest. So it's a great privilege to have you on for the conference, sir. Professor Govindan Rangaranjan has been faculty member of the Department of Mathematics, Indian Institute of Science since 1992. He is currently the Director of Indian Institute of Science, Bangalore. He is a fellow of the Indian Academy of Sciences and the National Academy of Sciences, India. He was awarded a GSC Bose National Fellowship. He was also awarded the Knight of the Order of Academic Palms by the Government of France and the Distinguished Alumnus Award by BITS Pilani. He was also awarded the Omi Baba Fellow. I'll request our chief guest, Professor Govindan, sir, to possibly say a few words before we initiate our valedictory program, sir.
Thank you for inviting me to be part of this valedictory session. It's a pleasure to be here. First, let me congratulate Cahotech for organizing this pitch fest. I understand that this is the only pitch fest for healthcare startups. So this is something which is very critical for India because I think it's what is missing in India is to the level that we need is for scientists, technologists and healthcare professionals to come together and create new startups, new innovations. Probably the reason for that is that we have all these siloed institutions. We have excellent institutions, medical institutions, we have excellent technological institutions, but we don't have institutions which put all of these together. So that may be one reason why we are missing some of the key ingredients which make innovations in this space possible. But it's critical that we undertake these innovations given the scope of healthcare challenges that India faces and the world faces. Especially in India, I think it is maybe impossible for us to produce enough qualified doctors who can take care of the 1.4 billion plus population. So it's important that we leverage the technology to reach out to patients, especially those in the rural areas and those who cannot afford expensive medicines and expensive treatments. So in this context, it's very heartening to note that Cahotech has been doing this for several years and continues to do this. And I also would like to mention that IAC is also making a small, start in this regard by starting the medical school on our campus, where we try to bring science, engineering, and medicine together. And so it is therefore appropriate that the next Cahotech will be hosted by us in Bangalore. I look forward to welcoming you all there. Thank you very much. Yeah.
Thank you, sir. We'll move on to the award ceremony, sir. What I'll request is that possibly, should we come in front so that we can, yeah, and the awards would be handed out by Professor Govindan, sir. I'll be announcing the awards and the winners for the hospital innovations and early adoption of technology as the first go. The category is Special Jury Award goes to 3 participants. The first participant I'll be calling, please come on to stage so that we can do the ceremony quickly. The first Special Jury Award goes to Indian Institute of Science, Bangalore and St. John's National Academy of Health Science, Bangalore. It was for Secure Ultrasound, a local scanning remote screening solution for antenatal care. Dr. Manish Arora, sir. We'll have photographs being taken by a very professional photographer, so don't worry. The second award goes to Batra Hospital and Medical Research Center, New Delhi, for the Earth Movers Distance-based tool for rapid screening of cervical cancer using cervigrams. Oncometer. Professor Upendra Kaul, sir. The next award in this category goes to Apollo Specialty Hospitals, Jayanagar, Bengaluru. Enhance patient safety through contactless remote patient monitoring. Ms. Shija Joseph. I think they deserve warm round of applause, please. They have been working hard and through a rigorous round of selection they have been selected. Now moving on to next category of hospital innovation. I'll be starting from, these are the winners. I'll be starting from backwards to 4. The second runners-up is All Indians Institute of Medical Sciences, New Delhi, for Digital Library of Court Cases of Main Hospital, AIIMS, New Delhi. Dr. Jitendra Sodhi. This is for second runners-up in this category. First runners-up, Baby Memorial Hospital, Kozhikode, for Nightingale AI-powered digital platform for nursing excellence. Dr. Bijoy Johnson. Gracie ma'am is around. Oh, we'll move on to next. First, we have first runner-up in this category, Dr. Rela Institute and Medical Center, Chennai. Optimizing medical inventory management, a data-driven approach with advanced machine learning techniques. Mr. Bharani Kumar Depururu. We have 2 winners in this category. I'll be announcing not in particular order, but whatever is been provided to me. AFMC, Department of Anesthesiology and Critical Care, Pune. The innovation of NIV mask with inbuilt feeding tube for patient on prolonged ventilation. Colonel Dr. Shamik Kumar Paul. Come on, they are the winners. The next winner in this category is Kaveri Hospital, Alwarpet, Chennai. Project List, Real List, digitization of checklist, QR code-based digital checklist to stay up to date. Mr. Balaji SV. Well done, both the winners. And congratulations to all the winners as well as participants. Moving on to the next category, early adoption of technology. Second, we have two second runners-up. The first second runners-up is AIG Hospitals Hyderabad for chlorine dioxide water disinfection system. Lieutenant Colonel P. Ashok Kumar Reddy. The next second runner-up in this category is Mar Sliva Medicity Pallai for virtual assistance to remote hospitals GEM of Idukki. Mr. Sriraj B. Since they are not there, we'll move on to, we have two first runners-up. The first one is Woodlands Multi-Speciality Hospital Limited, Kolkata, for the linen RFID, Mr. Arindam De Sarkar. The other first runners-up in this category is Max Super Specialty Hospital Vaishali for their Immovigil, a step towards safe blood transfusion to the bedside, Dr. Abhinav Verma. And the winner in this category of early adoption of technology is Christian Medical College Hospital, Vellore, for the automation in-house testing and calibration of biomedical equipment. Possibly the first in-house calibration being done by the biomedical department in hospital categories in the country. Ms. Jennifer Tamiz Priya. Thank you and congratulations to all the winners and the participants in the categories. Now we move on to the next award category, the Pitch Fest for Healthcare Startups. We had a vigorous and rigorous selection process for the Pitch Fest startups. I'll start with the Special Jury Award in the category of Innovation for Clinical Improvements. There are three Special Jury Awards. They come along with the cash prize of 50,000 prize money to each of the award. So Special Jury Award in the category of Innovation for Clinical Improvement is Artificial Learning Systems India Private Limited, Artilus, Mr. Girish Somanchi and Dr. Ramesh S. Way for the product of Artilus LCHP OCT with Artilus Dristi AI. Congratulations. The next Special Jury Award in the category of Innovation in Non-Clinical Area goes to NanoClean Global Private Limited. This is the product for the project CG Bird. May we invite Pratik Sharma, Amar Gupta, Ashish Bist and Gaurav Srivastav to come onto the stage. Okay, we'll move on to the next. Okay, yeah. Come. The third Special Jury Award in the category of Enabling Digital Transformation goes to Janitri Innovations, Ms. Priyanka Singh, for the Smart Fetal Monitor Keher DT. And the winner takes home, apart from the certification and the winner he takes home a cash prize of 1 lakh or prize money of 1 lakh. Category innovation in non-clinical area goes to Neo Motion Assistive Solutions Private Limited for the product NeoFly and NeoBolt. Mr. Ashish Mohan Sharma and Mr. Abhishek Kumar Singh. Congratulations to all the participants and the winners and the jury who selected them. From IIT Madras. Congratulations and well done. I'll be requesting President Kao, Dr. Vijay Agarwal sir, to present mementos to our big support for the event of the sponsors for the Cahotech 2023, sir. I'll be naming them. We'll call them one by one. The diamond sponsor was Dozy, whom we have already presented with the award. Gold sponsor, Will Grow Innovations. The silver sponsor, NHS Hospital. And the bronze sponsors, there's a list. Alden, Fujifilm, come sir, come onto the stage. There's a small way of appreciation from our end to you. Shanti Mukund Hospital. Thanks, sir. Thank you, sir. GE Healthcare. And finally, Medica Bazaar and United Imaging. Requesting Dr. Vijay Agarwal sir to also present Professor Govindan Rangarajan sir with a token of appreciation from the Cahotech 2023 organizing team as well as from the Caho family. And now I'll request so we need to announce the next Cahotech 2023
Okay, so
venue.
in fact, I have two announcements to make. And let me make the first announcement is that for all the people who were part of the Pitch Fest, Business World has agreed to put them onto a one-to-one kind of a showcase. They will be done on a video and podcast and will be done by Mr. Harvinder Narula. So thank you, Business World. And that will be extremely good. In fact, we'll try to take some of our previous ones also. So it will be like a continuous activity to engage with the startups. Thank you very much, Vardinder. And of course, we are indeed grateful to Professor Govind Rangarajan for accepting to be the host for the next Cahotech. And in fact, our second Cahotech was in Indian Institute of Science, but I think next year the Indian Institute of Science program will be something that will, every year our USP has been that our programs have to be better than whatever was in the last time. So I am sure that we will have a great program of Cahotech, and we also request Dr. Uma Nambiar to be the organizing secretary for that conference. So,
5 crores. Manish also.
okay.
Sponsorship. At least 5 crores next year.
Sure.
Run fast.
Yeah. Yeah.
Pardon? I don't think you were hearing yet.
So, thank you very much, ladies and gentlemen.
Yeah,
and
sir, just one, pardon me, we have missed out one of our brown sponsor, Elsevier. Please come on to stage.
Elsevier, yes. Yes, the color of bronze has to change by the time you come to Kolkata. Yeah, thank you, Hemaji, and yeah. Thank you. Thank you, sir.
I'll request Dr. Lalu Joseph, madam, to make the vote of thanks and conclude the session.
Thank you.
Good evening, and thank you so much. A lot of people to thank, so we made a small presentation so that we don't miss out on anyone. First of all, let me extend a heartfelt thanks to Dr. Harsh Mahajan for putting up this conference together. Great team effort, and real thanks to you and your entire team, sir, for the wonderful work that you have done. It's been a wonderful experience working with the entire team. So let's move on to some of our major, keep going. Yeah. The chief guest and the guest of honor, we had Dr. Jitendra Singh today and Dr. Girdhar Gyani. Big thanks to both of them. Ladies and gentlemen, let's give them a big round of applause for the time they spent with us. And we need to thank all our moderators, the speakers. We had wonderful speakers presenting to us, and the jury. For all the contests that you have witnessed, the hospital innovations, the pitch fest, we had several rounds and they spared their time, and I must really place on record our sincere appreciation to all the jury members from the industry who actively participated. Let's give them a big round of applause. Big thanks to all the jury members. So certainly I just cannot point out their names, several of them who sat for hours. And dear delegates, thank you so much. We had 400 participants who registered for this conference. Big thanks to our sponsors, Dozy, Wilgrow, NHS, Alden, Fujifilm, and all the technical partners who actively participated and made this event a grand success. So let's give them a big round of applause. And our dear media partners, healthcare, business world, dialogue, and our design partner, the circus. Lots to thank, and we really look forward to getting to Bengaluru next year, the Indian Institute of Science, and Dr. Uma, it's going to be a great experience, I'm sure, for all of us to be working with you. Big thanks to all of you. And our patrons, our governing committee, all the members of the governing committee of Caho, the entire Caho family, for taking the time and for being with us. And I must really place on record our appreciation and thanks to Dr. Yashpal Bhatia for taking the pitch fit so smoothly, and his Astron consultancy and the entire team. A big round of applause to all of them. for hosting this event and for making it a grand success. The event management team, ELCOT, for the support extended. Have I missed out anybody, Vijay sir? I'm coming. So dear friends, CAHO is an organization that started in 2013. We're all full-time people working in hospitals, and all of us really cannot spend that kind of time and energy. It is the CAHO secretariat that makes all this happen. So I think we should give them a big round of applause, Dr. Sakshi, Prakash, and the entire team at Vellore, about 9 of them there, for putting in continuous work and for making this event a grand success. Sakshi, Prakash, are you here? Sakshi, where is she? Thank you, dear team, and let's once again give them a big round of applause. Let's end this session with the CAHO anthem, and I would request the CAHO anthem to be played. So we start with the anthem and we end with the anthem, inviting all of you to become members of CAHO, participate in the events. It's a beautiful organization with a lot of passion. It's all about quality, patient safety, accreditation, and with technology as the enabler. Welcoming all of you to join this beautiful journey to make this country a beautiful place to live in. It's already a beautiful place, and it has a lot of things that we can contribute together. Thank you so much for being patient audience, and have a great evening and a wonderful time at Delhi. Thank you.
A new horizon of healthcare delivery and patient safety. We have a goal, a noble drive.
Hand in hand, step by step, we will thrive.
To march ahead together for a bright and shiny future with patient safety and quality healthcare. We are CAHO, your healthcare companion. Standing right by your side. Joining hands for